तक सर टाइम का सही इस्तेमाल करें हम लोग। आइए सर, चलो सर आइए। फोटोग्राफर आया गलती ना हुई हम थोड़ी बहुत उदास है हम लोग
Good morning, everyone. This is oral paper presentation. Because of only few participants who have submitted their full research paper, uh, there are three participants. Two are PG students, one is our faculty. So the prize will be distributed among two PG students. Evaluation will be done among two PG students. First, there will be first prize and there will be first runner up. So we will start from Dr. Tanya Roy, who is junior resident in Tata Main Hospital, Jamshedpur. The time allotted is 6 minutes and there is 2 minute time for discussion.
Good morning, everyone. Today I am going to present RCT study on non-invasive positive pressure ventilation versus nasal high-frequency oscillatory ventilation in preterm neonates of 34 weeks of gestation and less with hyaline membrane disease following surfactant administration via ensured technique. Now, as we all know, during transition from womb to the external world, out of the many challenges a newborn face is their respiratory difficulty. Now, as per the data, around respiratory distress affects around 7% of the newborns, especially preterm, who often require invasive mechanical ventilation. Although it is a life-saving intervention, but sometimes it has its own complications like various kind of lung injury, including and also bronchopulmonary dysplasia. Through non-invasive ventilation methods, although we can minimizes this risk, but our newer modalities like nasal high-frequency oscillatory ventilation have shown to improve the carbon dioxide removal and reduces the lung injury, showing promising result over the other current modalities of non-invasive ventilation. But the problem is all the data are mostly all the studies have been done outside India, so there is limited data available in Indian population. So in our study, our main research question was whether whether nasal HFOV was non-inferior than non-invasive positive pressure ventilation in preterm neonates with RDS for respiratory support following ensure technique of surfactant administration. Our primary objective was to assess the treatment failure, which was defined as the need for reintubation within the next 72 hours. And in the secondary objectives, we have taken certain parameters like respiratory acidosis, IVH of grade 2 or more, air leak, feed intolerance, NEC of grade stage 2 or more, shock, ROP, and also duration of ventilation and duration of hospital stay and mortality, which as a parameters, these are the parameters which also indicates the treatment failure indirectly. Now, we have included our inborn preterm units of 28 to 34 plus 6 weeks of gestation with RDS receiving surfactant via in-shore technique. And we have excluded the babies due to lack of informed consents or babies having major congenital anomalies, outborn units, units not extubated post-in-shore, and also UPGAR score of less than 7 at 1 minute of life. Now, after screening the newborns based on the eligibility criteria, newborns with the respiratory distress were shifted to an ICU and started on NIPPV as a primary mode of respiratory support who are having respiratory distress. Now, on NIPPV, if the FiO2 requirement was more than 0.3, to maintain the saturation target of 90 to 94%, the surfactant was given. And for our trial, all the babies were received surfactant via in-shore technique, that is intubation, surfactant administration followed by extubation. After extubation, the babies were randomly stratified into two groups. In the NIPPV group, the babies were set on the baseline settings, put on the NIPPV with the baseline settings of PWP of 5 cm of water, peak inspiratory pressure of 15 cm of water, and rate FiO2 of 21 to 30%. And in the next group, the nasal HFOV group, the frequency was set as 10 Hz with the amplitude of 20 cm of water and FiO2 of 21 to 30%. Now, based on their respiratory parameters and other lab values like ABG, and their settings were titrated. Now, when in the NHFOV group, when the MAP requirement was less than 6 cm of water with the FiO2 requirement of 25% or less, they were planned for weaning. And in the NIPPV group, when the babies require the peak inspiratory pressure of 12 cm of water or less, with the PWP of 4 cm of water or less, and FiO2 requirement of 25% or less, they were planned for weaning. Now, in both the groups, babies were weaned to the heated, humidified high flow nasal cannula with 21% FiO2. Now, the babies who shows the features of respiratory acidosis, hypoxemia, recurrent apnea, pulmonary hemorrhage, pneumothorax, respiratory deterioration, or shock were considered to be of treatment failure, and they were reintubated and put on invasive mechanical ventilation. Now, while we analyze our study results, our primary outcome, which was the frequency of reintubation within the next 72 hours, it shows a statistical significant p-value of 0.044. So there was less need for reintubation in the nasal HFOV group. And among the various parameters of our secondary outcomes, the three parameters show statistically significant results. Those were like mean PaCO2 value, ventilation duration, and also the hospitalization duration. They show a statistically significant value. So these are few studies before our study, like they also shows the similar kind of results, but there was no statistically significant results shown between the nasal HFOV and the NIPPV. But yes, there are certain limitations in our study, that it was a single center designed with a very small sample size and shorter follow-up was done. So larger multi-center trials with a longer follow-up duration are needed to assess the long-term outcome of this intervention and also its impact on neurodevelopment in the newborn. So to conclude, both NHFOV and NIPPV have a good safety profile, but nasal HFOV has shown advantages over the NIPPV in mainly three parameters, that is the lower intubation rate, shorter duration of ventilation, and shorter hospitalization duration. So yes, further studies are needed, larger studies are needed to explore the beneficial effects of nasal HFOV over the current modalities of non-invasive ventilation. Thank you. Yes, sir. Yes, sir. Thanks. Yes, sir.
Hello.
The one question is how you have not mentioned about these randomization. How you assign these subject recruitment to the NIV or NHFO, right?
Okay.
So and the second question is how do you calculated the sample size? That especially you are saying when the Indian literature is not available.
Yes,
So
sir.
how do you calculated the sample size and what is the process of randomization?
Sir, we have stratified based on the mainly the gestational ages and also random stratification was done and also for the sample size yes though there was one study in SSKM. Hello sir. Sir actually sir there was like we have like certain gestation based on gestational age we have stratified like our age group was in 28 to 34 plus 6, so in both we have made like in both in certain gestational age we have divided the babies in two groups and for sample calculations sir, there was one study in SSKM hospital. Sorry sir. Yes sir. Okay, sir. Okay, sir. Sir, it was double blinded. Like, okay, sir. It was. Sir, actually, I couldn't get that. Okay, sir. Okay, so stratified. Yes, sir. So stratified, we have like based on gestational age and yes, sir. Okay, sir. Sorry, sir. So there was one study in the SSKM hospital that at that and there with 86 newborns of with gestational ages of 26 to 36 weeks, and they have shown the similar kind of result also. So we from there we have extrapolated. Okay, sir. Okay, sir. Okay, sir. Sir, 44. We have taken 44. Okay. Yes, sir. Okay, sir. Yes, sir. Okay, sir.
But 44 is the total or the two arms together?
Yes, sir. Sorry.
44 is the total or
Total.
each
No,
arm has
no, no,
44?
sir. 44 total.
Total. That
Total.
means 20 to 22.
Yes,
there
sir.
should be 2 arms.
Yes, sir. Two
okay.
arms.
So like if you have
44, 44.
taken from a previous study, or are you doing as a pilot study?
This one is like a pilot study.
Okay.
Yes, sir.
That is, if you are quoting from another study,
No.
and you have to apply a formula. You have to get the
Yes,
power
sir.
of this study.
Oh, yes, sir.
So how much level like you expect?
Yes, sir.
Because yours is a non-inferiority trial, right?
Yes, sir.
Yeah. So the
Okay.
proper
So-
sample size calculus should have been there.
Okay, so actually not very much available data was there, so we have taken this a short. Okay, sir. 86, yes, sir. But there the RDS and post-ensure babies were not specified. There was only preterm babies who required invasive ventilation. Then the next following weaning or following extubation, they were divided into two groups. That was the study though, not specific to RDS with a surfactant. This study was not there.
I have a question only. So, in your analysis,
Yes, sir.
so was it an intention to treat analysis or per protocol analysis?
No, sir, it was per protocol analysis.
Per protocol analysis.
Yes, sir. Thank you, sir. Thank you, sir.
Thank you, Dr. Tanya. Our next presenter is Dr. Arnav Ghudai. He is PG DM resident from AIMS Patna.
Good morning, everyone. Myself, Dr. Arnav, Senior Resident, Department of Neonatology, AIMS Patna. My research topic is to assess the efficacy of prophylactic oral calcium supplementation in reducing the need for phototherapy in neonates with gestation age of 35 weeks or above. This was a pilot trial. So, as we all know, neonatal jaundice is the most common cause of neonatal morbidity and rehospitalization in the first week of life. And clinical jaundice is seen in 60% of the term neonates and 80% of the preterm neonates. and why we are worried, because the high bilirubin can cause bilirubin-induced neurological dysfunctions. And if we see the incidence, that is seen in 2 in 1000 in case of preterm babies and 1 in 40,000 in case of term baby. So as per the incident, the need for jaundice requiring the need for phototherapy, the percentage varies between 15 to 23%. So this phototherapy is required to prevent these neurological complications. The factor that is responsible for the neonatal jaundice are the immature RBCs, hepatic immaturity, and increased enterohepatic circulation in neonates. So the treatment options available are the phototherapy, exchange transfusions, sometimes IVIG and phenobarbital. But the experimental drug what we are assessing is the calcium phosphate. So there are two randomized controlled trial. Those they have evaluated the therapeutic role of calcium. Last one is published in the year of 2023. But the prophylactic role of calcium in prevention of need of phototherapy is yet to evaluate. So this was the research topic. The rationale behind this topic was the enterohepatic circulations contribute 10 to 20% of the bilirubin load in the circulations that our hepatic system has to deal with. So if we use oral calcium phosphate as a ionized compound, it binds with the bilirubin and it acts as a bilirubin trapping agent in the intestine, and therefore it interrupts the enterohepatic circulation, where the by interrupting this enterohepatic circulation there will be less bilirubin load in the circulations for which the liver has to work. So that will can lead to decreased need for phototherapy for neonatal jaundice. The novelty of our study was there was studies that have explored the therapeutic role of calcium, but this is the first study to investigate the prophylactic role of calcium for prevention of need for phototherapy. The primary objective of our study was to compare the proportion of neonates requiring phototherapy in the first week of life between the study groups, and the secondary objective, as it was a pilot study, to find out the safety profile of the calcium also. So we have kept hypercalcemia as an secondary outcome, and that was measured on the day 3 of the life. So it was a parallel group pilot trial, and it was done in the postnatal ward of IMS Patna, and populations were included all inborn neonates. The study was started after the IEC approval and the CTRA registrations. Our inclusion criteria was all inborn hemodynamically stable neonates with gestation age of 35 weeks and above. So we have excluded the babies those required NICU admissions, had cephalhematoma or subgaleal hematoma, had ISO immunizations. Baby with major congenital malformations and neonates requiring exchange transfusions were excluded. That was the interim exit criteria, the neonate requiring exchange transfusions. The interventions, we have given oral calcium phosphate as a dose of 40 to 50 mg of elemental calcium in 2 divided dose, started within 6 hours of life, and it was continued for 6 days. And the comparison group, the control group, that was continued to receive the routine standard of care. The sample size, as it was a pilot study, so we considered 30 in each limb, and we considering 20% possibilities of attrition, because we had to follow up for 1 week. So total sample size considering the attrition came out to be 80, that is 40 in each group. This is the concert flow chart showing the study flow and the inclusions of the population. So initially total of 89 babies were assessed for the eligibility. After excluding 9 babies, 80 babies were enrolled, and in the follow-up we can see there was 3 in the intervention and 4 in the control arm were lost to follow-up. And final analysis include 80 babies, because we followed the intention to treat analysis protocol. So we analyzed 80 babies, those were randomized, those were finally analyzed. So coming to the results, the baseline characteristics were similar in both the groups, and 5 babies in the intervention groups and 11 babies in the control group required phototherapy during the stay. So among this during the first 1 week of life, so among these 5 cases, 3 had NNJ during the primary admission itself, and 2 had readmission for the jaundice in the first week of life. Whereas 11 cases in the control group, 6 had neonatal jaundice during the primary admissions, and 5 were readmitted in the first week of life for neonatal jaundice. And more importantly, there was no episode of any hypercalcemia in the either of the study groups. So this is the stacked bar diagram showing the proportion of neonates requiring phototherapy in the first week of life across the study groups. So to compare this, we have used the chi-square test across the group, and there was a reduction in the proportion of the neonatal jaundice in the intervention group compared to the control group, with a relative risk of 0.83 with a 95% of confidence interval. It was actually crossing 1, so that was not statistically significant. The p-value was 0.09. And with a relative risk reduction of by 15%, the ranges varies between 2.2 to 32.2%. So this is the violin plot showing the distribution of serum calcium level across the study groups. So we can see the all the serum calcium levels were within the normal physiological limit in either of the groups. There was no episode of any hypercalcemia. To conclude, this is being a pilot study that demonstrated a non-significant yet favorable trends towards reduction in the proportion of neonates requiring phototherapy in the first week of life. Importantly, there were no episodes of any hypercalcemia in either of the groups, supporting the intervention safety profile. The major limitation of our study was it is a limited sample size, and that reduces the statistical power to detect a significant result. And future larger scale studies are necessary to comprehensively analyze the efficacy of the calcium for prevention of need for phototherapy. Thank you. Yes, sir. So there was one randomized control trial that gone for a 10 sample in each group. First we seen the safety.
Because you have a very, how many sample size was there?
Sir, 80.
80. And in one group you said there was a 5 baby, and another group was 11.
11.
Right?
Yes, sir.
So total group was 80.
Yes, sir.
Right? And then how do you validate for this? What was your validation process?
So validation process for the safety of the drugs, or
no. Validation. How you are going to validate these your intervention?
Sir, after this pilot study, we are planning to do an proper randomized control trial with a larger sample size. By using this data, with this outcome, we can calculate the sample size. Whatever sample size will come, we'll include that sample size and do the further studies.
No, I'm not asking about the sample size. I'm talking about the process for validation. Are you getting my point?
Process of validation of the results, sir?
No, before starting, because you are saying this is pilot study.
Yes, sir.
So before doing a pilot study, you have to do some validation process, and then you can only start with proper study. So what was your validation process? Unless the validation is not good, then how you can extrapolate the result? This is what my concern is.
Sir, the validation was there was already therapeutic role is established, sir. So with the concept of the same, we have gone for the pilot study, sir.
Okay, Dr. Arnab, it was good, but trial registration was also done before conducting the trial, and for this, it's a pilot study, understand. But how did you calculate, or did you define the power and of the study, and any blinding process?
So it was an open level study.
Open level.
Yes, sir. And the power of the studies, we can calculate the beta, so that will show us the power. But for a pilot study, as we cannot calculate the proper sample size, so the power is going to be less. So using this data, we planned for a second study where we are going to do a proper study, sir, with a larger sample size.
Okay, but you have to have some, like, assume that we expect like this much different.
Yes,
this
sir.
was a non-inferiority or equivalence trial?
Sir, this was because we are giving this a pilot.
Okay.
The previous study that was done, that was superiority trial, that was the therapeutic role. With that, we find that there is definite role. So, and they also showed that there was reduction in the need for the rebound in bilirubin, hyperbilirubinemia was also reduced. So with that concept, we extrapolated here also. We cannot do proper sample size because there was no previous studies. So we take the 60 sample size.
So Arnab, after doing this study, what would you like to suggest to other units? Whether they should, because of sample size and the process of validation is, to me, it's not earlier defined properly. So, but do you think it should be, then you can recommend to this that we can go ahead
based
with?
on one pilot study we cannot recommend.
Yeah,
So
that
we
is why I'm
need, so that's why we are not recommending, sir. We are just saying that there is a decreasing trend, so future studies are required with a larger sample size where we can definitely get results.
And one more question is, you said the calcium to be started less than 6 hours of life. So how it is possible? Suppose a baby is developing, may not develop, and then how you are going to start? That means you are starting calcium to everyone, probably to those who are you are contemplating to recruit as a subject.
Yes, sir.
So how it is possible? The prophylactic you started, even the baby has not developed jaundice, may not be possible to develop within 6 hours, and then you start dosing.
So
how do you do?
We are using calcium for the prevention, sir. So the starting point we have kept 6 hours of life. It is not the purpose for the therapeutic purpose.
No, that's okay. So I really doubt the ethical committee has started, even though
See,
the
ethical committee
disease is not there, and then you starting prevention.
Sir, calcium is a type of routine supplement that is given in the extreme less than 34 weeks. We are giving calcium, so that it is like a normal nutritional supplementations. So we are using the extra advantage of calcium by giving it to above and below 35 weekers to have a benefit in the jaundice.
So you have written below 34 weeks, baby.
Above 35.
Above 34 weeks, baby. So above 34 weeks,
35 weeks.
Above 35, yeah, jo bhi. So they should be hemodynamically stable.
Yes, sir. That was our exclusions criteria. Any NICU admissions were excluded, and baby has to be hemodynamically stable. Inborn neonates, those are shifted to mother side. So those babies we have included.
Okay.
These are because maybe many of these jaundice that develop maybe just a physiological jaundice also.
Yes, sir. So the
again,
sir,
because you are saying that because it's a safe drug which can be used as a part of your daily routine supplement. That's okay.
But extrapolating these, it is going to decrease the incidence of or that as a therapeutic dose. We are using calcium as a therapeutic for the hyperbilirubinemia. Still,
sir, yet it is a topic of research, sir, and the physiological jaundice, again one of the important factor is enterohepatic circulations, and we are targeting that enterohepatic circulations to decrease the bilirubin load, sir. But that is our main hypothesis behind this topic, sir. Thank you, sir.
Thank you, Dr. Arnab. With this, we complete the prize category presentation. Now, our third presenter is Dr. Richi Dalai. She is assistant professor in the Department of Theology. Richi Dalai.
A very good morning to all. So I'll be presenting my study on factors associated with in-hospital deaths in low birth weight neonates admitted at a tertiary care neonatal intensive care unit in eastern India. This was a retrospective observational study. So as we all know that low birth weight babies are susceptible to multiple morbidities and mortality, and there's an urgent need for identification for predictors for deaths in such babies. There are a few studies which have been done in our country and in other LMICs, but the main issues are they are very heterogeneous, they have variable methodologies, and the major predictors among all these studies are variable, so that data may not be extrapolated to our cohort. And with this background, we did this study with the aim to compare the various maternal and the neonatal risk factors between the low birth weight neonates who died in hospital versus those who survived during their first admission, to identify the predictors that cause death in these neonates. So this study was done over a period of 31 months retrospectively from July 2022 to January 2025, comparing LBW neonates who died in hospital admission versus those who survived. And we documented all the data in a de-identified manner. We collected multiple maternal characteristics and neonatal characteristics. we basically found a sample size of 322 considering a power of 80% and alpha of 5%, and taking a previous study which had shown that only birth weight and mechanical ventilation were significantly associated with deaths in such neonates. In the study duration, there were around 327 LBW neonates who were admitted to the NICU, and hence we decided to analyze this entire retrospective cohort to understand what the predictors of mortality were. We did analysis using STARTA 18BE, and we did initial chi-square test for comparing the categorical variables and Wilcoxon rank sum for comparing the skewed variables. And those variables with the p-value of less than 0.2 on univariate analysis were finally analyzed using multivariable logistic regression. So what we found was, on univariate analysis, among maternal risk factors, maternal UTI or sepsis and presence of APH were significantly associated with death in the LBW neonates. Among neonatal risk factors, completed gestational age in weeks were much less, and birth weight in grams was much less in the death group versus the survived group. Delayed cry after birth was also significantly higher in the death group. KMC received was much less in the death group, and blood culture positive sepsis and receiving antibiotics was much higher in the death group. So now, entering those variables which had a p-value of less than 0.2 in multivariable logistic regression, we found that delayed cry after birth and KMC were significantly different in both groups with significant adjusted odds ratios. So in our cohort, we can conclude that in the LBW neonates admitted to our NICU, delayed cry after birth and lack of KMC were the major causes, or say associations for risk factor, associated risk factors for death in the hospital. Also, we found that there was a trend towards significance for culture positive sepsis, though it was not statistically significant, but there was definitely a higher odds of death in the blood culture positive sepsis. So the limitations of the study was, this was a retrospective observational study, but the strengths were it had a large sample size, but multicentric prospective observational studies would be necessary to validate these findings. And the learning for our unit was that we need further quality improvement to improve the KMC rates and to reduce late onset neonatal sepsis. Thank you.
Okay, Richi. So
Yes.
good exercise.
Thank you, sir.
So first and foremost question, after doing this study, what the changes you have done in your unit as a faculty?
So right now we are planning to start a QI study. Mainly the issue, sir, in sick neonates we are not able to start immediate KMC, sir. We have not yet started immediate KMC in the unit.
Yeah, that's okay. But
Yeah.
not immediate KMC. You have you have not said in your study that it was you have not defined it is an immediate KMC.
No,
or
sir.
the
It
later
is any KMC actually.
So
Yes, sir.
so probably what I understood is once the baby stabilizes and then you
Yes,
the
sir.
KMC doing
Yes,
in the
sir.
step down unit.
Yes,
That
sir.
is what you are pertains to.
Yes, sir. Yes, sir.
Okay. So so what you would like to implement and
So
what the
basically,
changes you have done?
sir, we are not yet, for antisepsis measures, we are trying to find out the causes where sepsis, potential causes for sepsis breach. Like already hand hygiene and gowning and everything, like it should be followed, it was being followed in the NICU, sir, but timings of entry of the attendants was not controlled. That we are trying to control, sir. And second thing is that we are planning QI studies that we are about to do. We are about to start, sir, for mainly reduction of late onset sepsis and increasing KMC by involving nurses to increase the KMC duration, sir. We are planning that.
See, the neonatal mortality is actually a composite indicator, So,
Yes, sir.
So the lot many factors are responsible for the mortality. So what
Yes,
you
sir.
could do, see the antenatal factor, we probably may not be able to,
Yes, sir.
control because
Yes,
it is
sir.
an entirely different domain.
Yes, sir.
But as far as our unit is concerned, and just as you told you, to prevent sepsis, that could be one reason.
Yes, sir.
Or you can increase the rate of KMC.
Yes,
So
sir.
this is actually not requiring any additional resources also, and then you can
Yes, sir.
implement.
Yes, sir.
Right. So it's a good exercise, internal audit kind of thing,
Yes, sir.
and then that gives the relation to to work on that whichever
Yes,
the
sir.
factor
So
is
that was the
responsible
main
for
purpose of the
mortality.
study. That's why this retrospective observational study. Yes, sir. Thanks.
Okay. Dr. Rashid was a nice study. And I think it's a type of study, I just can recommend that make many like good and prospective changes. Okay,
Yes, sir.
thank you.
Thank
Nice
you, sir.
presentation.
Okay.
First, thank you participants, particularly PG students and our faculty, Dr. Richi, for submitting their articles, because we have only few articles submitted, and this
Are there in our state, or as far as the East zone is concerned. So probably the adequate information
Yes, sir.
sharing probably might have not done.
No, sir. They are very strict with all the protocols.
Okay,
The
okay.
organizing team.
So probably screening out was
Yeah,
there.
screening. There are so many posters and
Okay.
papers are there, but very few are the original research paper.
Okay.
So they have selected only original. They're
So
very.
So I would have requested that if there is a less, the purpose of our presentation to encourage all the postgraduate. So the screening, I understand there is very strict defined criteria for the screening, but there once you for the screening, but once you think that the participation is less, you could have decreased your strictness bars to lesser down, so that you could
Next
have
time,
maximum
next time we will
participation.
do.
So that will encourage the more competition, more encouragement. At least the postgraduate, they come, they present there, they feel empowered and encouraged. So that should be our purpose.
The problem is that they are more doing case series.
Okay, okay.
They are more doing case series, and including case series with research paper is difficult to judge, sir.
Okay.
Case series just observational study, and these
But
are.
even though I think probably this could be my just opinion, even though if they are not submitted, if the topic appears to be good, let them come and then hall भरा हो ठीक है वहीं पे screen कर देते हैं. So that could have been much
Yes.
encouraging for this.
That's a nice suggestion, sir. We will
Yeah.
abide by that.
So it's all depends upon how if you have a large number of participation, yes, of course you need screening.
Yes.
If the participation is less, then you can 5-10 ही आने दो सबको, and then we'll decide there only. So at least they will get a participation certificate for that. For the postgraduate, participation certificate is more than encouraging for them. Okay.
Okay, thank you, Dr. Rameswar. Thank you, Rameswar sir and Sachin sir, for such a nice morning session. We will break for 5 minutes for tea break. We can enjoy your tea and the biscuits there, and then we'll start the scientific session. I request everyone to please go. I will also request all the speakers to please upload their PowerPoint. Ravi sir and all this Rameswar sir. Everyone, please upload their PowerPoint and their CV. We'll break for 5-10 minutes and then we'll start the scientific session. पहला आप दो मैम. हाँ हाँ जी मैम. नहीं बिल्कुल थैंक यू मैम. मैम चाय कॉफी. बस मैम तो लेके चलिए ना. ये भी कहीं लेट है. ये भी के लिए Good morning, everyone. गुड मॉर्निंग। पटना में एक बार फिर आपका स्वागत है। आई थिंक कल आप लोगों ने पूरा साथ दिया हम लोगों का और पूरा एंजॉय किया। मैं थैंक यू बोल सकता हूँ आप सभी लोगों को, स्पेशली डॉक्टर नीलम वर्मा मैम, प्रोफेसर नीलम वर्मा मैम, जो कल भी आई मैम, पूरे दिन बैठी, कल इवनिंग में भी आई और आज भी आई मैम सुबह। तो थैंक यू मैम, आप लोगों की वजह से साइंटिफिक प्रोग्राम हम लोग अच्छे से कर पाते हैं। सारे सीनियर्स का सहयोग रहा है हमेशा और आशीर्वाद भी रहा है। तो इसी के साथ आपकी इजाज़त से मैं फिर से आज स्टार्ट करने जा रहा हूँ साइंटिफिक सेशन। हाँ, थोड़ी बहुत गलतियाँ मेरे से कल हुई हो उसके लिए पहले ही क्षमा मांगता हूँ। हो सके कोशिश करूँगा कि दोबारा ऐसी कोई बात ना हो स्टेज के माध्यम से। तो इसलिए फिर से आज पहला सेशन मैं बुलाना चाहूँगा डॉक्टर A.K. झा सर, प्रोफेसर पीडियाट्रिक्स PM डॉक्टर A.K. झा सर, and for chairing that session I will request Dr. Professor Neelam Verma ma'am, Dr. P.P. Mishra sir and Dr. Amit Kumar.
Hello. I think today it is too very early time and the gathering is very poor. Still we are going to start the session. First of all, the session is very important. We will discuss about the short bowel syndrome in neonates, and the speaker is a learned professor of Patna Medical College. Dr. Prabudh will introduce. And short bowel syndrome is a very important entity because it may be very serious condition. The child may be born with short bowel syndrome, that is known as when the stomach intestine is above the abdomen, it is known as gastrocystis. And when the infection occurs, necrotizing enterocolitis can lead to short bowel syndrome. So the management, medical and surgical, both are very, very important. Medical management, till surgery is done or the correction is done, we have to do this parenteral nutrition and care of liver and management of fluid, everything is being done. And the surgical management, lengthening of intestine can be done. All these things will be discussed by Dr. A.K. Jha, and Dr. Prabudh Mishra is going to introduce the learned speaker.
Dr. Professor Amresh Kumar Jha, Professor and HOD, Patna Medical College, Patna, MBBS, MD Pediatrics. His areas of interest: neurological outcome in premature and nutrition, major achievements establishing neonatology in PMCH, and he has 16 publications till date.
Thanks, chairpersons, for your kind introduction. Good morning to all audience present, though there is a bit of thin attendance, but I think time is important, so we have to start. normal intestinal length in term infants is approximately 200 to 300 centimeter. And short gut due to loss of ileum and ileocecal valve especially has very grave consequences which we will discuss later. For successful survival and adaptation in full term neonates, 25 centimeter of ileum with intact ileocecal valve is sufficient. The baby can survive and thrive. But if ileocecal valve is removed, then 42 centimeter of ileum is required for survival. But the diagnosis of short bowel syndrome is not made by measuring the intestines. That is measured during operation at the antemesenteric border. It is made using functional criteria rather than an actual gut length, and each based on prolonged need for parenteral nutrition for more than 6 weeks. Then we call it short bowel syndrome. Now setting the scene for pediatric short bowel syndrome. Short bowel syndrome classification is done according to remaining small bowel anatomy. Prognosis is dependent on multifactorial relying factors like etiology, classification, motility, length of remnant gastrointestinal tract. So importance of early and appropriate management is important. Increase in prevalence is seen in pediatric short bowel syndrome reported in the last decade. Resection at a younger age has higher potential for small intestinal adaptation and growth because the bowel grows approximately 30% to 40% in the last trimester. And if in premature babies, the full potential has not yet reached, so adaptation is relatively better. So careful surgical management is aiming the GI tract preservation is very important. Once it's lost, it's lost. The type of malabsorption varies according to the part of intestine. Every segment resected has peculiar consequences on intestinal absorption, and physiological process of intestinal adaptation stimulated by endogenous and exogenous factors are important. So early and physiological use of gastrointestinal tract as soon as possible after surgery is our aim. Classification and etiology of short bowel syndrome. Classification is done into 3 types for understanding the different outcomes. Type 1 is with enterostomy in enterorectal anastomosis. That means that practically the whole of gut is lost. Direct from ileum to coleum anastomosis is done, and there is absence of colon. Type 2 is with jejunocolic anastomosis, in which there is a small segment of jejunum left, and type 3 is with jejuno-ileocolic anastomosis, in which some jejunum and ileum is present. So this is the diagrammatic representation of these 3 types. The causes of short bowel syndrome in childhood, they are in the prenatal etiologies: intestinal atresia, single or multiple, 10 to 20%, gastroschisis, plus minus one of the several intestinal atresias, 10 to 16%, total or subtotal agangliosis, that is Hirschsprung disease, total or subtotal if ganglions are not present, though the bowel is there but they are not functional, that corroborates to short bowel syndrome. And in neonatal etiologies, most common is of course necrotizing enterocolitis and midgut volvulus from abnormal mesenteric rotation, meconium ileus in 20%. Childhood etiologies, to relate a few cases: volvulus related to bands or tumor, intestinal intussusception, trauma, arterial or venous thrombosis, Crohn's disease, extensive small bowel aganglionosis, and radiation enteritis. Now these are functional causes of short bowel due to absence of ganglia or damage by the radiation. The bowel is there but it's not functional, so it is a short bowel syndrome. Now consequences of different intestinal resections. If jejunal resection is there, it results in severe malabsorption, severe diarrhea with steatorrhea and critoria, and increased rate of gastric emptying. Because jejunum, the endohormones in the jejunum, they secrete, they stimulate the secretion of bile acids, and since that is not there, the fat will not be absorbed, and so it will result in lot of bile acid in the terminal ileum, and that will lead to diarrhea, and fat malabsorption that will lead to steatorrhea. If ileal resection is there, lipid and lipid soluble vitamins malabsorption with steatorrhea will be there. There will be cholelithiasis because of the excessive presence of bile acids that will lead to cholelithiasis, hyperoxaluria, because these free fatty acids, they bind with calcium, and that will result in excess of oxalate, and that will lead to oxalate stones in kidney also. And of course biliary colitis, all the bile going to colon, there is a lack of enterohepatic circulation, that will lead to biliary colitis. If ileocecal valve resection is done, then that will lead to dysbiosis. That means all the colonic bacteria will be refluxed into ileum and jejunum. This ileocecal valve prevents that. So if that is lost, there will be the colonic secretions will enter the small bowel, which will lead to diarrhea and bacterial colonization, and infection will prevail, and there will be bacterial overgrowth, small intestinal bacterial overgrowth. Colonic resection will result in increased fluid loss with increased dehydration risk, as most of the water is absorbed in the colon. Other general conditions like gastric hypersecretion is there due to increased gastrin secretion. So that will lead to gastric hypersecretion, and gastric emptying peptide, that is PYY, and glucagon-like peptides and neurotensin, these all are released by jejunum. So in the absence of jejunum, these peptides will be increased, and that will lead to gastrin hypersecretion, that will lead in hyperacidity. And there will be alteration in gut motility. These ileum and jejunum, they have a braking effect, especially the ileocecal valve, that has a braking effect. If that is lost, there will be intestinal hurry. The intestine will move fast, and there will be diarrhea and lot of loss of water and electrolytes. Now, adaptation after extensive intestinal dissection, there is physiological adaptation, as you can see in this diagram. For this, both exogenous and endogenous factors are responsible. If you feed the baby, that will, as you can see, it will lead to increase in secretion of the intestinal hormones, and that will increase the depth of the villi, the widening of the villi, there will be hypertrophy of the villi, and the intestine will try to adapt physiologically to the condition. Now we'll come to the management, early management after intestinal resection. In the early acute phase, fluid management and resuscitation are crucial. We are not much bothered about the growth and weight gain. In the early phase, first 24 to 48 hours, we are mainly bothered with fluid management and resuscitation. Early energy requirements are essential to maintain physiological state, just to maintain the physiological state, but not to promote growth. Parenteral nutrition is mandatory in this condition. One has to go for parenteral nutrition, and in early acute phase is provided essentially by glucose under tight glycemic control. We keep the glucose level between 120 to 180, and for sufficient provision of the energy. And lipids as energy supply should be introduced as an integral part of parenteral nutrition in the intermediate postoperative period. Now composite, this nowadays we use fish oil that has been shown to reduce the liver disease. Previously it was not used, only soybean oil was used, and that led to liver failure, steatosis and liver failure. So introduction of this fish oil has found to be useful and should be considered in all patients for longer needs of PN, parenteral nutrition. In the late acute phase, a gradual increase in energy supply is needed, taking into consideration enteral intake and intestinal malabsorption due to intestinal resection. So as we have seen that if you feed enterally, that stimulates intestinal adaptation. So that is very important. We definitely start with parenteral nutrition, but we would like to introduce enteral feeds as soon as possible in order to allow the gut to adapt. So during early management of intestinal resection, calculation of fluid and electrolyte requirement should take into consideration residual and intestinal anatomy, presence of stoma, levels of intestinal losses. Regular monitoring should include weight and urinary sodium assessment. So we will be guided by the urine output, the requirement of water, and the urinary sodium concentration to balance for the electrolytes. We have to give sufficient sodium and water to maintain the hydration. Nutritional requirements in the late post-operative phase need to take into account cumulative deficits, tissue repair, and catch-up growth. Now you need extra amount of this protein and fat for reparative work. So cycling PN, parenteral nutrition, should be started under tight glycemic monitoring in all stable babies over 4 kg of weight. So then we would like to, instead of giving continuous parenteral nutrition in the initial phases, now one can go for cyclical parenteral nutrition. Of course, monitoring the glucose levels under tight glycemic control, it should be taken up. During a hospital stay, urinary sodium levels should be monitored daily in late acute phase and weekly afterwards, especially in children with a distal stoma. Urine sodium levels should be maintained more than 20 millimole per liter and exceed urinary potassium. It should be more than, the ratio should be more than 1 in short bowel syndrome children if diuretics are not used. So we should see that more this sodium is replaced in compared to potassium. And in late post-operative phase, screening for micronutrient deficiency is mandatory, because as we all know, vitamin B12 is absorbed in the terminal ileum only, and if that is resected, there will be megaloblastic anemia and neurological deficits. So early enteral nutrition should be started depending on the tolerance, and they say that plasma citrulline levels, if you monitor that, that helps in deciding when to start enteral feeds. So cyclical plasma levels of gastrointestinal hormones, insulin, pancreatic polypeptide, gastric inhibitory polypeptide, gastrin, motilin, intraglucagon, and neurotensin. So if oral feeding is given, all these hormones, as we see, that they increase, and in enteral intermittent feeding they are also increased. So these things, these hormones, they aid in gastric, in intestinal adaptation. That means the intestine will, the villi will, there will be villus overgrowth, there will be widening of the villus, there will be deepening of the villus, and absorbing capacity, whatever part is remaining, that will adapt to absorb the maximum nutrients. So these all will be stimulated by oral feeding, but and also in enteral intermittent feeding, but in continuous it is not there. If you give continuous enteral feeding, the baby is not tolerating, then we go for this continuous feeding sometimes. So that will not help, that will not increase the level of hormones. Stimulation of neuromuscular function throughout fasting period, that will occur in oral and intermittent feeding. And release of epidermal growth factor from salivary glands and increased gastrointestinal secretion of trophic factors. Now this epidermal growth factor, that aids a lot in promoting the intestinal adaptation. So they all will increase in oral feeding. So one should try to go for oral feeding as far as possible, as is very clear in this chart. And intraluminal nutrients support intestinal growth and adaptation. Improved energy and micronutrient supply will be in all three. Efficient use of absorptive surface area and transport will be, of course, better in continuous feeding. And a combined approach and oral and enteral continuous intermittent is feasible in some cases. So pros and cons, human milk of different types of feeding. This human milk has many advantages. Polymeric formula, if human milk is not tolerated, we can go for polymeric formula. Extensive hydrolyzed formula is used in some cases, for better absorption, and amino acid formula for the cases in which all these are not tolerated, we go for amino acid formulas which are available. A choice of feed we have seen, and how to deliver enteral feeds after surgery. Feeding should be initiated as soon as possible after surgery in children with short bowel syndrome. Oral feeding should be preferred route of feed administration, as we have seen. If oral feeding is not possible, evidence on advantages of continuous and intermittent tube feeding are lacking. Enteral feed increase according to the stoma output, as we have seen, and surveillance of feed tolerance in previous 54 hours. Human milk donor is the first option if mother's milk is not available. In absence of human polymeric formula, one may be attempt first line option. If human milk and polymeric formula are not tolerated, then of course hydrolyzed formula should be used. And gradual increase in enteral feeds of 10 to 20 ml per kg may be attempted depending on the stool output. Tolerance of enteral nutrition should be assessed. And from clinical experience, EHF are well tolerated because they are hydrolyzed, they are easy to absorb, and in short bowel, frequency of CMA may be higher in general population. Preparing for home PN and discharge once the baby is specialized, because some cases may require lifelong parenteral nutrition. So it should be taught to the parents and caregivers, and clinically stable patients requiring for 12 weeks, they may be considered with home parenteral nutrition. And home PN services should include appropriate training and use of antiseptic measures. And children considered for should have secure CVC, stable fluid and electrolyte needs, and tolerate a parenteral nutrition infusion break. Thank you.
Hello.
It's
Thank
a very
you.
extensive topic, so I mean to cover
Thank
it all.
you, Dr. Amresh Jha. You have spoken so well, and every aspect of short bowel syndrome has been discussed in detail about the medical management, surgical management, management of complication, and how to maintain the other parts of life and when to discharge. And about feeding details, he has discussed very widely. So, yeah, any question? I invite the questions from audience. Any question, Dr. Prabhu?
So what Dr. Amresh Jha has already told, that we have to shift to the enteral nutrition as soon as possible. So that is, I think it is a very important. Enteral is very important as soon after the surgery. And also the counseling part was also done by Dr. Amresh Jha for their parents. So for that, it was a very nice gesture of that. And thank you.
Thank you so much, sir. You have already gave so much emphasis over short bowel syndrome. But the prognosis totally depends upon the skill of the surgeon, because every inch of gut is important, and timely nutritional rehabilitation is very important for a good prognosis. So a skilled surgeon and a good neonatologist has led to favorable outcome in last 5 to 10 years. Thank you so much, sir.
Thank you.
Delay surgery just so that we can manage the baby conservatively, and delaying the surgery at times leads to increase in gangrene as well, and subsequently saving, as sir was saying, saving significant amount of intestine becomes difficult later on. So you have to identify signs of gangrene inside gut, and if you identify it pretty quickly, then you can intervene early as well. But there is no fixed answer when is it is too early or prematurely getting in versus getting in late. So just finding the right balance when to go for surgical intervention is a very difficult skill to acquire. So your comments on that, when to go in and operate a baby with, say, suspected NEC, and yes.
It's a multidisciplinary approach. you need a neonatologist, a pediatric surgeon, a nutritionist, and of course a skilled nurse. It's very difficult, no doubt, to treat short bowel is very. Parents when they go for yes. So.
Is there any biomarker to reassess, or because earliest is the best? Whatever, if you are doing after gangrene, the chances of recovery is very poor.
So biomarkers are mostly clinical, are quite reasonable. And yes, definitely. So if you have bluish looking abdomen which is there clinically, and persistently low platelets which are there, persistent bilious aspirates are there, and radiological markers are important. Once you see a portal venous gas, once there is a fixed bowel loop at certain quadrant, then these are signs that you probably should intervene. And getting it too early, the disease could be at in the progressive stage as well. So if you operate, take out some bowel, then 2-3 days later, same problem would be there again in that baby. And this is when the gangrene is actually progressing. So again, going in too early at times, it could be, when the disease process has not fully evolved. And at that time, you have to have a second look surgery as well, because the symptoms have not abated. The platelets continue to be low, the abdomen continues to be distended. Then the surgeon is, okay, should I do a dye study? Should I go in again? And going again for such a baby, family, as sir said, it's a very difficult question for the costs increase significantly. Anesthesia risks are always there. So that is why mastering this art of optimizing the timing of surgery is still a dilemma.
Thank you, sir, and thank you, ma'am, and all the chairpersons and all the audience. In the morning hour, this is the first session of the test match. Very well played by the A.K. Jha sir and all the chairperson. I'll request you all to come for the memento distribution. Thank you, ma'am. There's a slight change in the scientific session because some speakers have to take a flight in the morning hours. So we have changed some. I think you will go with us. The second session by Dr. Ravi Sachan sir. I will request Dr. Ravi Sachan sir to please come on the dais. Sir is well-known personality, sir, please come. And for chairing that session, I will request Dr. Shravan sir, Dr. A.K. Tiwari sir, Dr. Jitesh Mandal sir, okay, Shravan sir and Dr. A.K. Tiwari sir to chair that session.
So good morning, everybody.
Sir, please.
I am thankful to the organizers for providing me this opportunity to chair a very important session. The speaker is none other than Dr. Ravi Sachan, who is Professor and Head Division of Neonatology at G.B. Pant Hospital, New Delhi. He has been Treasurer NNF 2526 and EB member NNF 2324, Vice President Association of Neonatologists, Delhi 20222, and Secretary Association of Neonatologists, Delhi 2021. He is editor, Handbook of Neonatological Clinical Practice, and so many work has been done by him. So I welcome sir, and
Thank you,
I
sir.
request
Thank
you
you.
to start your session. Your session is on jaundice. So let us just start your session, sir.
Thank you, sir, for your kind word of appreciation. And good morning, everyone. Just a small discussion about the management of anemia. So we'll be just, yeah, this is a very common topic, and we are, as far as a clinical pediatrician is concerned, we are facing a dilemma about the availabilities, common diagnosis. So there is a management dilemma amongst all of us, then which guidelines to be used, because lot many guidelines are available. So we'll just touch upon the what are the different guidelines available and what is their salient feature, and how at the end of the presentation, uh, which one is to use. We'll try to just to find out the answer, which is the better one guidelines are available, right? So as we all know that it's around a millennium decades old, neonatal joint days. So the breakthrough comes when the Kramer defined this Kramer's rule, what we are commonly knowing. It is around 60 years ago, and then phototherapy was started, and the journey of phototherapy beginning from the fluorescent tubes to the then bulb, fluorescent tube, and then halogen light, and then tube light, then fiber optics, and then blee blankets, and now we have got an era of LED, which are very more efficient as far as management is concerned. So despite the 60 years of history of use and research in important question regarding both the science, basic science and the practical application, phototherapy remains it is yet to be answered effectively. So different guidelines as far as is available for the management of neonatal hyperbilirubinemia is Canadian Pediatric Society of Guidelines, which is available since 1999, and there is no still update about that. So bilirubin level, especially based on the postnatal age and the healthy term infant, and this is not do not talk about the especially for the preterm baby. And then widely used is American Academy of Pediatrics guidelines, which was released in 2004, and it was recently updated in 2020, and that talk about management of neonatal hyperbilirubinemia beyond 35 weeks of age, but they do not consider less than 35 weeks of the gestation age. And the most of these are the based on the consensus guideline with the limited evidence, and they use intensive phototherapy, and it is available for more than 35 weeks. Another guidelines available about the European Society of Pediatrics, and that is also among the based on the consensus guideline and mostly endorsed with the American Academy of Pediatrics. Another is very common UK NICE guidelines is available, and that was updated in 2016, and that also talks about the treatment of stable and graph based guidelines based on the gestation age, and that uses the total serum bilirubin level, and that is again based on the consensus guideline and the expert opinion. The threshold chosen with a wide range of safety and the threshold for phototherapy, and well below the range of extent transfusion. Right, and the beauty of these NICE guidelines are they are available with the different gestation age, age wise normograms are available. And then we have a Norwegian guidelines, and it is again based on the consensus expert group opinion, and they are not very pragmatic to use. And then other guidelines are available. Next we comes to the NNF CPG guidelines available as far as our India is concerned. So it was first given in 2011, and then later on it is revised by 2019, and that's NNF CPG guidelines do talk about, and it is mostly based on the consensus guideline, and some has got an endorsement of American Academy of Pediatrics, but it is more pragmatic as it is country specific. So what the NNF CPG guidelines said, a neonate is available for the more than 35 weeks also, and the less than 35 weeks also. So more than 35 weeks this is more of based on American Academy of Pediatrics guidelines, but in case of a less than 35 weeks, it do recommends that the phototherapy should be started based on the total serum bilirubin level with 0.5% to 0.75% of the body weight in sick and healthy term infant, which is also incorporated in our facility-based newborn care guidelines by the Government of India, Ministry of Health. And that, but overall it also depends upon the based on the consensus guidelines with the limited evidence, right? And next is Indian Academy of Pediatrics guidelines, which was released in 2022. It is mostly based on the American Academy of Pediatrics and the NICE guidelines together, but it again is based on the consensus guideline and expert opinion. And then we have an ICMR guidelines by Ministry of Health, which was again released in 2022, standard treatment protocol for and this is also again based on the consensus guideline. So what the ICMR guideline says about the new management of neonatal jaundice. So this is how the algorithm is given. So I think it is a little busy slide, but I hope it is understandable. So this is just one algorithm which is for the available for the common pediatrician, and that's talk about the how to assess the neonatal jaundice based on the Kramer's criteria, and then it mention about the serious jaundice, right? So it has taken an approach, assess first the baby of if it is qualifies the criteria of serious jaundice, and then you proceed further as per this algorithm. So what is serious jaundice as per the ICMR guidelines is? So it any visible jaundice in the first 24 hours, or yellow palm and sole anytime, or signs of acute bilirubin encephalopathy like poor suck, feeding, lethargy, hypotonia, or any abnormal neurological manifestation like abnormal posturing such as arching, retrocolis, opisthotonus, convulsion, fever, or high-pitched cry. So based on these criteria for the serious jaundice, and that is management is started. You start intensive phototherapy, and then once you start the phototherapy, and then again means you do the investigation, and then as per the investigation you ensure the optimum phototherapy is to be continued, and if it is not, and then when can we start. So there is a very clear cut algorithmic based decision making guidelines on the day-to-day basis of clinical practice and for the common pediatrician or for general practitioner, right? Another guidelines which are just talked about the Indian Academy of Pediatrics guidelines. So management of neonatal jaundice, which was released in 2022, and I was the part of these STP guidelines and authored this. So again, this is based on the consensus guidelines, and the approach is start from the Kramer's rules, and then it is based on the RS specific normogram which is available, and this is mostly based on the Bhutanese chart, and it shows there is a high risk zone, low risk zone, and the intermediate zone. An intermediate zone you can identify here again further divided into the high risk intermediate zone and low risk intermediate zone depending upon the risk factor of the baby. All right. So this is again a little bit about you discuss about the history, take the about history, and then you do the investigation, total serum bilirubin, mother's blood group, baby blood group, or the common investigation which are we are practicing in day-to-day life, day-to-day clinical practice, right? And then again the decision making based upon the American Academy of Pediatrics consensus guidelines, and depending upon these are very well known, familiar to all of us, and then we decide according to the risk factor of the baby, and then we once the babies fall in that risk, and then we start with the phototherapy or with the exchange transfusion or when to stop phototherapy. So there is a clear guideline for that, So this is about the American Academy of Pediatrics guidelines. Next. So this is what we are familiar with this, and recently it has been revised. So depending upon the risk factor of the baby, we decide about the starting of the phototherapy. All right. So phototherapy and the exchange bilirubin. And this is again the algorithmic approach which is given in the American Academy of Pediatrics, how to proceed for the treatments. The detailed discussion about it may not be the purview of this our discussion. So I'm just touching upon the highlights and salient feature of the different guidelines available for our practice. And then comes to the very much talked about the NHS guidelines for the neonatal jaundice, right? What we call the NICE guidelines. So silent feature of the NICE guidelines, the guideline says do not rely on the visual inspection alone and estimate the serum bilirubin level in a baby with a jaundice, right? So then it says how to measure the serum bilirubin level. It says that first you measure the TCB for the babies, a gestation age of above 35 weeks and more, postnatal of that age. And if TCB is not available, then measure for serum bilirubin level. And if any time if you find the TCB level is more than 250 millimicroliter, which is approximately around 15 mg per deciliter in hour, which we are usually measuring as a serum bilirubin level. And then if it comes to the more than 15 mg per deciliter, probably don't rely for that, because the sensitivity of the TCB is not very good in the upper or higher range. So therefore you need to confirm it by the serum measurement of the bilirubin, right? And then next comes to how to measure the serum bilirubin, and then the confirmatory would be only to determine the serum bilirubin level with the jaundice in the first 24 hours, always measure for the serum bilirubin assessment. To determine the serum bilirubin level in the babies less than 35 weeks of gestation age, always go for the serum measurement of the serum bilirubin level, because the TCP again may not be reliable for that. Alright. Then how to manage the serum bilirubin? Use the bilirubin level, and that determines the management of hyperbilirubinemia in all babies. And the refer guideline especially for these, what is the threshold table for this? The treatment threshold for the graphs and investigation pathway, which is delineated and given as an algorithmic approach, and then decide accordingly whether the baby fall for the phototherapy zone or is for extend transfusion. Right. And the beauty of these nice guidelines is they are the gestation age specific, which is probably not very much as clear as in the other guidelines also. So the nice guidelines, the gestation age starting from the 38 weeks, above 38 weeks, and then you have a gestation age specific normogram till 20 weeks, 23 weeks of gestation age, right from 38, above 38, and then 38, then 37, 36, 35, till you get 23 weeks of gestation age. So they are more specific, more tailor-made for the decision making of the management of hyperbilirubinemia, and then you decide accordingly on the basis of label whether the baby is falling into the phototherapy range or for the extend transfusion range. So this is how these above 35 weeks. So looking at the different guidelines available, the common practitioner is getting confused and which is to be followed, and the till date no evidence or no studies has been available which compares head-to-head comparison between the guidelines, different guidelines available, American Academy of Pediatrics versus NNF versus NICE guidelines. So there is no head-to-head comparison between different guidelines available. There is no RCT, no meta-analysis is done, because most of the the studies are not very high-powered, and the methodology is not very robust. So therefore it's a dilemma. So what to start and when to start? So what is your ultimate final verdict? So which is to be followed? So the take-home message from this discussion would be, so it cannot be generalized for all the babies, and it cannot be generalized for every unit facility you are treating with. So depending upon the level of facilities available, if you are working a level 3 care unit, level 2 care unit, if you have got a level 2 SNCU, NBSU, probably ICMR, the standard treatment flow for ICMR for primary health center or secondary health center, it would be great to follow these guidelines, because this is a very generalized kind of things. And if you have got a level 3 or above unit like a tertiary care center unit, and then the definitely NICE guidelines or American Academy of Pediatrics guidelines to be followed. And if your target population is, if you are dealing with more than 35 weeks of gestation age, definitely you follow the American Academy of Pediatrics. And then if you have your target audience and the babies, the unit is catering more of preterm babies, more of low birth weight baby, definitely you follow the NICE guidelines. And if you want the country specific, then definitely the NNF is the one to be followed in all unit, and we can have an Indian Academy of Pediatrics guideline. So this is how I try to give some crux or the conclusion for this. So I hope it will with the age-old question, so may be able to give some discretion or the then which guidelines to be used. Thank you so much. I would be happy.
Thank you, sir, for elaborating such a nice guideline, and that some dilemma is also there, what to do, what not to do. Exactly. And one question from my side, we are facing persistence of hyperbilirubinemia. Even after exchange transfusion, even the phototherapy, the serum bilirubin persists between 10 to 18 milligram %, and how it should be managed?
Yes, sir, definitely. The management of persistent hyperbilirubinemia is concerned. So first of all, the reason need to find out why the persistent is of jaundice is. Definitely, as per the definition goes, any baby who has got a persistent jaundice, for a preterm baby especially, more than 21 weeks is called as a persistent jaundice, and for term babies it is 14 days. So all the persistent jaundice, if you qualify these criteria, the detailed investigation has to be done first and foremost, and then you find out what could be the possible reason for the persistence of jaundice. This could be, the baby may not be given early and exclusive breastfeeding. So because and lot many other factors are responsible for hydration of the baby, feeding, adequate feeding, breastfeeding. Right. So all these factors which are responsible for the persistent of jaundice. But of course, if anything which is a persisting jaundice thoroughly need to be investigated. Right.
Thank you. Any question from audience?
Yeah.
The first investigation is it a direct bilirubin or indirect?
Yes, of course.
And if it is indirect, most of the investigations have already been done.
Yeah.
The only thing that I would say from my side is don't stop breastfeeds.
Exactly.
Do whatever you want to do.
Yes.
Doing nothing is the only thing. Just explaining to the parents, this will go off in 3 months. I said, don't ask me this question for next 3 months.
Yeah.
The jaundice will disappear. The question is that when they get differing opinions from different doctors, and then the problem occurs. Yeah, jaundice breastfeeding ke karan ho raha hai. That is the worst thing that we can ever say.
Yes.
So if it is indirect jaundice, don't worry about it. If it is direct jaundice, then it goes into a different sphere itself. Then the detailed investigation starts. So if you have worry, 3 weeks, do a direct and an indirect. Indirect hyperbilirubinemia, do nothing. Absolutely nothing.
Exactly.
Yes. Thank you.
So if it is indirect, then need not to worry. Direct, then definitely you need to further work up, because at the same time, if it comes to with cholestasis, so then we further referral may be require, and further specialized center that will require a further investigation also, because that is ultimately hampering for the liver damage also. So that need to be considered. But if it's indirect hyperbilirubinemia, then no need to worry about. Just continue the mother milk. That's I think more than enough.
Yes.
I want clarification one thing. Many pediatricians tell keep the baby in the morning sunlight. Previous AMS guidelines specifically criticize it, and newer guidelines nothing is told. So you give a clear-cut message. Is there any role of the sunlight in the management of neonatal hyperbilirubinemia?
See, the management of hyperbilirubinemia, the phototherapy works under a very narrow range of spectrum, of light. That is not available in the, if you are exposing the baby to the sunlight, that may not be very much feasible or therapeutic for that baby if you are exposing for the sunlight, right? Because it has got a very narrow spectrum. What we are using in a phototherapy, that is a specific spectrum for the therapeutic point of view. So it is the sunlight, exposing sunlight should not be confused as a therapeutic option for the treatment of hyperbilirubinemia. It should not be done. Maybe you may be doing more harm for this baby, exposing for the sunlight, maybe baby getting hypothermic, and then you will end up another complication for hypothermia. So it should not be in a replacement, or it should not be considered as a treatment for hyperbilirubinemia.
Thank you, sir.
Denies? Okay. See, as far as
very good app, even my nurses can use it. If my nurses can use it, every nurse around the world can use it.
Basically,
you don't need doctors. They do the bilirubin themselves.
Yeah.
They put it on the chart. High risk पे यहाँ पे phototherapy देनी है, low risk में यहाँ पे देनी है.
So,
and then you decide on that.
They based on actually the American guideline cutoff are the based on the American guidelines are there.
Thank you, sir, for such a nice, because the jaundice is a great neonatologist, and it is a great discussion. Thank you.
Thank you, sir. Thank you all the chairperson. Please come for the memento distribution. मेरे पास एक ही जवाब है सर कि मस्ट इंक्लूड दादी को शामिल कीजिए काउंसलिंग में. शी इज द मोस्ट इंपॉर्टेंट पर्सन फॉर फोटोथेरापी. और गायनेकोलॉजिस्ट को जरूर इंक्लूड कीजिए. हमसे पूछने के बाद वो गायनेकोलॉजिस्ट के पास जाता है कि कराएं कि नहीं कराएं, है कि नहीं मैम? थैंक यू. मूविंग ऑन नेक्स्ट, वी हैव नेक्स्ट सेशन बाय डॉक्टर प्रतिमा आनंद मैम. आई विल रिक्वेस्ट मैम टू प्लीज कम ऑन द डैश, एंड फॉर चेयरिंग दैट सेशन Dr. Nishant sir, Dr. Kumar Sambhu sir, and Dr. Jitesh Mandal sir. Vinod sir.
Hello. Dr. Pratima Anand is a very pertinent figure in IAP. She has done MD Pediatrics and DM Neonatology from AIMS, New Delhi. She is Assistant Professor Neonatology in Department of Neonatology, Lady Hardinge Medical College, New Delhi. Her areas of research interest is neonatal sepsis, neonatal growth and nutrition, extreme preterm care. Her publication has got more than 50 publications in national and international journals. And she's a national trainer of neonatal resuscitation, facility-based neonatal care, point of care quality improvement, and simulation-based learning. And she's a very terrific speaker.
Thank you for the kind introduction. Thank you organizers for giving the opportunity to talk about the follow-up today. It's a vast topic and a little bit theoretical also, but I'll try to make it friendly for the practitioners and also for the daily follow-up which we do. So let us first see why neurodevelopmental follow-up is needed, and when to do the assessment, and how should we assess the baby when the baby comes for follow-up, as we were discussing about jaundice also. So follow-up is needed because we all know the first 1000 days are actually a continuum of care. The brain continues to develop in the first 2 years, 3 years, 5 years, and we don't know how long till adult also. Till 12 years also there is adaptation which occurs, the neurological adaptation, and the myelination that continues to occur, cognition development, it continues to occur for the first 10 to 12 years, even in school age. So this is just a very, what to say, gross representation of what is the risk, and it varies as per the reports from various countries, and this is the highest incidence which has been reported from various networks, and the risk can be as high as 1 in 59 for autism, ADHD, speech delays which are discovered much later in the school time. And as the babies who are extreme preterm, they are surviving, the risk of developmental delay is also more. So this is just stressing the importance of follow-up. Discharge ho jayega baby in NICU se, but we need to follow them up closely to detect early delays and to intervene early. As we see weekly decrease in gestation, the risk of delay increases. The overall risk of moderate developmental impairment is high in the extreme preterm the baby is, higher the risk of impairment. It can go up to 40% in some babies who are 22 to 23 weeks babies who are surviving. This is all theoretical again, and if we see at the low birth weight babies, very low birth weight babies, there also the risk varies between 16.9% to 20%. So this is the burden, and the asphyxiated babies, those who are having moderate to severe HI, we all have been reading in our books that the developmental disability at 2 years of age can be up to 40% of the babies, they can have some developmental delay. Even in mild HI, there can be 20% babies who can develop delays. And these delays are not only gross, tone and developmental delays, but also delays in social adaptation, delays in cognitive impairment, delays in mathematics, calculations, executive dysfunctions, which are subtle dysfunctions which may not be noted by us. Jaundice, we have already discussed. The risk of delays is odds ratio, if we see, it's almost 1.6 times higher, and those who are receiving exchange transfusion, the risk is much more, 4 times higher of delays. So how do we follow up? So there is a categorization which we need to do. सारे बच्चों को ज़रूरत नहीं है कि we call them very frequently. So we need to categorize or triage the babies who are discharged from our NICUs or from OPDs, and we can categorize them into high risk, moderate risk and mild risk. So these are the conditions, and this we have taken from a study from Kerala from Dr. Naveen Jain. There are other risk categorization from NICHD, NHD. So each network database, they have categorized based on their own unit protocols. And these are the broad guidelines which you can follow. There's the babies who are less than 1000 grams, less than 28 weeks, who have morbidities like BPD, NEC, IVH, perinatal asphyxias, who are severe asphyxiated, major surgical conditions, severe IUGR babies, ventilated for more than 24 hours, symptomatic hypoglycemia, seizures, meningitis. We all anticipate that these babies can have high likelihood of delays, so they need to be put under high risk babies. The next category can be moderate and mild. Mild are the ones who are actually having a very low birth weight. Simply being a low birth weight predisposes to developmental delay. Mild HIEs, transient hypoglycemias who responded to feeds, suspected sepsis, jaundice who required phototherapy, and milder grades of IVH. These can be put into milder risks, who can be followed up a little less frequently. This is again another category of risk factors given by our own Indian consensus guidelines. They have also divided more or less in the same way. So the care which should be provided is a severe or a moderate risk of a baby should be actually followed up in a comprehensive developmental clinic or a child developmental clinic with a pediatrician who has a team of members to detect the adverse outcomes early. Purpose, as I said, there are many injuries after meningitis, after jaundice, which are actually perceptible to early intervention, and there is a neuroplasticity which is there, which can reverse the injury. The baby can be normal actually in terms of gross developmental, and to minimize any sequelae which are there, so that the disability adjusted life years is not there. The baby is able to do his own work at least when he grows up. So how frequently should we do it, and till when? So the routine developmental surveillance for low risk babies, considering the logistics and the practicality, we can follow up till 2 years of age. But high risk babies, they need to be followed up till school year 5 to 6 years, and also prolonged till 10 to 12 years. So that is the protocol. And what is the checklist? I suggest that one should have a checklist like this in our OPDs or in our high risk clinics, where age should be there, at what age he should be called up, and what are the parameters which we should be seeing. So one is general health or the general examination, where we all see the general examination, vaccination, the growth, the head circumference, any anomalies which can be detected later, nutrition and supplementation, the proper developmental outcome which should be seen in some babies who are high risk, the complete detailed developmental assessment, and the special senses should not be forgotten, which is hearing, vision, any other early stimulation which we need to know, or early learning interventions. So these are the categories which should be there for the ready reckoning in our OPDs, and the age at which you want to call the baby based on the categorization which we have shown. So the broad guideline which we follow for timeline which we follow for follow-up is within the first 72 hours, 48 to 72 hours, we have to call all high-risk babies to see how he is being adapted at home regarding the temperature maintenance, feeding, general well-being. So that is there when we call them the first time, 72 hours after discharge, and every week possibly, ideally, till the baby becomes 2 kg, around 2 kg of weight. And then we link it to the immunization schedule 3, 6, 9, 12, 18 months. And a regular follow-up should be compliant. You should look at the babies, the residents, the parental compliance, and then you should advise them at least 3 to 6 monthly follow-up for the first 2 years. After 2 to 3 years, what we did in our various CDCs was we used to follow them at least annually. So I showed you the checklist. So these are the checklist again which should be followed, and for nutrition we follow the IYCF guidelines or any international standard guidelines to give them the complementary feeding. So how should we assess? I have given you the parameters of assessment. To how should we assess it? We should have a comprehensive child developmental clinic, and when I was at Safdarjung Hospital during 2021-22, immediately after COVID, we developed a comprehensive CDC where we had limited space there also, but we tried to divide as per the domains. Like as soon as the baby came, there was a room where where a nurse or a postgraduate did the anthropometry. Then we had one room for tone assessment, which we did by Hein. Then the third room was a comprehensive play area where we did the detailed developmental assessment of the babies who showed some delay in the screening by Bailey assessment. Hearing and vision room was separate because for hearing we need a sort of soundproof room. And of course data is very important. We need to have a data management. We need to have a record of the babies who have come to us and what are the interventions which we are prescribing to them. So we also had a data monitoring room. So before we call them for the follow-up, before discharge, what can be done? We all know before discharge anthropometry we take, but make sure that head circumference is taken properly and accurately. The staff and your residents are trained in taking the head circumference. That's the most important and the simple tool. And a detection of microcephaly or plateau of the head growth, it may actually predict the future developmental outcome. So we see what are the outcomes at the time of discharge, which you can see whether the baby can develop CP, cerebral palsy, or developmental delay. Any abnormal tone detected, it increases the risk of CP by 12 to 15-fold. If the baby does not develop cry for more than 1 day, good cry, 21-fold risk of CP. Weak or absent suck in the first 2 days, 48 hours, it has a risk of 14-fold. And he's not able to suck, therefore dependent on tube feeding, again 16-fold risk of developmental delay. Diminished activity, 19-fold. So now the various domains. So the first and the foremost which a pediatrician or a neonatologist is scared is the gross developmental delay, of which tone is one of the parameters. So this is a tool which is very comprehensive. This is the graph which is called Hammersmith neonatal examination. But once you are trained, or once a person is practicing it regularly, you can do the screening in 10 to 15 minutes. It's not a screening, it's a tone assessment in a proper way, and you have to score the truncal tone, the axial tone, and there is a score chart on the basis of which you score it. And if you can get a person who can do HNNE at the time of discharge and at your follow-up clinic, then actually you can predict the risk of delay and early intervention. So you see there is a cutoff for HNNE, there is a cutoff score, and for preterm babies a score of 26 or more is expected, and for term baby at 2 weeks of age a score of 31 is expected. So this is one of the objective criteria. If possible, if you can get someone who can do HNNE, it's good to have a score, an objective score, which will tell you what's the risk of CP or tone abnormality in this baby. And this HNNE can be then followed up in the infancy period as HINE. It also has same sections and same form, and the scoring is also there. So what we did was we actually started doing it. Of course, in the initial period it takes some time to get used to it. It is a time-taking procedure of 20 to 25 minutes per baby, and may not be possible for a busy OPD to have it, but it's a good tool to detect the tone abnormality. Another simpler tool which has lesser parameters, which you used to do during our training times also, is use of Emil-Thiessen tone assessment. You can have simple figures like this in your OPD chart or in your case file, and you can just mark the posture of the baby in which he is presenting in. And Emil-Thiessen has a lesser parameters and lesser, it may take lesser time, lesser angles to be assessed in the Emil-Thiessen tone assessment. Another grossly seen parameter is, which you can see just when the baby is lying down, and it is an upcoming tool, is a general movements assessment, which is by Prechtel. And this is the chronology or the course of general movements which take place. A normal term and a preterm baby can have some body movements which change its pattern. So fidgety movements is important one, and if the fidgety movements are present at 4 to 6 months, that means the baby is doing well. So this is another tool which can be used in your OPDs, and it is a rapidly detectable thing which can be done only by visual examination, and it also has a good predictability. Compared to HINE, even general body movements has a good prediction for cerebral palsy at 3 months, 6 months, 9 months and 12 months of age. Now we come to the proper developmental screening. So proper developmental screening, we can use a number of tools. I think most of you are aware of it. There are some Indian tools and international tools. This is the most common one used Trivandrum development screening chart. The lower limit shows the centile, 5th to 10th centile, and the upper limit shows the 90 to 95th centile. And if it crosses the lower one, that means, it is towards this side, that means he has still not achieved this milestone. So that becomes a red flag. So it's easy to see, no need to remember the milestones, and you can just plot it as per the age of the baby and plot against it the milestone which is there, and you can use it in your practice also. And this is one of the charts for 0 to 3 years, 3 to 6 years. So these are the charts which we are using, most commonly we are using them. Internationally, there are a lot of screening charts, Denver, Bailey, parent evaluation, age and sexes. These are a little complicated, or even we are not trained, but we use Denver or Bailey's sometimes. TDSC is the one which we are using. So this is the Denver tool, which takes less time, 10 to 20 minutes, and it can detect whether the baby has some red flags or not. So that can be used. I am sure you must have all seen this. This is a TDSC is a little simpler one. This is the international one, and it has a reasonable sensitivity and specificity. The range is very vast. So any of these two you can use to screen the milestones as a snapshot. These are just for the completion's sake, that you should have a developmental specialist to do all these things, ages and stages questionnaire, the autism tool which is there. You should have a developmental specialist to do that, because we may not individually get time. But don't miss, as a pediatrician and neonatologist, the vision and the hearing assessment. And the first and foremost of importance is ROP. No matter when the baby comes to you, where the baby has delivered, where he has been provided the NICU care, if he comes to you within the range of the ROP screening, please do screen them. And even 4 to 6 months after discharge, if it is the first ROP screening, you should be doing it. For proper visual assessment, these are some of the guidelines. Clinically, how you can see whether the baby needs some visual test. So at birth, he will follow a moving target. 3 to 4 weeks, he will try to fix. 4 weeks, he can follow till a particular angle, 90 degrees. By 3 months, he goes up to 180 degrees. And by 6 months, he will position to see the objects. So this also you can have a ready reckoner, so that you just detect while examining the baby, yes, his vision is okay or not. So that can give you some clues. And if you get a warning sign from the parent or from your general examination that his vision may be affected, you can use the proper Teller test. Again, hearing ke liye also, this you have some guideline that he should be, there is a Murphy's sequence. So by 6 months, he should be able to turn toward the sound through a curving arc. So this also you can keep it for your ready reckoning, so that while examining the baby itself, you can see whether he is hearing properly or not. Of course, you have a diagnostic test or a screening test of BERA, which an audiologist would be doing. There are very many tools for language assessment, like LEST, autism tools, like I said, M-chart, and better to have a developmental specialist with them. Complete assessment of development will take time, because the baby may get irritable, the baby may cry, the baby may get cranky. You should have a play area to do a complete Bailey assessment, which is important, but a trained person should be doing it. A list of assessment tests is there, but Bailey 3, Bailey 4 has come up now, so that is the one. We have another scoring for walking and for tone assessment as the child grows up beyond 2 years, which is the GMFSCS score. This also we can score objectively. There are a number of intelligence tests, and this I have like to just try to summarize it. What all tests to be done at what all age. So 40 weeks corrected age, 3 to 6 months of age, you should be able to do tone assessment, developmental screening, and developmental milestone screening. 7 to 9 months, again tone assessment, Bailey and language assessment. 12 months language assessment, 18 months tone, development, language, and a functional motor assessment in the form of GMFCS. Don't forget that it is, we all know, and you all are experts in it, that once you have done something, examined a baby, do not forget to counsel for the wholesome, as a holistic thing, that you should be looking at the nutrition as per the standard guidelines. We have a good MCP card, and we have a good IYCF visuals which are there. Advise them about the complementary feeding, immunization, don't miss that, and don't miss to tell the danger signs to the young infant. I think that finishes the overall holistic visual follow-up of the baby. Thank you so much.
Thank you, ma'am. Thank you for enlightening us whom to follow up, how to follow up, different tools like HNNE, HINE, how to measure tones in 15 minutes, how to screen. So very well explained. One friendly question, ma'am. In first 6 months, how many these graduates called, they come in the follow-up? Any data? I think only 50 to 60%
Yes.
baby came, and most of the parents thinks after a few months, my baby is okay, why should I go to the doctors? So this may be the reason, but actual problem sometimes came very late. At that time, rehabilitation center or multidisciplinary center, these type of centers we are very lacking, especially in the Bihar and all these type of states, very lacking. So how to promote these type of centers, and telephonically sometimes we go for the follow-up, your child was admitted here and we want to see your baby to examine. So anything other than telephonically, any programs, you have any idea?
DEIC program is there, sir, District Early Intervention Center, in which all the centers are linked with the Early Intervention Center, and they are supposed to recruit a child psychologist, a developmental specialist in it, along with an audiologist. But I agree it's a big challenge even in Delhi. In tertiary centers, our follow-up rates are 60 to 70%, mostly because they are migrants. They go off to their hometowns after delivery, and it's difficult to call them. Only thing we can do to call the parents back is to give them a visual picture of what's the risk of their baby. If it's really a high-risk baby, we should be telling them that's a red mark, putting a red mark on the prediction of the CP chart, and then giving it to them that he may appear grossly normal, but then even minor flaws in the neck holding and all, somehow pictorial, if we give them the risk, then perhaps the follow-up rates can be increased. And regarding the government programs, DEIC is one program which is there, which can link the follow-up with the intervention. That's there. But implementing is a challenge.
So
it is a challenge.
we need to improve the number of cases that came to the follow-up. So basically some programs, doctors are also busy, very busy. So still focusing on this.
Yes.
So DEIC has started in Bihar as well. So we had a center at NMCS, District Early Intervention Center, where all the department people like orthopedician, ENT, eye, pediatricians, neurologists, they are supposed to be there. And this has also been started in Bihar. Okay. Yeah.
वो sustain करना मुश्किल हो रहा है sir, even.
DIC is running in many of the government hospitals, but the problem is because it is a multidisciplinary
Personnel
approach.
are not there.
It involves the not only pediatrician but orthopedician,
Yes,
ophthalmologist,
yes.
speech audiologist,
Speech therapist also.
Yes, physiotherapist, and assessment is a very big challenge, and it's not only a single man approach. It should be a multidisciplinary
Yes,
approach.
intervention is a challenge.
Yeah.
Executive.
So any question from the house? So thank you so much, ma'am.
Thank you.
Thank you so much.
Thank you, ma'am. Thank you, sir. I will request all the chairperson and ma'am to please come for memento distribution. I will request Alka ma'am and Neelam ma'am to please distribute the mementos. Moving on next, there is slight change in scientific session, and मैं माफ़ी चाहता हूँ उसके लिए, लेकिन मुझे मजबूरी है मेरी. तो next session, I will ask Dr. Ashwini Singhal sir to please come on the dais, and for chairing that session, Dr. Avinash Sahai sir and Dr. Amit sir. Dr. Avinash Sahai sir is the HOD in BIHAR, Netaji Subhash Medical College, BIHAR. Dr. Amit is the Associate Professor, IGMS.
Yeah, sure. I understand.
Good morning, everyone. So today we have none other than Dr. Ashwini Singhal sir. Sir is consultant neonatologist at Sapling Hospital, Ludhiana, and sir has done DNB neonatology from AIMS, New Delhi. And sir is a well-known figure in the area of QIs, prenatalology, and medical legal issues. So looking forward to your presentation, sir. Over to you, sir.
My thanks to organizers and the chairpersons for having this opportunity to talk to you on a very important session. Everyone discusses, but usually gets lesser importance in conferences. I really don't know why. Okay, before I proceed, I think it's a common to beat the law, know the law. There is no other way. So this postgraduate diploma in medical law and ethics I did from Bengaluru. It's an online thing. I think this should be mandatory for almost everyone who wants to learn a bit of law. This is a bit of law. I'm not saying do LLB, all of you, but do this postgraduate diploma, a wonderful course. Just an introduction to law and medicine. So, being a neonatologist is very risky. I have just give me the bell at 15 minutes. I'll stop. I want to answer 5 questions rather than take 20 minutes to talk. Why is it risky? Courts and judges treat babies with enormous sympathy, and that everyone does. anyone who's human would treat babies with sympathy. They are the first ones to be rescued in any mission. So do courts. So any damage to babies, any death would be treated with sympathy. Common problems, and we've learnt in the previous session, common problems can lead to severe long-term injuries. That's the problem. For elderly, that may not be true, but simple mistakes and long-term injuries. And if you know how the damages are calculated, the number of years that baby has to live would determine the damages in today. So if that baby is expected to live for 80 years and the baby is having some damage, we pay for years. Opposed to for the adults, I am 50, you have to pay for only 30 if there is negligence in my care. Few men with meningomyelocele filed a case against the doctors that my mother was not counseled properly, otherwise she would not have given birth to me, and actually won the case. In UK it works like that. So after you attained majority, you filed a case, you won it, 21 years. Thankfully there is no precedence in India. I'll forget it. Now coming to some of the specific issues, I'll just deal. A 26 weeks baby is born in your hospital, dies of prematurity related issues on day 3 of life. Parents accused of lack of facilities to handle such a small baby, citing international guidelines. Now, what will you do in such a situation? I'm talking of standards of care. Now, dealing with such patients, we need to understand, in a court of law, you will have to show competence, past experience, how many 26-weekers you have handled. You can say, I did not handle any 26-weeker, but did we tell the parents कि मेरे यहाँ पे तो 26 हफ्ते का कोई भी बच्चा बचा नहीं था, आप कहोगे तो मैं ट्राई करूंगा वरना नहीं करूंगा. And that is what needs to come uprightly. We do that. We did that for a 385 grams baby. I said, none of have survived, not even one in India. You want me to work on this baby? I will work. We worked, the baby survived for 4 weeks, but then we did that on video. Yes, this is the chance of survival. So be truthful to the patient. Second is accreditation. Accreditation with... Precisely. Some patients will say, I want you to handle this baby. The international guidelines are this, the national guidelines are this. I have not had a baby who is less than 400 who survived. You want me to work, I will work. There may be less than 5% chance of this baby surviving. Fair enough. We have been upright. And this happens, let's forget neonatology bit. Now, the same thing happened in Ludhiana. In a small nursing home, the patient said, you do a Whipple's. He said, we don't do Whipple surgery here. He said, Doctor साहब आप कर लीजिए जो होगा मैं देखा जाएगा मैंने medical college में नहीं लेके जाना. Fair enough. Now, I am talking of 400-gram baby. The same thing could happen to a 26 weeks or 27 weeks baby in a SNCU. Don't 27 weeks baby survive in SNCU. Some of them do survive. And patients can say, you continue working on the 27 weeker in a SNCU. But we give my data. कि मेरे डेटा में तो नहीं है पर पड़ोस के SNCU में 27 weeks से 2 बच्चे survive किए थे पिछले साल में. So we can work on that. The question is being truthful. Accreditation helps, and you can have an NNF accreditation, which we have. I have put my data in public domain. That मेरे यहाँ 26 हफ्ते के इतने बच्चे survive करते हैं. Be positive to put that on the notice board of the hospital. Let us be truthful again. Okay, this was a curious case. Can someone suggest what happened? A low birth weight baby admitted to NICU gets late onset sepsis. Parents who are doctors say this is hospital acquired infection, although we say it is healthcare associated infections. Is the hospital responsible for HAIs? Yes or no? You can't be neutral. In law, you cannot be neutral. I don't see any hands in either yes or no. Yes, they are. And this went against the hospital. National Commission held that hospital liable for a patient who develops infection while hospitalized. Now, first thing is use the correct terminology even if when you're discharging. Don't write hospital-acquired infections, write healthcare-associated infections. Now, what can you do for that? Remember, I don't know what defense the hospital provided. Also remember the sympathy factor for babies. But you need to put in your housekeeping routines. The incidence of neonatal sepsis in your ICU and the national benchmarks or the international benchmarks. If you can satisfy the court that this is a normal complication of caring for a small baby, you are not at fault. But if 100% of your babies get antibiotics, I'm sorry, who's going to save you? If 100% of the babies get antibiotics once they are 14 days of old, then there will be no justification. Then you are not running a good neonatal ICU, then you are responsible for HAIs. So, what helps? A good record keeping. कि मेरे यहाँ पे दिन में 3 बार पोछा लगता है, मेरे हॉस्पिटल में every equipment daily clean होता है. Do we have a record of that? That is one. The processes, and second is the outcomes. I always talk about quality, 3 things. The one is infrastructure, the second is processes, the third thing is outcomes. And we need to have data for all 3. We need to have data for all 3. हमारे हॉस्पिटल में GDA ही नहीं है 24 घंटे, and we say we clean the equipments. Who's doing that cleaning? Third issue, a term baby discharged home after 3 days of birth. Now this is between government and the private sector. Child diagnosed to have congenital hypothyroidism at 6 months of age. 6 months, still early. Some of them are diagnosed at 2 years, and many senior people would know that. Parents are furious neonatal screening was not either advised nor performed. Are we liable? But do we do it in all SNCUs? Okay, we said yes. That means the doctor at SNCU should also be liable. Are we doing thyroid screening? Precisely what I am saying. Precisely what I am asking. There are no government guidelines. Government doesn't do it. Government doesn't do it. Lady Harding Medical College doesn't do it. Is a private hospital liable? Answer is yes. I am sorry. You are judged at a different level. You are judged at a different, if you are charging fee, then you are perhaps judged at more national or international levels. The same thing happened for aneuploidy screening. I know of that case. Baby was Down syndrome and the parents said, you did not do aneuploidy screening. I have some obstetrician sitting here. Is that justified? Answer is, we at least advise. Whether they do it or they don't do it, that is their choice, but we at least advise. What are the common things? Well, there is no limit to that. You can say fetal echo भी advise होनी चाहिए थी, but no. अगर एक anomaly scan नहीं advise किया गया during pregnancy, that is deficiency in care. Whether that is done in the government hospitals or not is not the case. I am pretty sure primary health centers में नहीं होता. जब आप government hospitals की बात करते हैं, do we compare ourselves to a primary health center or an All India Institute of Medical Sciences? So if government facility is offering the test, do it in the private. Absolutely, there is no escape out of it. मुझे 3 minutes और, I'll stop after that. If government hospital is not, and you think it is vital, do offer it to the parents. Do offer it to the parents. Be that hearing screening, or be that a CCHD screening, a critical congenital heart disease screening, or be that a thyroid test. Same thing about jaundice. At least in the discharge summary, mention what is the level of jaundice at discharge. Not mentioning the level of jaundice in a discharge summary means you have not assessed it. Not documenting is not done in law. Parents of a 2-year-old child with cerebral palsy accuse the hospital and pediatrician of negligence and deficiency of care. Baby born 29 weeks, parents spent around 10 lakhs. That is the worst part of it. Their contention is, had they been informed of the risk, they may not have continued the treatment. What do we do? How to obtain this consent? That is the question. And this is going to come in 2 to 3 years, not immediately after discharge. Parents are going to come to you. Communication and documentation of communication. इंडिया में इन्फॉर्म्ड कंसेंट का मतलब क्या होता है? पेरेंट्स हैव बीन इन्फॉर्म्ड ऑफ द कंसेंट. The best thing in very high risk babies is to have a audio visual consent. And I'm pretty sure about this. अगर आपको बहुत high risk, for all 24, 25, 26 weekers we have a AV consent. Problem in India is that parents are illiterate, the consents are in English, parents are under distress. जैसे जी हमें तो कागज दिए थे साइन करने के लिए, हमने कर दिए, कंसेंट तो नहीं है. एंड यू कीप ऑन प्रूविंग इन द कोर्ट ऑफ लॉ कि हमने सारा कुछ एक्सप्लेन किया था. ऑल्दो उसकी कुछ वैल्यू है, ये नहीं कह रहा हूं कि कुछ भी वैल्यू नहीं है कंसेंट फॉर्म की. बट जब हाई रिस्क कंसेंट होता है ना, रियली हाई रिस्क, डेथ ऑन टेबल का कंसेंट लेके आप प्लेसेंटा प्रीविया की सर्जरी कर रहे हैं, तो फिर आप ऑडियो विजुअल कंसेंट कर लीजिए. समझा सर? क्या हिंदी में है? हिंदी में है. वो कहेगा मैं तो बच्चे का चाचा तो आया था, पापा को तो एक्सप्लेन नहीं किया. पापा कहेगा मेरे को तो हिंदी पढ़नी नहीं आती इतनी, इन्होंने तो वैसे ही साइन करा लिया. द क्वेश्चन इज, court is sympathetic towards the patient. Remember this always. We need to safeguard ourselves. Yeah, sure, Amit.
So that he can never say that it was not told. And some witnesses also should be there. So normally what I do is, when such a patient is there in which I say, like अभी हम बात कर रहे थे NEC short bowel, तो सर्जरी के लिए लेके जाना है एक प्रीमेच्योर बच्चे को. So I have 2-3 patients who are there as well. You may say that confidentiality is at stake when it is done. So just as a witness, you should have few people that okay, this was counseled. That is one thing. And repeated counseling is also important. हमने एक बार बता दिया भी ये बच्चा ऐसा है. अभी मेरे साथ एक हुआ 26 वीकर, उसको ग्रेड 3 हेमरेज से 3rd डे पे होगा. आई सेड डोंट गो फॉर एनी मोर ट्रीटमेंट, एंड ही सेड कि करना ही है. 17 ईयर्स बाद उसके वो बेबी हुआ था, एंड इट वाज अ 4th सिजेरियन. उसको 10 साल से IVF ट्रीटमेंट चल रहा था. सो उनको तो हर कॉस्ट पे चाहिए था. मैंने कहा इसको ब्रेन एबनॉर्मलिटी रहेगी. उसने कहा हिले ना, हाथ पैर ना हिलाए, पर मुझे बच्चा गोदी में चाहिए. हाँ, वो माँ के वर्ड्स थे, बच्चा हाथ पैर चलाए ना चलाए. मैं सोचूंगा कि मैंने कहा 10 लाख तक खर्चा आ जाएगा, 10 लाख का खिलौना लेके जाऊंगी मैं डॉक्टर से. तो उसकी
दैट इज ट्रू.
बार बार अब उसको शंट डाला बाद में. अब वो फिर उसका MRI कराया, उसके अंदर उसको सिस्ट आया. तो कहता डॉक्टर साहब इसके ब्रेन में दिक्कत नहीं जाएगी.
वो बाद में भूल जाते हैं, बाद में they don't remember this. And audio visual is not very difficult these days.
Audio visual पे problem ये है कि when you want to search it, it is never found.
No, the question is,
वो हुई थी, वो कहाँ हुई थी?
नहीं, वो उसका तरीका ये ही है. एक हार्ड ड्राइव बनाइए, उसमें UHID नाम से सेव कीजिए और उसको 10 साल पड़ी रहने दीजिए. या एक CD बनाइए, उसमें डालिए और उसको पड़ी रहने दीजिए, वो सेव हो जाएगी.
एक हॉस्पिटल में ना there are at least 30 audio visual stations. अब आप हर की सेव करके NICU की सब निकाल के मैं अलग रखते चला जाऊंगा, वो फिजिबल नहीं रह जाता.
आई एम सॉरी, आपके पास 512 GB का फोन है, उसमें रिकॉर्ड कीजिए, उसको अपनी हार्ड डिस्क में लगाइए. वो
फोटो से भर जाता है. वो आपकी फोटो से भर जाता है.
आपकी फोटो से भर जाता है. उसको निकाल के हार्ड डिस्क में डालिए. आई एम सॉरी, यू हैव टू डू इट इफ यू वांट टू सेव योरसेल्फ. देयर इज नो. दिस इज द लास्ट स्टोरी and I'll take questions after this. Your parents live in a small tier 3 town with little medical facilities. One of them has a chest pain taken to a reputed doctor in the town who believe is a cardiologist, as heart specialist written boldly. ECG done, streptokinase administered. You arrive on the scene and patient is shifted to a higher center, and you are told this was a fit case for primary angioplasty. What do you do? मैंने कार्डियोलॉजी जानबूझ के डाला है इसमें. No, what the issue is here? The issue is heart specialist. Issue is who is a neonatologist. I'm sorry, I've seen many talks since yesterday and everyone claims to be a neonatologist. Please, for your own sake, do not write neonatologist at least today. It may have been okay 20 years down the line.
what is the NMC guideline? RMP shall display as suffix to his or her name only NMC recognized or accredited medical degree or diploma as provided in the nomenclature of regulations and listed on the NMC website. Now, if we cannot accept a MD medicine as a cardiologist, neurologist, endocrinologist, or whatever, we should not be accepting a pediatrician as a neonatologist written there. I am not saying pediatricians cannot treat newborns, and I was having a discussion with Dr. Amit yesterday also. Pediatricians can very well treat newborns as much as a MD medicine can treat angina or hypertension or everything, or even a stroke. But saying that I am a neonatologist puts you in a soup, and that soup is continuing. Many of you would be knowing in the national capital. So writing yourself as a neonatologist puts you at two risks. One, you are not, and this is violation of the rules. Second is, now you are being judged to the level of a neonatologist. Then you cannot say, मैं MD pediatrics हूँ और मैं neonatology के level की care नहीं provide करना चाहता. So there are two problems in a court of law. So it is better not to write it. Yes, go ahead and treat all children, all newborns. The ones who are recognized by the NMC, yes. No, मेरा question heart specialist था. Who can write a cardiologist? Okay, answer me that question. You'll get the answer to your question. Who can write himself as a cardiologist? And who can write himself as a neurologist or an endocrinologist? Let us move further. The question is, we set some different standards for ourselves and we set different standards for others. Why? Why MD medicine should have a different standard and MD pediatrics should have a different standard? It should not. At the answer you are not able to give. Should MD medicine write himself a nephrologist? You are not able to give. Should MD medicine write himself a nephrologist? Leave the cardiologist bit. I'm done. This bit. I'm done. I'll just go through one slide. This is the last one. A case in the Supreme Court on ROP screening not been done. A case in the Supreme Court on ROP screening not been done. Just read the red things. Entries not recorded. The red things. Entries not recorded in the same sequence. Date is mentioned in a different column. Date is mentioned in a different column. No time of the ophthalmological examination is written, and do not mention the dilatation of the pupils. Now, these were the observations of the Supreme Court to say that ROP screening was not done while in the hospital because the doctors tried to tamper with the records by inserting the ROP examination after the baby was discharged. But I have put this slide just to show that yes, there is negligence and the law will find it where the negligence is. जब हम बाद में मॉडिफाई करने की रिकॉर्ड्स कोशिश करते हैं तो कहीं ना कहीं भूल जाते हैं. अब आपने ट्रीटमेंट चार्ट पे डायलिटेशन के ऑर्डर्स नहीं डाले हुए तो वो दवाई कहां से आई? या आप इंडेंट करते हैं या पेशेंट से मंगाते हैं. I'll take one or two questions.
Such an eye-opener the lecture was. The message is loud and clear. Don't be fearful, but definitely be careful. So,
thank you, sir, for giving such a nice lecture on this very important issue. Two things which you have said. One is a malpractice. Another is a normal practice. In Bihar, we are saying this is a very, very common problem we are facing. खासकर माल प्रैक्टिस वाले तो बच जाते हैं. The person who is doing a real practice get into the clutch. So we should follow what you have said. Thank you.
Thanks again.
Questions any if we have.
Thank you.
Thanks again.
Questions any if we have.
Do you have any comments or questions? I think we just discussed it along the way. Any comments or questions? I think we just discussed it along the way.
Okay.
Thank you, everyone.
So we conclude it. Yeah. Thank you. Okay.
Thank you, everyone.
So we conclude it. Yeah. Thank you.
Thank you, sir.
Thank you, sir. I will request all the chairperson and the speaker to please come for memento distribution. I will ask Vinod sir. Sir, you all know कि कानून का हाथ डॉक्टरों के साथ नहीं है. So medical legal we should know. And moving on next, we have the next talk of Dr. I will request Dr. Amit Upadhyay sir to please come on the dais. And for chairing that session, Dr. Santosh Kumar Singh sir from Motihari, Dr. Rakesh sir from Motihari, Dr. N.P. Gupta sir from Darbhanga, Dr. Anil sir, Betia, Dr. Vinay Ranjan.
अरे कुछ नहीं होता एकदम फर्स्ट क्लास मस्त एकदम बढ़िया मजा आ रहा है. Good morning everybody. It's a wonderful audience and I was still trying to get over wonderful sessions which I have heard from Dr. Pratima.
Thank you, Dr. Chandan. Respected the speaker of this session, Dr. Amit Upadhyay ji, needs no introduction. He is the in charge of pediatrics and neonatology, New Tema Hospital, Meerut. He is presenting, adorning the post of Secretary General of NNF, Central NNF, and he going to discuss a very important topic. And I request Dr. Amit sir to please start your deliberation.
Thank you, sir. So, neonatology SNCU. A lot of neonatology is still in the OPD practice. So OPD practice is if not more important than ICU care, because most of us may not be doing ICU care, but we continue to do our OPDs. So why neonatal visits to OPD are important? I remember in my DM days, visits to OPD are important. I remember in my DM days I would loathe going, so I always wanted some substitute to be there so that I can just work in the ICU. So I was a very ICU type of guy, and but now you realize that OPD you need, if not nothing more than for seeing happy faces. And in ICU you often see very grim faces of serious babies and parents. So it's important for, as Dr. Pratima said, follow-up of high-risk neonates discharged from a unit. You need to see them, what is happening to them. So OPD is important over there. Referral from other centers, where do they reach? They won't be reaching to your ICUs. So you need a OPD chamber where you can see the reports of babies admitted elsewhere. You can see the babies who are coming over. So mothers come over for many benign problems, like ये सर यहाँ पे skin black है, कि यहाँ पे उसके teeth है, उसको यहाँ पे eyes में redness है. So sometimes even emergency symptoms, babies are brought to your OPD. So you have to be very vigilant and listen to, if the mother is complaining about something, you need to listen to her. And if the mother says कि दूध नहीं पी रहा ठीक से, so बच्चे शुरू में दूध नहीं पीते हैं, सोते जाते हैं, so हम उसको मान लें कि convince करके भेज दें, and he is having sepsis, so that is not good as well. So newborns may be normal at birth and we can send him to the bedside, but on first day itself or second day, third day, they develop problems like Dr. Ravi Sachan said, jaundice, or they may develop cyanosis. He was normal at birth, pink. We shifted him to mother. On third day, he developed cyanosis. He probably had a congenital heart disease. So he would again be brought to you in the OPD only. So the approach to a newborn baby in OPD is taking an important history. Taking is very important, and we have to ask about if the baby comes with fever on first or second day. So you need to ask history about, was there any leaking EV or any other associated risk factor which can lead to early onset sepsis. They should be asked. Term babies having fever for more than an hour is significant. So you need to ask about history of say oligohydramnios, maternal hypertension, because late preterms, babies born at 34-35 weeks, they are high risk in a sense that they are not admitted in NICUs. They appear big, but they are actually not big. They are not full term. 1.9 kg will not be admitted in NICU, but he is very prone to develop hypoglycemia, hypothermia, jaundice. So who diagnoses them? So how often are we screening a 1.9 kg babies in our maternal ward? Do we screen them for hypoglycemia? Oja sir, आप इतने railway hospital में ऐसे, so what proportion of babies who are say 1.8 kg, 1.7 kg ये nursery में admit तो नहीं होते हैं, so उनको screen करते हैं आप लोग regularly for hypoglycemia?
Then we do not admit them. But if suck-swallow coordination is not developed well, then we do admit and for observation.
No, admission के लिए नहीं, screening for hypoglycemia,
yes,
temperature,
we do screen with regular screening protocols of 0, 6, 2, 6, 12, 24, 48 hours. लेकिन अगर 3 readings 50 के ऊपर अगर आती हैं, तो we stop screening.
Great, thank you. So Dr. Oja, I would like to say, is my elder brother, and मैं उनकी वजह से ही आज यहाँ खड़ा हुआ हूँ. He has been my guide and coach from MBBS days, and I am always indebted to Dr. Oja for that.
Thank you.
Thank you, sir. So you need to take perinatal history, neonatal history, and after taking this history and examination, you need to assess, you have to ask some questions, look at the baby. बच्चा ठीक नहीं लग रहा कि ये नैक जो एक डॉक्टर्स की होती है, that is what differentiates a good doctor from a okay doctor, कि वो उसको 12-24 घंटे पहले बता देगा कि ये बच्चा ठीक नहीं लग रहा, उसको ये चाहे ना पता चले कि हाँ क्या abnormality है. So but certain doctors do have a knack to say कि ये ठीक नहीं लग रहा, और आपके पास बच्चा पहुंचेगा, आप कहोगे यार इसको रेफर क्यों किया सर ने, तो सर वो कहेगा कि अमित मुझे ये ठीक नहीं लग रहा था बेबी, I couldn't pinpoint why he was not looking okay, and then over next 12-24 hours you would see that some abnormality has appeared. So that mild tachypnea which was there in the range of 60 to 64, 65, जो कि initially हम लग सकता है कि normal है, but they would worsen with time at times. So you listen to the concern of the parents very carefully, you classify the symptoms and sign as urgent, emergent and non-urgent, and you promptly treat if required. And do the counseling. Like jaundice is the biggest, as you said, it's the bread and butter of pediatricians. So अगर first day पे कोई jaundice आ रहा है, उसने आपने bilirubin भी करा लिया और वो 6-8 आया, तो 6-8 को पेरेंट्स के दिमाग में रहेगा कि तो बिल्कुल नॉर्मल है, सर ने कहा कि वो कहेंगे कि तो ठीक हो जाएगा जी अपने आप, बट उसको काउंसिल करना, उसको बताना ये बहुत इंपॉर्टेंट है. उसको चार्ट दिखाना, जो डॉक्टर रवि सचान AAP के चार्ट दिखा रहे थे, वो चार्ट के साथ ही काउंसलिंग करनी चाहिए कि भाई देखो 24 घंटे के अंदर इतना बिलिरुबिन ये तो फोटोथेरेपी की रिक्वायरमेंट है. There was a baby who came to me with bilirubin of 10. So that was only about 16 hours old baby. Mother had RH negative, baby was RH positive. He came with, मैं कहा कि इसको तो बहुत हाई बिलिरुबिन है, एडमिट ही नहीं हुआ. He said कि नहीं, मैंने पूछा वहाँ पे और सब लोग कहते हैं कि 15 तक तो कोई रिस्क नहीं है. So I said कि this is not even 24-hour-old baby, तो exchange range के अंदर बन रहा है, but he did not get admitted. He again came on 3rd day with bilirubin of 35. And then got an exchange transfusion then on 3rd day, and then he developed bind as well. So power of convincing, as say going through obstetrician, going through grandmother, whatever it takes to convince them, but we have to convince them. Danger signs have to be told each and every time, and so in jaundice you have to tell them if the baby has a extra sole or palm, anytime you have to come back. One should write, in every newborn we see कि review with the doctor or pediatrician after 48 hours. So we always do that कि 48 घंटे बाद दिखाना आना ना आना उसकी मर्जी है, लेकिन फिर ये नहीं कह सकता कि जी जॉन्डिस ज़्यादा हो गया और हमें पता ही नहीं था, नहीं तो हम आ जाते. So advise exclusive breastfeeding to all for 6 months in OPD. That is a prime advice which should be given. This is our duty as a pediatrician to advise every family and every mother about exclusive breastfeeding. So we know what are the basic requirements. Hygiene is something which is very important for in OPD as well. Thermometers, weighing scale, they all can be, infection transmitters as well. So before putting them to another baby, we should clean them, and after using it on a baby, we should clean them again. Room should be warm, AC, cool to 18 degrees, not an optimal OPD to examine a newborn baby. And it should be comfortable to that baby. Anything which is cold to me is definitely very cold for that newborn baby. And mother and baby should be examined together. At times बच्चे का चाचा बच्चे को लेके आ रहा है, उसे पूछो कि हाँ जी माँ का ब्लड ग्रुप क्या है, फिर कहेगा मैं भी फ़ोन करके पूछता हूँ, फिर वह भी फ़ोन नहीं लग रहा. So one should always encourage that okay, next time you definitely come with the mother. So father का कोई रोल नहीं होता बच्चे की केयर के अंदर. He is the least important person in that I realized in Indian setup that father वो तो बच्चा है जी, वो क्या बताएगा, उसको क्या पता है. So what do we look for? Feeding behavior. One always, as sir pointed out, that feeding, sucking, swallowing coordination should be assessed. Respiration, tachypnea is a very important sign for everything. Hypoglycemia, hypocalcemia, ICH, they all will at some point or the other have tachypnea, even if it is mild. So counting a respiratory rate for full 60 seconds and seeing that it is noting that it is less than 60 is very important. What if it is more than 60, 62, 64 after a 1 minute count? Then IMN says count it second time, because it is a very cardinal sign. It should never be missed. So if second time count is also more than 60, then you should advise evaluation on a baby and preferably admit him or at least observe him in NICU for next 4 to 6 hours of what his progress is. Then you look at the skin variants, skin color abnormalities, umbilicus, posture. A baby who is lying just flexed in a frog-like position. Normally, sir, पीछे ज़्यादा तेज लेक्चर चल रहा है आगे से. So मैं ये रिक्वेस्ट करूँगा पीछे का डिस्कशन जो है हम लेक्चर के बाद के लिए 2 मिनट का रख लें. आगे वाले लोग भी सुन नहीं पा रहे हैं इस वजह से. Thank you. So posture of the baby has to be seen कि उसका flex posture रहना चाहिए, hip joint, and उसके पैर lying flat on the bed अगर हैं, so that is not good. That is a hypotonic baby, and that baby needs observation again, or at least counseling that something could be wrong. He could have muscular problem, he could have hypoglycemia, he could have sepsis. And so movement, as it was pointed out that practicals, your quantification and quality of movements is to be seen. So if the quality of movement is not good, then that baby is also abnormal. So in OPD, your skills are tested much more than in ICU. Because in ICU, there could be other doctors who are saying, there could be nurses who would tell, there are monitors who are telling you. But in OPD, it's only you and you who are responsible for that baby. So you are directly responsible कि मैंने tachypnea छोड़ दिया, उसने दिखाया और उसको 1 महीने बाद पता चला कि जी hypotonic था, बच्चे को कोई congenital problem थी muscular. So one should never miss out. Skin pustules, which we so commonly see. IMNCI guidelines say if there are more than 10 pustules, then it is abnormal marker of sepsis. So you have to clean them out. If they are less than 10, the management is different. If they are more than 10, your management is different. So then triaging is very important. What are the danger signs which every baby in which you should look for? That is, baby is not feels as well that the baby is not feeding well. Then convulsion. So any time there is a convulsion, this baby definitely needs admission. There is no role for OPD management of a baby who has convulsion. He would need investigations for the causes of seizures. He would need management. He would need monitoring. Every seizure is potentially life-threatening. So one should वो कहे कि जी ऐसी दवा लिख के जो टेस्ट होने का कि भाई किसी और डॉक्टर से पूछ लो इस चीज़ का, मेरे हिसाब से इसकी कोई ऐसी दवा नहीं है और जांच नहीं है जो मैं आपको ओपीडी बेसिस पे दे दूं. सो फेब्राइल सीजर न्यूबॉर्न बच्चे में नहीं होता कि उसको कन्वल्जन हो रहा है तो थोड़ा बुखार के साथ हुआ है, उसको फीवर और कन्वल्जन है तो पक्का उसको मेनिंजाइटिस होगी, उसको हमें रूल आउट करना पड़ेगा एडमिशन के साथ ही. फास्ट ब्रीदिंग 60 और मोर, chest indrawing, grunting, this just means severe distress is there. Fever, so this cutoff is important, 37.5 degree or above, or baby feels hot to touch. Low body temperature, both high and low temperatures are diagnosis of sepsis or markers of sepsis, less than 35.5 degree. Movement only when stimulated or no movement when stimulated. Palm and soles are yellow within 24 hours. So these are significant danger signs and one should always look for them. So jaundice has already been told. There is a Kramer index, and so based on this, if it is reaching stage 5, it is severe jaundice. It needs detailed investigation. Any jaundice within 24 hours or staining of palm and sole is more, and we should always investigate such a baby. Anytime you feel there is direct jaundice, as said by stool color which is abnormal, any jaundice which persists for more than 14 days is prolonged jaundice, and all babies with prolonged jaundice should get workup for jaundice done. Fractionated bilirubin is most important. In first couple of days, total bilirubin is good enough. But beyond 14 days, if you are doing a bilirubin, fractionated bilirubin should be done. Total, direct, indirect fraction should be tested. All babies should be, cholestasis should be excluded in all babies. Cholestasis is direct bilirubin increase more than about 1.6 milligram per deciliter, or about 16% and above of total bilirubin. AP charts have already been told. Pathological jaundice already has been discussed. So I won't discuss that. Local infection like omphalitis, they are very important. They cannot be ruled out. Umbilical infection, you would be surprised to know that it requires IV antibiotics to cure it, because it can lead to portal vein thrombosis and portal hypertension later on. So umbilical sepsis cannot be treated just by orally, and so non-urgent symptoms, they are good, like viral illnesses, some cough and cold. There is a lot of concern about cough syrups now, because many babies have died in MP and across the country recently. So patients, अब कोई भी आप खांसी की दवा लिखोगे तो patient ने, मेरे को 3 patient ने पूछ लिया अभी 2 days ago कि सर खांसी की दवा दे सकते हैं क्या, अभी सुना कि इससे बहुत नुकसान हो रहा है. So patients are very aware now, and cough syrup should not be. Newborns have no का कोई रोल नहीं है cough syrup का या जुखाम की दवा का. Nasal drops should be given only. Fever in newborn should not be taken lightly. Any fever more than 100.4 is should be advised observation and investigation. So if baby obtain investigation for fever includes taking a blood culture and performing lumbar puncture and inflammatory markers like CBC, CRP. So any baby within first month, if he has fever for more than an hour, which is more than 100.4 degree, then full workup including blood culture, CSF and your sepsis marker should be done. So that is important take home message. If the patient refuses CSF, that is fine, but at least I have advised him. That should be there. That was what Dr. Ashwini wanted to convey, and I 100% endorse his statement of counsel and document your counseling. So know the normals. Penis length के लिए बहुत एक common dadis come with कि डॉक्टर साहब, so we have to look at the penile length at the normograms and advise blood pressure norms, growth charts. Suboptimal growth is an important concern. Initially people don't look at it, but after 1 to 2, when the baby is 1.5 to 2, there cannot be a prescription without a newborn baby का prescription है, उसमें head circumference नहीं लिया. 5-5 साल तक follow up के बाद बच्चा आता है कि जी इसकी ग्रोथ कम लग रही है, और पता लगा 5 साल में उसने 50 बार लोगों को दिखा रखा है, बट एक भी हाइट का डॉक्यूमेंटेशन नहीं है, वेट का रहता है, हेड सर्कमफ्रेंस का कोई डॉक्यूमेंटेशन नहीं है. सो ये गलत चीज़ है कि हम एक एज अ पीडियाट्रिशियन, अडल्ट फिजिशियन कैन नॉट डू. अडल्ट फिजिशियन कभी भी हेड सर्कमफ्रेंस मॉनिटरिंग नहीं करेगा, लेंथ नहीं देखेगा, बट एज अ पीडियाट्रिशियन हमारे तो वी आर बॉर्न एंड ब्रॉट अप. MBBS टाइम से ही एंथ्रोपोमेट्री के ऊपर कितना एम्फेसिस रहता है सारे कॉलेजेस में, बट प्रैक्टिस में अगेन हमारे हेड सर्कमफ्रेंस नहीं रहता और हाइट नहीं रहती. सो हमें नहीं लेना, हम ना लें, बट बाहर जो बंदा वेट लेता है, पर्चा बनाता है, ही शुड बी ट्रेन्ड टू डू ऑल दिस. और जिसमें आपको कीप एन आई ओपन कि अच्छा सर कैसा लग रहा है, इसका छोटा लग रहा है तो आप ले लो खुद उसका. सो astute clinician will always look for these things. Skin and joint, we can leave that. excessive crying को कभी हमें बहुत लाइटली नहीं लेना चाहिए. पता लगा 4 बार बच्चा आया, एक बार हमने उसको आयुर्वेदिक कोई इसकी लिख दी, फिर हमने उसको कॉलिकेट लिख दी, फिर कॉलीमैक्स लिख दी, चौथे डॉक्टर के पास गया, उसने कुछ और लिख दिया, और suddenly baby is brought dead because he had a big intracranial hemorrhage because of which baby was crying. So there are signs. Excessive crying can be because of underfeeding as well. So you should look at his feeding. It could be colic. Newborns में colic incidence would be very low. वो थोड़े से बड़े बच्चों की दिक्कत है. तो अगर early he is having excessive cry, cerebral irritability is an important cause and it should always be ruled out. अगर 2 बार वो आ गया आपके पास complaint लेके कि excessive cry है और consolability. In a crying baby you should look for consolability. कि उसको लेके ना और उसको घुमा रहे हैं, क्या वो चुप हो जा रहा है, वो नहीं हो रहा ना, तो you advise admission. Because such a baby, you should, if you have a cranial sonography, then you immediately do yourself and see कि brain में कुछ सब ठीक लग रहा है या नहीं लग रहा, कहीं bleed तो नहीं है, meningitis तो नहीं है. Excessive cry वाले बच्चे जो जुखाम वगैरह के साथ आते हैं, nasal blockage की वजह से बहुत excessive cry वाले आते हैं, तो you look for common cold. और उसकी आपने उसको nasal saline drops वगैरह डाली, थोड़ा suction वगैरह किया, he would respond. Then red bottom, कि उसके जो है ना थोड़ा सा stools are more, and some babies they have ammonical stools and you know red bottom is there, that is a common cause of excessive cry. Ear eyelash falling in the eyes can be very irritating and that is a common cause of excessive cry. So these all should be excluded before we write Colimex 6 drops 3 times a day for 3 days, and before we write pedicloryl and Finargan, and so they should never be written in your prescription for a baby with excessive cry. So developmental peculiarities, hemangiomas, most babies, natal tooth, this breast engorgement, Mongolian spots, these are erythema toxicum, and so babies do come with all these problems and we have to satisfy. Epstein pearls on penis, on the midline structures it is commonly seen. So we should to know so that we can advise the parents appropriately. Hemangioma, if it is at a cosmetic region, then if it is at a region where it is it potentially fit like over the eyes, over the nares, and anal opening, so these are the places where it can cause significant problems. So we should look for that, and propranolol or beta blockers can be given for that. There are guidelines. IAP has wonderful guidelines about hemangioma which were published in Indian Academy of Pediatrics, and target dose is 2 milligram per kg, but you begin at 1 milligram per kg. But initially once you start it, you should monitor the baby for bradycardia, hypoglycemia, because beta blockers do tend to have a side effect in these things. Once you see, you should examine, because first time we are there at birth and it becomes very awkward when we don't examine for say syndactyly. It's not that we have to do something, but parents kya kare doctor sahab bataya nahi, dekha hi nahi. So one should examine the nails, fingers very properly. Never miss a anal opening which is not there. So a quick examination, all the openings, nares, mouth, anal opening, palate, they all should be. So tongue tie, unless there is forking of tongue in the midline indentation is there, it is not of any significance. Though I see some dentists, especially American board qualified dentists, are very aggressive about managing tongue tie because they feel that it interferes with feeding. Somehow that concept is not there amongst the neonatologists here, and we often सबसे ज़्यादा आता है एक स्पीच डिफ़िकल्टी के अंदर भी बहुत आता है कि हाँ जी स्पीच डिले है, कोई इसके टंग टाई तो नहीं है, उसकी वजह से तो नहीं है. सो अगेन टिल फॉर्किंग इज देयर वी डोंट हैव टू डू एनीथिंग फॉर दैट. ईयर टैग्स you have to wait till about 4 years, but ear tags tend to have a relation with renal problems. So किसी को ear tags हैं, especially multiple, you should always screen for ultrasound KUB. Ambiguous genitalia is a complex topic, but you can just not miss that. If you miss that, it is again, you will have to take help of Dr. Ashwini Singhal very soon. So this is a cause of a lot of controversy and fights, that okay, sex was inappropriately told. Preterm babies tend to have a very prominent clitoris at times, which can give an impression of having a a penis as well. So parents may feel कि हाँ ये लड़का है जी definitely, और फिर बाद में आप जो है कह रहे हैं कि हाँ जी female है. So all things should be seen and shown to the patient कि क्या है, and give a time for that to the baby. Like ये इसमें ये दिख रहा है, some parents may take this as a phallus as well, when this is actually a prominent clitoris. Newborn screening, ये भी हमारे OPD में ही रहता है. We should advise, Dr. Ashwini has already emphasized on screening for hypothyroidism, but at least G6PD, hearing screen, and now there is a CCHD, congenital cyanotic heart disease screening by a simple pulse oximeter applied to your right upper limb and done before discharge. That, you know, TGAs, pulmonary atresia, all those cyanotic disorders you can diagnose. Shock you can diagnose if HLH is going to be there. Pulses may not be picking it. Pulse oximeter will not be picking the pulses very prominently and quickly. So blood tests, hearing test, and CCHD screening. These are the screening tests we should be doing in our, or at least advise it for all our babies. So key message will be convince all for exclusive breastfeeding. Screen all babies at least for hypothyroidism. Hypothyroidism is something which will make the baby, mentally retarded for life. Irreversible damage to brain is going to happen if you don't screen for hypothyroidism. So never miss out on that. Always advise. आपके ऐसे गवर्नमेंट हॉस्पिटल में भी नहीं अगर होता है तो हम लिख के दें कि भाई जांच कराना. 20-30 रुपए की जांच है, हर मरीज करा लेगा, बाहर से भी करा लेगा. उसको बस एक्सप्लेन करना है कि इससे क्यों कराना है उसको. थायराइड क्या, थायराइड तो बड़ों को, हमारे घर में किसी को थायराइड नहीं, डॉक्टर साहब आज तक खानदान में किसी को नहीं हुआ, बट स्टिल आपके बच्चे को कराना है, उसको ये बताना रहेगा. So identify the emergency sign and symptom, review history from mother for cardinal details, look, feel and listen is very important, and record all findings carefully. Thank you.
It's really different, same phases for OPD practice and IPD practice. We see the same phases, same in happy phases and some sad phases in the NICUs. But we see your lecture, sir, apart from do the screening from the intrometry to the routine investigations, one thing we came note see here, if you do or not do, we at least prescribe the routine investigation in the baby checklist and do the thorough examination at the time of the birth. So major congenital issues or congenital screening is not missed by the same.
बिल्कुल. Keep our eyes open and full concentration on that patient. हम phone पे बात कर रहे हैं और बच्चे का exam चल रहा है, so then we are more likely to miss things. So full concentration, he is paying for it or somebody is paying for AB. So our full concentration, once our mind, hands and senses are with your patient, you are very unlikely to make a mistake. Errors happen, patient, you are very unlikely to make a mistake. Errors happen कि phone पे वो ICU में बात हो, chest tube डाल दो, इसका ये कर दो, बच्चे को आपने देख के, that should not be done.
Okay.
Thank
you, sir.
That should not be done.
Okay.
Thank
you, sir.
Excessive trend, sir. Are we allowed to prescribe phenyl oil? It was under green tick.
Probably if you think that all other causes are ruled out, then giving that with samethicone could be reasonable. Giving that with samethicone could be reasonable, especially if he is a newborn. And I believe newborns soon after birth they don't have colics, and so a few month old you can give a trial of that.
Thank you, sir.
Thank you.
Sir, one question from my
Yes,
side.
sir.
Your slide is so there is no probiotics in the colic, but there is a various paper presented.
Yeah, like Rotary and all people have come over and all do prescribe at times. So if it gives benefit to the baby, sometimes mother also says कि डॉक्टर साहब ये दवा देते हैं तो चुप रहता है, थोड़ी देर बाकी होता रहता है. So it is 5 drops for 2 to 3 weeks, and then most people would prescribe. But yes, important would be to rule out all other causes and look at the response in first 2-3 days and then see.
We have already diagnosed this is a colic pain, nothing else.
You
then what
can.
should we prescribe?
Typically I don't do prescribe these probiotics. So there are at times personal preferences as well. There is some data to suggest that you can use.
Mother का repeated complaint, बच्चा रोता ही रोता है.
The feeding and all are important issues. At times feed intolerance is also an issue. So अगर वो चीज़ हो रहा है, then getting the stool test for pH and all should be done. And at times, a lot of milk intolerance babies also tend to be crying a lot. They are also cringy babies at times. So look at the weight gain and everything.
So can we give a placebo as a probiotic?
Yes, probiotics are good in the way that they at least they are not causing harm to that baby. So you can give it.
Okay, thank you, sir.
Thank you.
Thank you, sir, and thank you all the chairperson. I request you both to come for the memento distribution, and sir, I will request Nigam sir and Bhupender sir to please assist in the memento distribution. And moving on next, we have very important panel discussion. And the moderator is none other than Dr. V.C. Manoj sir. I will request Dr. V.C. Manoj sir to please come on the dais. And for chairing that session, I will request Om Prakash sir and Vinod sir to chair that session. And V.C. Manoj sir, please, sir will call their panelists. And the panelist for this session, Dr. Bhavesh Kant Chaudhary, Dr. Ajay Kumar, Ma'am Dr. Poonam Lal, and Dr. Amrita Sinha Ma'am. We must thank both Dr. Poonam Lal Ma'am and Dr. Amrita Sinha Ma'am. There are 2-3 programs going on simultaneously with the pediatric side and gynec side also. Ma'am took all the time and came here. Thank you, ma'am.
Can you just say, okay, can you just give me the names of the, because others are only Babesh is
So, this is great to see our National President of NNF, Dr. B.C. Manoj, to take part in this NNF East Zone conference. And he will talk about the care of both the ends of the cord. The one end by the obstetrician and another end by the neonatologist or pediatrician. And needless to say that he is known by all the neonatologists and pediatricians of India, and we feel proud of finding you at this place in Bihar. And he is professor and head of the Department of Neonatology at Lakshmi Hospital, Kochi, and the National Executive Member, Neonatology Chapter of Central IAP. He had been the President of NNF Kerala, President IAP Thrissur, Secretary NNF Kerala, and he has got a lot of publications in national and international journals. He is known as a great academician and an excellent clinician in the field of neonatology, and he has got extracurricular interest in lifestyle medicine and this sports nutrition. By looking at him, you will not find any more fat in his body. You see, he's looking smart, dashing, and handsome. So, with these words, we give our president.
Sir, we are going late, so please start the panel discussions.
Thank you, sir, for the very kind words. Hello, everyone. Good morning. In the next 45 minutes or so, we would try to look at some of the practical points in a joint project that we, the obstetricians and pediatricians do, bringing up a small life into the future. Perinatology has advanced and newborn care has also advanced in similar lines. As we were mentioning yesterday, we have come from the last century when we were talking about intact survival and then intact survival to now helping the babies reach their full potential in adult life. It's a very competitive world, so even the brain potential need to be realized, and then they have to be free from all sorts of diseases, lifestyle diseases including. So then in 2014 we had the great human microbiome project, and then we started understanding the human interaction. We realized that we are no longer a single player, we are a superorganism. We have multiple gus living in our body. Actually the genetic potential, if you look at, we have 3 million genes of a gus, and we only contribute to 23,000 genes. So that is the magnitude of the gus that live and interact with us through the enteric nervous system, gut-brain axis. So as we understood microbiome, all the diseases thought process got changed, and all the concepts in perinatology also evolved. Now for us, given a choice, fetal well-being is what a neonatologist or pediatrician would want. And that is where our interest and the obstetrician's interest do merge. And that's the way it should be. So all we are interested in this session is fetal well-being, and then subsequently what happens to that fetus. I have a great array of experts here to give the obstetric perspectives. We have Dr. Amita Sinha and Dr. Poonam Lal. To give the neonatal perspective, we have Dr. Ajay Kumar Singh and Dr. Babesh. Dr. Keshav is not well. So as we are running short of time, the introduction, I'll just skip the introduction. I don't have the CVs of all the people also. So let's straight away start with a live scenario that we all face sometimes in our common tea room when this discussion comes up. A 41-year-old, these days the mothers are getting pregnant late, 41-year-old obese mother with gestation diabetes, and then it's coming, your obstetric colleague is saying that it's referred to you, referred to them at 23 weeks with fetus weighing 360 grams, history of leaking. And for them it's a very precious child. For some reason or the other, for us all babies are precious, but for them it's a very, very special child. There is a history of infertility treatment also for 7 years. Now in this scenario, I would like to hear the perspectives from our obstetric experts. So can I ask Dr. Amita Sinha, is this baby too small, or should we be, what should be our approach at this point of time?
Thank you for this question. How small is too small? This heading is really not only a medical question, but it is an ethical and compassionate decision guided by science, context, and humanity. So, first of, as an obstetrician, our duty will be to count and to understand her scenario, like she is 41 years old and gestational age is only 23 weeks, weight is only 390 grams. So then our first priority will be to manage it as obstetric point of view to prolong the pregnancy.
Excellent. So the first point is we need to prolong, even though it's precious, we don't want to deliver it
under the guidelines of PPROM, but we will try to prolong the pregnancy so that if baby comes out. Here there are many concerns like viability of the fetus. If we think about peri-viable period, this comes under from 20, if it refers to the birth from 20 to 25th or 26th week of gestational age. Here the fetus is 23 weeks gestational age. So it is peri-viable period. So first of all, I would like to treat, then I will counsel the parents regarding its peri-viability period and its viability. This period is where baby comes out of the uterus. Survival is possible, but not confirmed.
Very high risk of
very
severe
high risk
morbidity.
of severe morbidity.
So better that we don't lay our hands on
exactly.
this.
Long-term morbidities. So there are many ethical complications.
Madam,
ethical implications.
I was interested to know how is the concept here actually? How small is too small in your practice and like in the generally in this part of the country?
Yeah, how small is too small? That means if we don't want to do 20 weeks to 25 weeks. In our criteria, this is 20 to 25 weeks, and as per WHO, 20 up to 26 weeks. These are very small. And if we deliver any small baby, so we have to consider ethical implications also. Like we should balance the preservation of life versus quality of life. Only सिर्फ उसे हम जिंदा कर रहे हैं कि आप लाइफ टाइम सपोर्ट पे रख रहे हैं, that's not necessary. So we should consider all these things and talk to parents. So paternal or parents' autonomy is also one important component we should discuss. And third, limited resources for intensive neonatal ICU care in BIHAR or in rural setup. So we should also talk about that. Okay, how will you manage, if you are in periphery, how will you handle this case, how will you carry this? And though long-term morbidity is very high, if we deliver the baby, patient thinks of there will be emotional burden. And so there are many challenges and practical solutions for that. So I think we should, first we should prolong the baby, as I told earlier, and these conversations should be with patients and their parents.
Any other thought process at this point from any other expert?
Yes, from challenges, regarding
no,
challenges.
from any others?
Any other?
All right, so I think
we have practical solutions also for that. Any institute should make some guidelines for handling these type of preterm babies, number one. Number two, we should, our government side, or we should improve, the pediatrician, neonatologists should improve their neonatal. These are the practical solutions that we can handle in future, and everyone should know how to handle these cases.
Perfect. So, Madam has enumerated the whole, this thing, parental expectation is a big factor which we need to consider. What is the reality scenario in your setup, and what is the national and the global scenario? This baby, periviable, if you are going to call this, if you are going to have this delivery in this period, even internationally, the bus centers, there are 3 bus centers where this baby has a reasonable chance. That is again Iowa in US, the Scandinavian countries like Sweden, and then of course the Japan. These are the places where they have the least morbidity. Even they have pretty high 40 to 60% morbidity for these babies, depending on now it's coming down. So better not to deliver these babies at this point of time, but we don't live in a perfect world. Sometimes
we should be truthful to the patient regarding its prognosis.
Exactly. Yes.
Sometimes patient go into labor in spite of conservative management.
Exactly. So
we have to lose the baby sometimes because it's not possible to
so
23. But most of the time, if we do conservative, we have baby with leaking at 23 weeks. We did conservative treatment and they prolong up to term also.
What could be? No, I am just interested to know what could be the safe gestational age where you would reasonably like this thing. Can I ask my
33 weeks, 32 weeks
here
onward at least.
I am not asking that in this part of the country. What is the reasonable period?
I am happy with 33 weeks.
33 weeks.
32 weeks onward, the baby is safe. Like
any different opinion from the pediatric panel?
Sir, it's depend on the expertise and the level of
no, I want here the value, realistic value here.
Sir, in AIMS Patna, we are able to save 26 weeker baby onwards, sir.
So it's variable. Everywhere, all over the country, it is like that. We have state-of-the-art facility existing in a center, and 100 kilometers away, we have the most primitive, and so on. It varies actually. From 26 to 28. I think that is taking it too far, I believe.
Sir, आपने कहा लीकिंग है, ये नहीं कहा कि कितनी लीकिंग है. लीकिंग के साथ we have continued pregnancy 34-35 ये बोल रहे हैं और अगर 20 weeks में but sometimes neurological complications are too much. Sometimes neurological complications are too much.
So intact survival. Intact survival now should be the norm above. Now should be the norm above 28 weeks, or rather, I should say we should try to make it to the accepted level of 26 weeks.
As far as possible.
6 weeks.
As far as possible.
One way is, sir, patient should be transferred to. One way is, sir, patient should be transferred to optimal neonatal care center. Patient, suppose my place is Bhagalpur and there is no neonatologist like DM, So we can shift patient if possible. to
Excellent
that
point, sir. Actually, in utero transfer makes a lot of difference in the survival if you do not have tertiary care neonatal facility. This is not a baby you can manage in the periphery. Even the best of the centers, this 23, 24 weeks is going to be a nightmare. But then we have experts who manage to prolong the pregnancy until 28 weeks. But now mother has gone into labor and the expected fetal weight is 750 grams. So now, can I ask Dr. Poonam Lal, what are your thoughts? How are you going to monitor this baby at this point, and then how are you going to deliver? When and how are you going to deliver? It's mother has gone into, has abdominal pain and cannot prolong much probably.
The pregnancy is a patient is. I have to ask the patient whether he wants cesarean section.
They want.
Huh?
I am the patient. I want. I am the mother. I want.
Section, I have to consult them. Even after cesarean section, we can lose the baby because.
See, usually what the patient says, maybe I don't know about this
because
area.
during
We will do whatever initially the thing. We will do whatever. Please save the baby. This will be the initial response of the majority of the people.
In this case, it is a case of infertility for 7 years. They will want baby, of course, and sometimes preterm baby during delivery, sometimes they can undergo fetal distress. So we have to discuss, when we do cesarean section, the chance of survival is not sure. So we have to ask. Sometimes the poor patient, they want normal delivery. They want normal delivery at any cost. Even in fertility cases, poor patient, they want normal delivery. Then we have to allow the patient for the spontaneous labor. He's going into labor.
Madam, no, accept it. Now for shortage of time, let me streamline the discussion. Now we have decided to prolong as much as possible, but we know that it's not going to last for few more days or weeks. So now at this point, what is going to be a monitoring plan? And how are you going to?
We
You're
will
going
give
to
corticosteroid and Maxel.
Yeah, some interventions we are going to do. We will come to that.
If
Anything
he is
else?
going into labor, so we have to give corticosteroid and Maxel for neuroprotection.
All right. So you would some interventions you would like to do before
delivery. In the another case, another term born pregnancies. In the another case, another term born baby cried immediately after birth and presented with refractory seizures, hypotonia, hyperepilepsia, not feeding well all day 3 of life, and was in encephalopathy. Basic metabolic workup was normal. Brain imaging wasn't, which just showed ICI feature, but this patient, this baby never had any problem in the perinatal period. And so gene panel testing was sent for neonatal encephalopathy and refractory seizures. And the result was positive, showed mutations in the MOCS genes suggestive of molybdenum cofactor deficiency. Treatment was started with enoxaparin, and there was a dramatic improvement. Seizure stopped, the tone improved, and also showed improved survival and neurodevelopmental outcomes. And another last case, the baby 3.2 kg male, delivered by LSCS, intensive resuscitation at birth, refractory hypoxemic respiratory failure with severe pulmonary hypertension. X-ray chest was normal and the other workup were normal, but baby remained dependent on ventilator. And so this whole genome testing was done and was positive for FOX F1 gene mutation, suggestive of alveolar capillary dysplasia with misalignment of pulmonary veins. So the baby was withdrawn from the ECMO, counseling was done with the parents, and just given the comfort care only. So this is how the genetic testing changed the management of the newborn in the NICU. So there have been studies we saw that those newborns who underwent the molecular genetic testing, 2/3 of this newborn had a meaningful immediate change in management. So either it's a new subspecialty consultation, targeted imaging or laboratory evaluation, surgical procedure or avoidance of surgical procedure thereof, and this is specific therapies, and also in the change in the goals of care, like from comfort care to withdrawal of life support, life sustaining supports. So coming to when
to order genetic testing. That is the main topic, coming to the main topic, indications of genetic testing in ICU. If we have a newborn with one or more unexplained congenital anomalies, which can be cardiac, renal, or facial, or unexplained dysmorphic features like unusual body or facial features, then unexplained dysfunction in one or more organ system, whether it's a cardiomyopathy, liver failure, immunodeficiency, or kidney malformations, or any newborn with severity of clinical presentation out of proportion to what is expected. Suppose a term baby born by normal vaginal delivery was well, crimes of the birth, after a few hours developed respiratory distress, and the patient and the baby remain on ventilator requiring high oxygen for a long time. So which cannot be explained by any other things. And those some newborns in NICU with a prolonged diagnostic odyssey, standard labs, imaging, infection workup failed to provide a diagnosis, or unexplained neurological findings like severe hypotonia, seizures, and encephalopathy. Then the newborns in NICU with suspected inborn errors of metabolism, so investigation showing severe metabolic acidosis, persistent hypoglycemia, hyperammonemia, and unusual metabolic profiles, or there is a family history of recurrent unexplained infant death, siblings with similar clinical findings, or some genetic order some genetic tests which will the results of which will impact initial management of the case, like conditions with available targeted therapies like metabolic disorders, guiding surgical decisions, or palliative care decisions. And who are the neonates whom genetic testing should not be ordered, like confirmed genetic diagnosis, whether it's a prenatal or postnatal, and no additional clinical features suggestive of potential second genetic disorder, and a clear non-genetic explanation of clinical presentations, like those with the congenital infections, or those who, the mothers who had this substance abuse, and later the newborn had some congenital defects. So before ordering a genetic test, so something we have to do is in detail family history should be taken, and also a deep clinical and detailed clinical examination and a dysmorphology assessment, which should be sent to the lab where we order the genetic test. So that will help in the diagnosis, or in identifying any problem in the variations, in the mutations, so that they can report it properly. And before the testing, informed consent is what is required much, and also pre-test counseling should be done, because why we're ordering the genetic test, what genetic test we're ordering, and what the likely result of the test, and if any secondary or incidental reports come, so whether they opt to disclose or not, that should be done in the pre-test counseling. So there are many different types of genetic testing in the NICU, from the conventional cytogenetics, that is karyotyping, to molecular cytogenetics, that is fluorescent in situ hybridization, to CMA, the chromosomal microarray, then the DNA sequencing, the molecular genetics sequencing, then whole genome sequencing, and the rapid exome sequencing, and the genome sequencing. All these genetic testings have its own strengths and limitations, and we have to know the strengths and the limitations of each test before ordering which genetic test we should send. So the conventional karyotyping, which is the cheapest one, but it still takes time, 5 to 14 days, and they are mostly used for detecting large chromosomal abnormalities like aneuploidies, like your trisomies or monosomies, and the large structural changes like translocations. And diagnostic yield is very low, around 5%, but it's got its own limitations, like cannot detect micro deletions, insertions, and duplications, or single gene disorders. And second test, this is a FISH, that is fluorescent in situ hybridization. They are used for rapid testing. The result you can get in 24 to 48 hours. And for non-micro deletion syndromes or aneuploidic conformation, which was diagnosed by other genetic tests like the microarray. So the best example is Dizor's syndrome, the 22q11.2 deletions. And the diagnostic yield is, it is only targeted. Unless you have a phenotypic suspicion of disease, you cannot order. So you require a prior clinical or phenotypic suspicion. And the third is chromosomal microarray. And it detects your what is called CNVs, like copy number variants, that is microdeletions and duplications. Diagnostic yield is increased compared to your karyotyping, so at around 10 to 15%. So they are useful for unexplained congenital anomalies and development delay. So microarray is gradually replacing this karyotype and the face nowadays. And the advantage is they have higher resolution and karyotype, and which can overlook the whole of your chromosome in the genome. But it has also got its own limitations, like it cannot detect the changes in the nucleotide level. So it cannot detect single nucleotide variants or balanced translocations like inversions and the Robertsonian translocations. So next is our coming to our DNA sequencing. So begin from our Sanger sequencing to the next generation sequencing, NGS. So targeted single gene testing. So it detects variation in one specific gene based on a strong clinical suspicion. So for this also we need to have a clear phenotype and a clear suspicion before ordering it, because we are targeting only single gene mutations. So best example is the non-familial mutation or classical clinical syndrome, that is CFTR gene mutation in case of cystic fibrosis. If the parents are carrier, or if you have a child with cystic fibrosis, so you can do this targeted single gene testing. The limitation is low yield if phenotype is not well defined, especially in a very premature infants, or those who are very sick with so many lines with endotracheal tube, with the OG tube, where the phenotypes are disturbed. So you cannot, that's a problem there. Then the gene panels, not a single gene, but multiple genes for a particular phenotype. So it detects a variant or a set of genes linked to a specific phenotype. So there's many phenotypes that right from that refractory seizures, then to cardiomyopathies or inborn errors of metabolism to mitochondriopathies. Okay, when these are used when the phenotype suggests a narrow spectrum of conditions, they are faster and cheaper than the whole exome or genome sequencing. But it also got its own limitations, the phenotypic variations and new gene mutations. Like because there may be some the gene panel which we sent may count to be all normal. There's no variation, but there will be some novel genes which may cause this the phenotypic presentation which has not been identified yet. So that's a limitation of this. So there are many panels. I'm not going to do it. So the sixth one is the whole exome sequencing, the WES. It detects all the protein coding regions that amount to 1 to 2% of whole human genome. The human genome consists of around 20,000 genes, maybe more, which may not be detected yet. The diagnostic yield is 25 to 40%. They are especially useful for critically ill infants with unexplained severe illness or multiple anomalies where all other genetic tests could not identify. And it can identify at the nucleotide level. Okay, mutations at the level. So the single nucleotide variations and the small indels, the insertions and deletions. But it also has got own limitations. It cannot detect at the non-coding areas that are remaining of that less than 1 to 2%. And it also does miss the major structural variations and the repeat expansions in the DNA sequence. So the biggest one, the broadest one is the whole genome sequencing. It detects the entire genome, including the coding and the non-coding areas, structural variations, even the mitochondrial DNA mutations. Diagnostic yield is 30 to 50%, but the problem is the cost and the problem with the interpretation of the result, the complexity. And but still also it has got own limitations, like it cannot detect somatic mosaicism, because the sample we send for genetic testing is either blood or from the that one buccal swab. Okay, but supposing those with a lymphatic malformation, we need to take the sample from that area, but sometimes it's not possible, but it cannot detect epigenetic variations like DNA methylations, like one example is the Beckwith-Whiteman syndrome. And the repeat sequencing is the same, the whole genome sequencing, but with shorter durations. The result we might expect in 2 to 5 days. The one thing the thing good about the whole exome sequencing, we can do a trio testing, so where we send sample of the patient and for the biological parents. Okay, so if any new novel variations or mutations are detected, we know how it's been transmitted, whether it's pathogenic or not. And another problem with whole genome sequencing is there may come out some secondary findings, incidental findings, or BUS, is a variant of uncertain significance. So secondary findings are we are sending the genome testing for some other phenotypic problem, but there come out the gene, the cancer predisposition gene came out to be positive, like for the breast cancer, BRCA1 and BRCA2. So this may have implications when the newborn grows, but not for this moment. And also, like, screening should be done for the mother, because the mother might have may later develop this breast cancer. So and also we are sending the testing for any another phenotype, any other say for the refractory seizure or something, and the result came out to be like there found mutations at the MYL2 and MYL3, which is for cardiomyopathy. So it has got health implications. They are secondary findings. Another are incidental findings, which is especially with this DNA sequencing, like non-paternity and non-maternity, because this becomes a very big issue then, because whatever we expected, the biological father may not be biological father and the mother, or there are some consanguinity results may come out, or sex chromosome number results may come out. So we should have counseled them pre-testing that if you want to wish for disclosing the secondary or incident findings. And the last, of course, another problem with this whole genome sequencing is the variant of uncertain significance. So we found some the variations or mutations or some in a new gene which may not have relation to the disease process, but later on these are unsignificant at the moment because there are some novel mutations. But if you later on with more research they come out that these are related to the disease also. There's limitations. So this I have discussed. So I'm not going to the evidence. The whole exome sequencing or genome sequencing has a highest yield and lesser with the karyotype, phase, and the microarray. Well, I'll just go to the last one more minutes more. So how this diagnostic workflow should go? If we have a newborn with suspected genetic conditions, what we have to do? If we have a clinical suspicion of aneuploidy or chromosomal structure changes, and if it's a time critical, so better to order for phase. So you'll get report in 24 to 48 hours. If it is not time critical, and if we are suspecting broad chromosomal anomalies with clear, there may be also multiple anomalies or unclear diagnosis. Either we go for that karyotype or that microarray, chromosomal microarray. But they have the limitation I will discuss with the karyotyping. It will look the whole of your chromosome, but it will detect only the major abnormalities and the translocations. We have lower resolutions. With the microarray also, it will detect the whole chromosome problem. You are looking the whole chromosome, but it has a higher resolution which can detect the copy number variants. That is your micro deletions, then duplications and the insertions, but it still can misbalance rearrangements like insertions and the ribosomal translocation. In another case, if we diagnose like this a condition with unexplained clinical presentation or anomalies, clinical features not pointing towards any specific gene or chromosomal abnormalities, because it's where we cannot order any phase or any gene panel or nothing, or all other genetic tests you have done already, but remain still suspicious of genetic problem. That's the time we have to send for order whole exome or whole genome sequencing. Okay, and it also again can from that thing we can also go back to it. So if the microarray detects some problem, so just for the confirmation of that, if you want to look at the whole of the chromosome, then still after doing chromosome microarray, we can order later on the phase or the karyotype again. So it's not from up down, but we can go from down to up also to look the whole picture. Okay. Last one, if we have a condition where there's a phenotype specific for a single gene disorder or panel, that's the condition where we order for single gene or panel testing. So last two slides. So we have some challenges in genetic testing, cost and the availability. So that's a problem. It may not be available, and the cost is a big issue. And the turnaround time for results, because except for phase, where you can get the result in 24 to 40 hours, rest all the genetic test takes around 5 to 14 days. But those babies who are sick in the NICU may not give this much of time for the result. So there's a time with a role of rapid genetic testing, rapid whole exome and the rapid whole genome testing. If it's available, if it will come up, it will be a good thing. And the secondary incident findings I've discussed, and also interpretation of variance on the significance, and there are some ethical and consent issues. So coming to the conclusion, evidence-based guidelines have not yet been published for genetic testing for neonates admitted in NICU. Appropriate genetic tests should be chosen depending on phenotype, keeping in mind strengths and limitations of each test. Unless clinical phenotype strongly suggests a specific chromosome or single disorder, a broader genetic testing approach, ideally rapid exome or genome sequencing, should be ordered. So this is my unit here at Genome Simfa.
Thank you, Dr. Ramesh sir. You have explained very nicely on the genetic problem, and it is really very challenging for not the baby, for parents also, and it is really very vast screening, and really it is cost and availability problem. It is not done everywhere. We are facing in the district practice difficult to how to screen and how to parents afford. So we are in OPD practice every day we face severe problem of the defective seizure, either respiratory failure or cardiac failure or cardiomyopathy or muscular dystrophy. So we are usually referred to patient to higher center. We could not treat. So one we should keep in mind, particularly district periphery doctor pediatrician. I've read in the Kedas book clinically, the mind does not know, I cannot see. So whenever came baby with a severe problem, with serious complaint of any challenging symptom, we should always keep in mind about the rule out genetic, and we can save the baby, we can prevent the anxiety of the parent. So we are usually referred to higher center like Patna, like Dr. Binod Babu or Dr. Savan or anywhere. So we are facing every day, and we undiagnosed, we cannot diagnose, and baby either die in our clinic, or if the parents can afford, we can move to higher center. So we always keep, it is really cost problem, very costly investigation, and not available everywhere. So we should keep in mind whenever we treat the baby came with the serious problem. Thank you, Dr.
According to me, this genetic testing is not only important for the present pregnancy, but to prevent the mishaps in the further pregnancy also. So it should be offered to all the parents, irrespective of whether the child is going to survive or not, but it will definitely help for the future pregnancy planning for the parents.
Thank you, sir. Very informative session. We know genetics is the future in every field of medicine. So thank you, sir. I request all the chairs come for the memento distribution, and Neelam ma'am and Alka ma'am to please facilitate the. Moving on next, we have Om Prakash sir. I will request Dr. Om Prakash sir to please come on the dais, and for the chairing the session, Dr. Om Prakash sir to please come on the dais, and for the chairing the session, I will request Dr. Bhupendra Narayan, HOD Pediatrics, Patna Hospital, Dr. A.K. Sahu Hospital, Dr. A.K. Sahu sir, and Dr. Gopal Saran sir. Dr. Bhupendra Narayan sir, Dr. A.K. Sahu sir, and Dr. Gopal Saran sir.
I am introducing the speaker whose name starts as Om, and Om is a very powerful word. तो देश में रोम, रस में सोम और आदमी में ओम, इसका कोई जोड़ नहीं है। और ओम ऐसा वर्ड है जिसके उच्चारण से मृत्यु भी भय खाता है। महामृत्युंजय मंत्र का ओम त्र्यंबके यजामह सुगंधि पुष्प वर्णनम, तो वह है। और उतना ही पावरफुल हमारे न्यू प्रेसिडेंट ऑफ द आईएपी एनएनएफ डॉक्टर ओम प्रकाश सर हैं, जो कि मल्टी टैलेंटेड हैं। ही नॉट ओनली नो पेडियाट्रिक्स न्यूरोलॉजी, he also can do cesarean section and what not. So he is a multi talented person, and so he clarify the power of Om. So regarding Dr. Om Prakash sir,
कट शॉट कर दीजिए।
हैं?
कट शॉट कर दीजिए।
थोड़ा कम कर दे।
कट शॉट कर दिए ना सर।
ठीक है, कोई हर जाना रे, आपको पूरा समय मिलेगा, आप प्रेसिडेंट है, आपको कौन रोकेगा? Dr. Om Prakash sir, obstetrician, converted neurologist, President NM Bihar, pioneer of SNCU and BN's RCP movement in Bihar at present, consultant Raj Gopal Health Care Center Darbhanga, Darbhanga Maharaj हैं, ही समझ लीजिए, and faculty online neurology training orientation program, India, principal investigator ICMR SCCN, और हम जो जानते हैं ये जो है वो नाल्स के ट्रेनर, हम जब से हम होश संभाले तब से इनको नाल्स के ट्रेनर जानते हैं। सो सर सर
और एक और है, ये डीएमसीएस के जो एनआईसीयू का जो प्लानिंग और जो हुआ, सब इन्हीं के गाइडेंस और इन्हीं के ही जो है मार्गदर्शन में हुआ है। तो एक तरह से ये इंजीनियरिंग का भी विभाग का जो है सो ये काम सब जानते हैं, मल्टी टैलेंटेड। ठीक है, वो प्रकाश जी सुनिए।
So I am going to start where the Dr. Jagdish has left. So we are discussing the different facets of our newborn care, and we have always in our mind that we should advance, but do not have disrespect for the previous things. So in next 15 minutes, I want to highlight some new frontiers in neurology. The first thing, Dr. Jagdish, I bow that you have made my work very easy. So genomic medicine in an ICU, and that lead to the precision medicine. We will discuss the newer modalities like point of care, ultrasound, focus, and echocardiography, some non-invasive remote monitoring technology. AI is everywhere giving its impacts, and machine learning, decision support infrastructure, how it will can. Telemedicine, we have just seen from the Gurgaon at Hyderabad, how a surgery was performed. and supportive care, which is very important, developmentally supportive care and neuroprotection, what we have new frontiers, and this is the era of the non-contact, so we will discuss something. And what we can do in Bihar, I will have some focus on that. So we all know in 2003, the genomes were decoded and there was rapid progress was done in field of the molecular medicine. Rightly told, we have only 23,000 genes, but we harbor around 2 to 4 million genes of the microbiota. So we can utilize all these information, and what previous day Dr. Jagdish Sahu during discussion of the natal encephalopathy pointed that whole gene sequencing and exome sequencing can be helpful. So there is rapid growth, and we have learned how genetics to come with us. New programs are combining RWGS with AI and functional omics to not only diagnose but also suggest possible therapeutic options. The next, focus and portable. Last day, Prabhat Kumar, I discussed him, how will be the learning curve. He told me three months must be given for the knowing the point of care portable echocardiography. It focus enhance the diagnostic accuracy. It will not displace the conventional radiologist who are advanced knowledge about that, but by learning, we can cut short the time for the diagnosis. We can do diagnostic accuracy, we can use monitoring and screening, as well as improve patient and clinician confidence, procedural safety. So focus can be considered as an extension of physical examination. It will not substitute the physical examination. What is happening as a tool comes, we depend upon the tool. Man behind the tool is most important. So focus is becoming indispensable tool in the NICUs. We have now the focused SOPs, and on a guideline from the American Academy of Pediatrics, panelists agreed on 39 of 41 recommendations for the use of the cardiac, lung, vascular, cerebral, abdominal focus in critically ill neonates and children, and we can be benefited and we can learn and advance our outcome. So there is a learning graph, how we can fix. So it may be educational point assessment with reviews and clinical overflow, and we can lead to the institutional credentials. Due to short of time, I am just referring Pediatrics volume number 150, number 6, December 2022. Anyone, this is free. Similarly, non-invasive remote monitoring technology. Because most of the patients are in remote areas, and camera-based systems are being developed to monitor vital signs without touching the baby, and this reduces the risk related to the virus, skin damage, infection, and improves comfort. Vision-based behavioral state detection, like baby is asleep or awake, crying. We can use lightweight AI models on Raspberry Pi for preterm infant, especially in low resource settings. Dry contact or low contact ECG systems with AI learning may be the future tool, and it can detect. Previous day we learned that this EEG monitored this seizure is more important. So we can have in future a new frontier, and here comes the role of the AI and machine learning. The AI is your jinn. चिराग घसो जिन उठेगा, आप जैसा उसको कमांड देंगे वैसा कर देगा. कुआं खोदना, पहाड़ बनाना पड़ा. So this is the prompt, which is the most important. So you must learn how to prompt. That is your friend, and you talk to the AI tools as you are learning, talking with your friends, and दिल खोल के उससे कहें, कुछ भी छुपाए नहीं, तभी वो काम कर सकते हैं. तो AI integrated tools for monitoring, analysis, risk assessments, and with clinical decisions, they help you. And now the mobile apps I discussed in the morning with bilirubin checkup. So we have many apps are being developed, and biomedical engineering is very important partner of us. So both online, offline, both are done, and we can use the previously used tools like kangaroo mother care to monitor how it is working. So it can be used with telemedicine in remote areas. Remote neonatal care units can be connected with AIMS Patna, and Bhavesh in the AIMS Patna can direct the working this graduate level doctors of the care and the advanced management of this neonates. We are going to have MNCU in near future, and here we need the help of the both obstetricians and neonatologists to run it. And here telemedicine will be a great help. It will be a very new frontier, and we can master it easily. So a specialized NICU or MNCU with a small baby focus with environment modification like noise, light reduction, infection control, all can be better support from remote. And also for the supportive care innovations and developmental neuroprotection, I always talk about the intact survival, and we all know in previous panel discussion we found IVF baby decision about the cesarean section or normal delivery, the baby to be cared in ICU or with mother, everything can be support, and here we can develop by telemedicine the supportive care which will be family centered. Kangaroo mother care, skin to skin contact. The difference between skin to skin contact, as the baby is delivered, it came from the sterile environment, and the bird is focused occupied by the microorganisms who are more elder than us. So having a good bacteria colonize on the body, the skin to skin contact is the first thing to be done. Kangaroo mother care is for the low birth weight baby, and here we have the parental involvement even in NICU environment. These are not new concept, but here technology can help you, and the new frontiers like web apps, telemedicines, and remote sensing, all these are helping. So better non-invasive respiratory support, improvement in humidification, flow therapies can enrich our management. And we all know when we touch, we give something and take something, not only temperature, heat, microorganisms, other things, sentiments, everything is given. But sometimes if we are not touching, God has given only do no harm. Every benefit is given by God, but when we touch, we can do harm. So if the non-contact ambient technology, edge devices, they can monitor infant using computer vision, ambient sensors. There will be less wires and smarter incubators. These optimize low power offline work to ensure continuous monitoring even with unreliable, and I request all of neonatologists to go green. Last month I go green. There is no electricity bill. You can use over roof solar panels. They generate enough energy to run your big hospital. You can save the energy and it go to the grid station too. So we can have association of sun by solar energy to protect our babies. So we will not depend on power, and if you will use the hybrid mode,
The hybrid mode will have support when there is no sun, rainy seasons. So I again request, I talked Rajesh Kumar previous night. He was telling that the baby army should do TSH in cord blood. Though this is not reliable, Bhavesh, I discussed with Bhavesh is not agreeable, but scaling genetic screening at birth or by cord, we can expand newborn screening, and large scale newborn screening is known. 1700, one baby in 1700 have hypothyroidism. So there are challenges too. The cost and the learning curve. The ethics not clear, consent, data privacy. When we collect data, the conflict of the data privacy always arises. There is no regulation in our country, and validation needs clinical evidence is still bigger. But if we will do, then we will collect the data and we have a clinical evidence. So challenge is also to integration into existing NICU and now MNCU and all things. We start everything, do some days and then भूल जाते हैं. हमारे जो मेंटर थे डॉक्टर कैंपी सिन्हा, वो कहते थे ये ढीली पतलीन है, घसकते रहेगी, चढ़ाते रहो, नहीं तो नंगे हो जाओगे. So these are my thinking, which are going to be new frontiers in next 5 years. That is broader adoption of the rapid gene sequencing in ICU, and maybe newborn genome screening as part of the standard care, which are now prevalent in many advanced countries. More AI or ML assisted diagnosis, predicting modeling for morbidity and mortality, and predicting respiratory distress, necrotizing enteritis, sepsis, which are our enemies. So proactive care is possible. Non-invasive continuous monitoring, increasing, for example, camera-based assessments, wearable sensors, reducing the invasiveness of monitor. It will improve supportive care in very preterm, the tiny we are needing most and giving disgrace many times. So, optimize environment, noise, light and handling, nutrition. The milk bank is now regarded as low cost intervention. So human milk and even pasteurized human milk if you do not have care. Developmentally appropriate care, the best thing is the mother's touch, mother's presence. The both parents should be allowed to the even very sick newborn, and though it is not new concept, Swami Vivekananda has told about that, but we have taken a new frontier on this. And we should have focus on equity. Tools designed by LMICs, affordable, rugged offline, and low power telemedicine to be extended especially. So this is my suggestion. What we can do, this is my last slide. So we can pilot a non-contact system. Our SNCU can do for it. We have in our SNCUs or NICUs a telemedicine link, and we can connect to the higher medical facilities. We can collect good local data. We always ask about the microbacterial flora of your nursery, where you can use microbiomes, 3 dose duration and directions, all things. Mother's milk is the God's gift. भगवान लोग स्वर्ग में अमृत पी लेते हैं, फिर भी धरती में जन्म लेते हैं कि माँ का दूध मिल सके. Mother's milk is superior to the amrit. So we must fight every tooth and nail for this donor milk and milk banking. and we have local problem, local persons, local resources, local technology, even छोटी छोटी चीज़ें. हम लोग बच्चों का नियोनेट्स का ब्लड प्रेशर का कोई रिकॉर्ड यहाँ नहीं रख रहे हैं. इवन हम लोग दोनों हाथ की SpO2 की मॉनिटरिंग नहीं कर रहे हैं. बहुत छोटी चीज़ें हैं, लेकिन ये हम न्यू फ्रंटियर्स में चाहेंगे कि इन सारे चीज़ों को, और सब कुछ तो हम बात कर रहे हैं, भवेश न्यूरोलॉजी के यहाँ पर हेड हैं, वो सोचेंगे तो उन्हें चालू हो जाएगा. SPO साहब कुछ सोचेंगे तो बिहार के PSC में हो जाएगा. हमारे यहाँ इतने सारे पॉलिटिशियंस आज जमा है, अमित शाह भी कल यहाँ थे, वो अगर सोचेंगे तो हो जाएगा. 2010 में नीतीश जी ने सोचा था और उन्होंने ईयर ऑफ न्यू बॉर्न डिक्लेयर किया था. एक बार फिर से हमको ईयर ऑफ न्यू बॉर्न डिक्लेयर करना है. सो धन्यवाद, आपने मुझे सुना. मैं ये एक विजन स्लाइड था, कहीं से भी कोई बहुत ज़्यादा इसमें साइंस नहीं था, ये साइंस से अलग चीज़ें थी. तो धन्यवाद, आपने मुझे सुना. अगर कोई कुछ इसमें ऐड करना चाहते हो, जैसे कल 11 को मैंने 13 करने के लिए कहा, आज के अखबारों में वो 11 हाइलाइट्स है, वही आज के अखबारों के हेडिंग्स बने हुए हैं कि 11 जीवन रक्षक लो कॉस्ट इंटरवेंशन बच्चों की जान बचा सकते हैं. तो मैंने 2 जोड़ा था उसमें, फैमिली इन्वॉल्वमेंट विच इज़ मोस्ट इम्पॉर्टेंट. और एक बात मैंने एक जगह और भी कही थी, हम भी एक पार्टी हैं. मेरी मेंटर डॉक्टर सुनीति सिन्हा कहती थी कि कभी कभी लगता है मैं 7वें आसमान पर हूँ, और कभी पताल में भी कहीं जगह मिल जाए तो चेहरा छुपा लूँ. मेरी स्थिति एज ऑब्स्टेट्रिशियन, बिकॉज आई एम पेरिनेटोलॉजिस्ट, एज ऑब्स्टेट्रिशियन, एज neonatal care person, I can't say me to neonatologist after previous talk, so I never claimed for that. So हम लोगों को एक पार्टी के रूप में लिया जाए सारे मैनेजमेंट में. वी आर ऑल्सो केयरिंग बेबी, वी हैव सेंटिमेंट. जब कोई एक बच्चा, मैं पिछले 2 महीने से उसका केयर कर रहा होता हूँ उम्र से, और उसका ग्रोथ नहीं हो रहा होता, और मान लीजिए बाद में वो CP होके आ जाता है, आप मेरा दर्द नहीं समझ सकते. आपको एक बच्चा है, वो सारे बच्चे मेरे बच्चे हो जाते हैं जिस समय मेरे पास आते हैं. तो मुझे भी एक पार्टी के रूप में, सारे नियोनेट्स तो ठीक हैं, उनके पेरेंट्स ठीक हैं, लेकिन ऑब्स्टेट्रिशियन एंड पेडियाट्रिशियन न्यूरोलॉजिस्ट, दे शुड बी आल्सो टेकन एज ए पार्टी. थैंक यू वेरी मच.
Thank you, Dr. Om Prakash. Very nice deliberation and giving very vision for the future.
Thank you for your interesting presentation. किसी को कुछ सवाल पूछना है या कोई सजेशन देना है? Anyone from the audience?
Thank you, Om Prakash sir, और प्रेसिडेंट NNF बिहार, और बहुत ही बढ़िया सर ने सारे डायरेक्शंस और सब.
Thank you, Om Prakash sir. So by concluding this session, I want to say couplet. Whole things of this conference or any neonatal discussion depends to reduce the neonatal mortality. So neonates have some expression. Neonates say that I am neonate, I am neonate, I have some anticipate, I have some anticipate, I needs warm touch, gentle care, and as early as breasted hair, as early as breasted hair. So, and this rate of neonatal mortality come down only by WIN, warming the neonate, prevent the infection, antenatal, natal, and postnatal, and give appropriate nutrition from antenatal and postnatal. So with these words, I am concluding, sir. Thank you.
Thank you, sir. Thank you, Upendra sir. All the chairperson, I will request to come on dais. Moving on next, we have next session by Dr. Professor Alka Singh ma'am. I will request ma'am to come on the dais for For chairing that session, we have Dr. Rakesh Kumar from NMCH, Dr. Akhilesh Kumar, Dr. Sujit Kumar from NMCH, Dr. Subhash Chandra sir, and Dr. Rajnandan Chaudhary sir.
Dr. Alka Singh, MD, PhD, MRCP UK, retired superintendent NMCH, ex-HOD pediatric NMCH, President IAP, NRC Bihar 2025, Secretary NNF Bihar 2013 to 14, President Patna IAP 2019, Secretary ICC Bihar 2017 and 18, Vice President Bihar IAP 2023, Purvanchal Sisu East Zone IAP, Academic Excellence Award, Bihar IAP, 60 publications in international and national and state journals, and national trainer, FIMNC, FVNC, and NRPIYCF.
Thank you. A very good afternoon to everyone. Today I'll be talking on neonatal transport in low resource setting. So neonatal transport is actually a poorly addressed topic, and it contributes, if the transport is not proper, it contributes a lot to the mortality and morbidity of the newborn babies. It is the process of safely transferring sick or premature newborns to health facilities that are equipped with a higher level of care in order to reduce their mortality and morbidity. So this has been discussed before also, that in utero transfer is the best transfer. If possible, the pregnant mother should be transferred to a higher facility, so that which has a higher level of care both for her and for the newborn babies. If it is a high risk pregnancy and adequate neonatal care is not available in the existing facility, it is always better to transfer to a tertiary care center. But sometimes this is not possible because babies may deliver prematurely, or there may be perinatal complications which you have not predicted before, and so this transfer may not be, you may not be able to plan this transfer. Neonatal transport is not new. In the West, very early in the 19th century itself, rudimentary incubators were being developed, and now it has progressed so much that there are helicopters and highly specialized airplane systems for neonatal transfer. Joseph D. Lee, there's some amount of history, in 1898 he developed the first incubator station in Chicago, and Julius Hess, 1922, he developed the first transport ambulance. This was also in the US. So this is a helicopter, a newborn baby being transferred by the helicopter, and the network is very well developed in the West, but unfortunately not so well developed here in our country as such. What are the challenges? The challenges in low resource, we are talking about low resource settings. So in low resource settings, transport systems are often inadequately developed, which can contribute to preventable neonatal deaths which could have been prevented. Those babies also may die because the transport system is not so good. Poor infrastructure of the existing facility where the baby was born, inadequate equipment, lack of organized transport services, scarcity of ambulances. Very few ambulances with inconsistent fuel supply, especially in government setups. It may be difficult to procure fuel at the right time. Poor roads, long distances, and very important is lack of trained staff. So that is a big hitch. Then poor communication between the facilities and the communities. Timely referral and organized transport can save lives even with limited resources. This we have to remember. So if there is a prompt transfer, then a lot of babies can be saved. Where to transport? So NNF had recommended from a way long back that take the baby to the nearest referral facility by the shortest route and using the fastest possible mode of transport. So that is what we have to try. Babies may have to be transferred from home to the health facility or from the delivery room to the NICU, intra-hospital transport, in the hospital itself to operation theaters, or for special procedures, imaging. For all these purposes, babies may need to be transferred, and to a higher center for advanced neonatal care. And finally, reverse transport. After the baby is well, he has recovered, then you may have to transfer it back to the existing facility or to home. Indications are quite a few. If the baby is premature, it depends on in what facility the baby has been born. Whether there is they are equipped to care for such babies or not. Prematurity less than 32 weeks, VLBW babies less than 1500 gram who require SNCU and NICU care. Severe respiratory distress requiring ventilation or CPAP, birth asphyxia, grade 2, 3, intractable seizures which are not responding to your phenobarbital, sugar, calcium, etc., and you don't know what to do, so you may have to transfer. Life-threatening sepsis, shock requiring inotrope support, severe jaundice requiring exchange transfusion. So these babies may need to be transferred. Congenital anomalies requiring surgical intervention, or if there is a need for advanced monitoring or special investigations. So these are the possible indications for transport. What are the preparations that need to be done? Informed consent from parents. That is very, very important, and that has to be taken. And you have to explain to the parents that this baby has to go to a higher facility and take their consent, written consent. Thorough pre-transport stabilization, we'll read about it later. Write and send a referral note to the referring facility where you are referring the baby. Encourage mother, always encourage the mother to accompany the baby for feeding and bonding. So that is a very important aspect that mother should accompany. Pre-transport stabilization. So you have to ensure that the baby follow the ABC, ensure airway patency, adequate feeding, adequate breathing, circulation, and you have to maintain the body temperature. So use skin-to-skin contact. We'll come to it later. And warm blankets or hot water bottles. Correct hypoglycemia. If the baby is clearly hypoglycemic, if the sugar is less than 45 milligram per deciliter, then you may have to give 2 ml per kg of 10% dextrose. Start IV fluids, or if the baby is stable, you can just feed the baby. If the baby is able to breastfeed, then do that. That will also correct the hypoglycemia. Administer antibiotics. The first dose of antibiotics, you may have to give vitamin K, 1 dose, and essential medications as indicated. Secure the IV lines ensure adequate ventilation, and provide clear referral documentation. So the principles of safe transport, the stable sugar, temperature, airway, blood pressure, lab work, the basic lab work like CBC, sugar, and maybe ABG if you have it in your hospital, and emotional support. So these are the principles, the stable, to make the baby stable before transferring. Essential, what are the essential equipments that should be there in the transport ambulance? Portable oxygen cylinders, oxygen concentrators, whatever is available. That should be enough to last the whole period of journey. Then ambu bag, laryngoscope, endotracheal tube, thermal mattress, or improvised warmer like hot water bottles. And hot water bottles should always be wrapped in pieces of clothing, because there have been cases of burn to the newborn babies if they are just directly touching the hot water bottle is touching the baby. Then monitoring, for monitoring you have to take pulse, portable pulse oximeter, thermometer, stethoscope, and there should be battery backup. That you have to see in the beginning itself, that the battery doesn't finish on the way, and it should be kept fully charged. Resuscitation drugs and IV fluids should be prepared before departure. So these drugs should be available: adrenaline 1 in 10,000 dilution, normal saline 10% dextrose, some anticonvulsants like phenobarb, phenytoin, and dopamine. So these are the emergency drugs that you may need to use on the way, so these should go with the baby. Modes of transport. Ambulances are ideal when equipped with oxygen and warming device. Modified vehicles. So many other modes of transport have been used, like motorbike ambulances, taxis. These have been used in rural settings. And kangaroo mother care, skin-to-skin contact during transport, maintains temperature and bonding. So kangaroo mother care is the best way to keep the baby warm during transport if the baby is stable. If the baby is not stable, maybe you might not be able to do it. In some areas, boats or bicycles are adapted for neonatal transfers. So see, this is a picture of a baby being transported in an auto rickshaw and in a boat. And this is the transport incubator. Then ambulances, which are designed, ICU on wheels. Team, what should be the team? Team should include at least one doctor and one trained neonatal nurse. That is the ideal team. But if both are not available, at least one trained healthcare provider, nurse or paramedic should accompany the baby. And you inform the receiving facility early and of the estimated arrival time. Share details of the stabilization measures, what all you have done, and the ongoing treatments, and maintain communication en route if mobile network is available. So as you are proceeding with the team, the ambulance is going, if a mobile network is available, you keep talking to the facility where you are referring the baby, that so we are reaching at this time, and things like that. Care during transport, ensure continuous maintenance of warmth. So you have to ensure that warm feet during transport. That means that if the feet of the baby touch the feet, you understand that your baby is not in cold stress and is comfortable and normothermic. Kangaroo mother care is highly recommended, low cost intervention, proven effective for warmth and stability during transport. Ensure open airway, adequate oxygenation, and safe feeding. So feeding, if your baby is stable and you are feeding, that should be safe. Baby may, or baby might aspirate or choke in the way. Babies may become unstable during transport. That you have to remember and take care of, and try to prevent it. So low cost interventions in a place of low resource setting. So tiny babies, they inspire great innovations with simple things like you can use a styrofoam, thermocol boxes, cane boxes. This is a cane box in the picture, or cardboard boxes with warm water bottles covered with cloth to maintain warmth. Aluminium foils may be used to wrap the baby, plastic bags to keep baby warm, and solar powered incubators. Nowadays, solar powered incubators and oxygen concentrators where electricity is unreliable. So that helps a lot. And simple transport incubators made from locally available materials. You may not go for the costly and fancy brands, but simple incubators can be made from locally available materials, and training of health personnel, training of families for kangaroo transport, and basic monitoring. बच्चे के पेरेंट्स को बताना है कि हाँ ये पैर छूते रहिए, बच्चे का कलर देखते रहिए, और so that they also know whether the baby is stable or getting worse. So these mother and father, anyone can do kangaroo mother care. Low cost interventions, a plastic box, and then there is a cardboard box. Low cost incubators. And then there is the stop stool. So when the baby reaches the tertiary center, this is a stop stool. In what condition the baby has reached there. S for sensorium, T for temperature, O for oxygenation, P for perfusion, and S for sugar. So this is a paper, a research paper which came out in the BMJ Open about transport characteristics and predictors of mortality among neonates, referred to a tertiary care center in North India, a prospective observational studies. So what are the transport characteristics, how the baby has reached the destination, that predicts the mortality. And so they have recommended that the pre-transport stabilization and trained personnel and inter-facility communication should be adequate to reduce the mortality. Another research paper, a cross-sectional study on transport of neonates in resource-poor setting. So they have used the stop stool to assess that the condition in which the baby is reared and they reach the facility where you have referred, then you can apply this stop stool, and this depends on the logistics of the transport. So if the transport has been done in good condition and according to what it should be, then this mortality and morbidity becomes less. What are the contraindications? If there are congenital anomalies incompatible with life, if the baby is non-viable, less than 400 gram, less than 23 weeks of age, unstable baby is not responding to resuscitation and who can die during transport. So these are contraindications. Then medical legal issues. If cardiac arrest occurs on the way, stop the vehicle, do CPR according to NRP guidelines. If death occurs on the way, we first shifted to higher facility. And then there you get the baby admitted and explain to the parents and to the medical officer of the higher center to issue a death certificate. The baby needs a death certificate. If it is the obligation of the transport team to facilitate the issue of a death certificate. Government programs under the National Rural Health Mission, there is Janani Shishu Suraksha Karyakram, which offers free services, referral transport they have also, from to refer baby and mother from one facility to another, drop back services back home. There is Janani Express, vehicles for emergency transport for pregnant women and infants in rural areas. Then we have the ambulances, 102 mainly for maternal and neonatal transfer, and 108 is a general and transport system, and also for the infants also. Regional network. It is very important to establish regional network connecting referring hospital with center involving multi-partner hospitals. And there is a central command center for this, a helpline to manage all transport requests with 24/7 response and coordination. This is very well developed in Karnataka, Manipal Ambulance Response Service, Neonatal Care on Wheels, MARS now it is called. And it connects multiple hospitals and ambulance services. Then there is GVK EMRI, Ganpati Venkat Krishna Reddy Emergency Management and Research Institute. It is a not for profit organization under PPP model in Tamil Nadu. They deploy specialized neonatal ambulances. In our state, where are we? There is home-based newborn care where the ASHA workers, they go to the homes and identify sick newborns and refer them to higher facilities. Then there is HBYC program, additional home visits beyond initial 42 days after birth, newborn stabilization units, and real-time referral systems where they will use electronic devices to send papers of the baby and track the course of the baby. In some districts like Sivan, but it has not actually started as yet, it is in the streamline. So what are the recommendations? Implement regional neonatal referral networks with clear protocols, train community health workers, invest in affordable transport incubators, develop telemedicine, that is also important, systems to guide stabilization during transit. The take-home messages will be neonatal transport in low resource setting is challenging but critical for survival. Safe neonatal transport is possible even in low resource setting with planning and innovation. So if there is a plan and innovations you can make, then neonatal transport can be a safe process. Teamwork, practical approach, focus on stabilization, thermal care, communication, to improve survival, and low-cost innovations and community involvement are key to reducing the neonatal mortality. Thank you.
Thank you, Professor Dr. Alka ma'am, for your very nice and informative presentation about neonatal transport in low resource setup. Any question from audience? Thank you.
Thank you, ma'am, and all the chairperson. I will request ma'am and the chairperson please come for the memento distribution. I will request Golwara sir to please assist in memento distribution. Moving on next, I will call Dr. Saroj Kumar. Saroj Kumar sir. And for chairing that session, I will request Dr. Ashok Kumar sir from Hajipur, Dr. Varun Kumar, and Dr. Sunil Kesri sir. Ashok. Dr. Manmohan Mishra sir. Saroj boss.
Dr. Saroj Kumar, Associate Professor, Department of Pediatrics, working at Nalanda Medical College, Patna, and is Director, Apex Child Care and Vaccination Center. He is MBBS and MD, and his areas of interest are neonatology and pediatric pulmonology. He has major achievements and publications. He has written a book, a handbook of pediatric and neonatal ventilation,
write 12 chapters in long and short cases in pediatrics, written 2 chapters in short textbook of pediatrics, published more than 25 original articles in national and international journals, and he has written a textbook of pediatrics based on new NMC curriculum, which is coming soon. So he will share insights on antifungals in neonates and NICs. Dr. Saroj, please.
Thank you, sir. A very good afternoon to all of you. I am going to have a brief presentation on antifungals in neonatal intensive care units. So, first of all, we will see the neonatal fungal infection may have mucocutaneous presentation or may have invasive fungal infection. We are more concerned about the invasive fungal infection, and it includes Candida bloodstream infection, meningitis, UTI, peritonitis, endocarditis, and congenital cutaneous candidiasis. So why we are more concerned about this invasive fungal infection? So this is the large retrospective cohort study published in Frontier Pediatrics in April 2023, and around 8,408 infants were included with gestational age less than 29th week. And it was concluded from this study that preterm infants with invasive fungal infection have significantly higher incidence of mortality and adverse neurodevelopmental outcomes than those with non-invasive fungal infection and no infections. So this neurodevelopmental impairment is very important, and for improving the quality of surviving newborn, we have to prevent this invasive fungal infection, diagnose early, and treat appropriately. As far as the burden of this invasive fungal infection is concerned, the incidence is inversely proportional to the gestational age. The incidence rises with decreasing gestational age, and incidence is around 1 to 4% in very low birth weight baby, 2 to 8% in extremely low birth weight baby, and it may rise up to 20% in neonates with birth weight less than 750 gram or gestation less than 26 weeks. According to Delhi neonatal infection study that has been published in Lancet in 2016, Candida species is responsible for 25% of sepsis in outborn neonates. The major problem of this invasive fungal infection is in outborn newborn. Outborn newborn. It is almost rare in inborn. And out of that, the 3/4 of infection occurred at or beyond 32 weeks of gestation. Regarding mortality, it is around 13 to 20% overall, but it may go up to 5% with disseminated infection or meningitis. The common etiological agent, Candida is the most common etiological agent, and out of that, Candida albicans is responsible for around 50% of the cases. And rest, Candida parasilosis, Candida glabrata, Candida krusei, tropicalis, pseudotropicalis, aspergillus, or rarely by the mucor species. So we have to identify some of the risk factor and try to avoid these modifiable risk factor. And these are extreme prematurity and ELBW babies, babies having complex gastrointestinal disorders like NEC, gastrocysts, and bowel perforation, prolonged use of antibiotics for more than 5 days, usage of 2 or more antibiotics, parenteral lipid infusion for more than 7 days, central venous catheter, lack of enteral feedings, use of H2 blocker or proton pump inhibitors, bacterial sepsis, intubation and mechanical ventilation, hyperglycemia and postnatal steroids. So we should try to avoid as far as possible or used judicially. Now, why newborns are more vulnerable? So due to their immature skin and mucosal barrier, they are more vulnerable. And in neonates, there is impaired neutrophil and macrophage functions, and there is decreased complement and antibody response. Due to this, the infection leads to rapid dissemination to the different organs like CNS, kidney, eye, and liver. Coming to clinical feature. The clinical feature of invasive fungal infection is non-specific, and it mimics general bacterial sepsis. The most common presentation may be apnea, lethargy, bradycardia, respiratory distress, increasing oxygen requirement, thrombocytopenia, and rising CRP. In 1/3 of the case, it may present as GI symptom like abdominal distension, bloody stools, gastric aspirate. It may present as UTI, meningitis, ventriculitis. In eye, it may present as endophthalmitis, endocarditis, and in bone, it may present as osteomyelitis and arthritis. So the presentation is non-specific, mimicking any bacterial sepsis. So we must have the high index of suspicion to detect this invasive fungal infection. Now coming to diagnosis. The positive fungal culture from the sterile site like blood, urine, CSF, bone or joint, peritoneum, and pleural fluids. So positive fungal culture from these sites is the diagnostic. And in the diagnosis of this invasive fungal infection, blood culture is the gold standard. And most of the growth usually occur within 72 hours, but we should monitor the growth during culture for more than 10 days just to detect any fastidious or slow growers. And the sensitivity of this blood culture varies from 28 to 78%. We must do urine culture if we are suspecting UTI. So the Candida UTI may be defined as and 10 to the power 3 or more colony forming unit per ml in case of suprapubic collected urine. And regarding CSF, it should be done in all the cases of candidial bloodstream infection because CNS infection is quite common. And depending on the clinical presentation, we may send culture from other sterile site like peritoneal and pleural fluid. In every case of suspected invasive fungal infection, end organ dissemination screening is must. So we must examine eye for detecting retinitis or endophthalmitis. We should do renal USG for detecting any fungal mass or renal abscess. We should do echo for detecting vegetations and endocarditis, and we should do cranial USG or MRI for CNS involvements. And there are certain newer diagnostic tools like glucose assay, PCR for Candida DNA, and fluorescent in situ hybridization test. But these tests are expensive and not routinely available in NICU setting, so in detail. Coming to the treatment. So since the report, the standard diagnostic method is blood culture, and the report that we get, we should not wait for the report. So there must be some basic principle for management of this invasive fungal infection, because the earlier the treatment improve the survival of the newborn. We should have the high index of suspicion, and in that condition we should start empirical therapy. So start empirical therapy in the condition of high index of suspicion, like if there is ELBW babies with sepsis non-responsive to the antibiotics, or there are multiple risk factors of this fungal sepsis along with thrombocytopenia. So we should not wait for the confirmation of diagnosis.
we should start the antifungal therapy and tailor the therapy as per the culture reports. And remove central line if fungal sepsis is suspected. So what are the options that we have for this treatment of fungal sepsis? So we have 4 classes of antifungal agents: polyenes, azoles, echinocandins, and pyrimidine. Among polyenes, amphotericin B, deoxycholate. Among azoles, we have fluconazole, voriconazole, posaconazole. And among echinocandins, we have caspofungin, micafungin, and enidulfungin, and flucytosine. So which drugs should be used? So as we have seen that most of the invasive fungal infection is caused by Candida species, and most Candida species are still susceptible to both fluconazole and amphotericin B. So as per protocol, amphotericin B deoxycholate is the first line drug for systemic candidiasis or any systemic fungal infection. This should be the first line drug. And few species of Candida like Candida glabrata, Candida krusei, these two are resistant to fluconazole, and Candida lusitanii, which is resistant to amphotericin B. Amphotericin B, basically how it works, basically it binds with ergosterol in the fungal cell membrane, and that creates a transmembrane channel leading to cell membrane disruption and cell death. The dose of amphotericin B deoxycholate is 1 milligram per kg per day, and the liposomal form of amphotericin B, we can use higher dose in the dose of 3 to 5 milligram per kg per day IV. It should not be used in the dose of more than 5 milligram per kg per day in newborn. And amphotericin B is broad spectrum. We can use in any systemic fungal infection like Candida aspergillus mucor. And this liposomal form is less nephrotoxic, so it has some benefit, but at the same time, this liposomal amphotericin B should not be used in UTI. And we can add flucytosine for salvage therapy in the meningitis along with amphotericin B. Now, amphotericin B is the first line drugs. The alternative is fluconazole, but fluconazole should be used in neonates who had not received fluconazole prophylaxis. This is the alternative drugs, and fluconazole inhibits ergosterol synthesis via fungal cytochrome P450 inhibition. It should be used in the dose of 12 milligram per kg per day, oral or IV, and preceding by the loading dose of 25 milligram per kg for the neonates. It has got excellent CNS penetration as well as urinary penetration. It is also preferred for Candida infection as well as for prophylaxis of fungus. The next drugs in this group is voriconazole. It may be used for aspergillus in the dose of 9 milligram per kg per dose IV every 12 hourly, and it requires drug level monitoring. Now the third drug is echinocandins. It is used to treat fungal infection unresponsive or resistant to amphotericin B and fluconazole. And among these echinocandins, we have caspofungin and micafungin. These micafungin are well studied in the newborn in the dose of 4 to 10 milligram per kg per day IV. We can use this caspofungin also in the loading dose of 70 milligram per meter square per day followed by 50 milligram per meter square per day. It has got advantage that it has minimal toxicity and effective in Candida resistant to other drugs like fluconazole and amphotericin B. So to sum up, the preferred drugs for Candida infection is first line amphotericin B, is fluconazole, For Candida glabrata and cruzi, since it is resistant to both amphotericin B and fluconazole, the first line drug is echinocandins, especially the micafungin. For aspergillus, the first line drug is either voriconazole or amphotericin B. For mucor species, it is amphotericin B. Cryptococcus, for it is amphotericin B and flucytosine. So overall, if you compare, the first line drug for all infection is amphotericin B, alternative is fluconazole, and if we are suspecting the resistance to fluconazole and amphotericin B, then echinocandins should be used as the preferred drugs. So during drug therapy, we should monitor for the toxicity, and for amphotericin B, we should monitor for the renal, hepatic, and electrolyte imbalance. During fluconazole, hepatotoxicities should be monitored properly, and echinocandins have minimal toxicity, but still we should monitor for the renal and hepatic toxicity. Duration of therapy. In case of invasive candida infection, it should be continued for minimum of 2 weeks after the last negative culture. And for meningitis, it should be continued for 3 weeks after the last negative culture. In case of endocarditis or osteomyelitis, it should be used for 6 weeks or longer. And at the same time, during therapy, we should do blood culture every 48 to 72 hours, so that we can identify the clearance point. Now, the focus must be to prevent this invasive fungal infection in neonatal intensive care unit, and among that, antifungal prophylaxis, especially in the high risk NICU, having invasive fungal infection incidence of more than 10%, is advised as per IDSA guidelines, and it has been suggested as per the Cochrane Review 2015. So fluconazole prophylaxis is mandatory in the dose of 3 to 6 milligram per kg IV oral twice weekly for 6 weeks, and it decreased the overall invasive infection incidence with no major adverse effect noted. But although this fluconazole prophylaxis decrease the incidence of invasive fungal infection, but it does not decrease the risk of death or neurodevelopmental impairment. You can see this Cochrane Review published in October 2015, and the key findings are: the overall analysis showed a reduction in the risk of severe fungal infection in infants who received systemic antifungal prophylaxis, but did not show a difference in the risk of death. The trial did not assess the risk of long-term problem, including disability. So definitely it will decrease the incidence of invasive fungal infection. Now the other steps for prevention is antibiotic stewardship, rational use of antibiotics. We should limit broad spectrum antibiotics, early enteral feeding, minimize parenteral lipid infusion, remove unnecessary catheter early, infection control bundle should be followed, early extubation through CPAP. We should avoid H2 blockers or proton pump inhibitor, and limit the postnatal steroid use. Regarding prognosis, the mortality is around 13 to 20%, and it may go higher in case of CNS or disseminated infection. Mortality may rise up to 50%. And neurodevelopmental impairment risk is twice higher than in non-fungal sepsis. It leads to longer NICU stay and higher cost burden. So the takeaway message is we should have a higher index of suspicion for fungal sepsis. We should start treatment early without waiting for the confirmation of diagnosis. We should remove central venous catheter early. Amphotericin B is the gold standard first line. Fluconazole for prophylaxis of high risk units, and follow stewardship and prevention protocol. And this is the future direction. The one drugs, ibrexafungerp, this is oral glucan synthase inhibitor. The trial is going on, and there is increased study on the role of artificial intelligence based sepsis prediction score, HERO score. This HERO score is currently being used for the bacterial sepsis, and the trials are ongoing for the utility in the fungal sepsis, detection of fungal sepsis. and development of neonatal pharmacokinetics model for precision dosing. Thank you very much.
Thank you very much was for a wonderful and details presentation of this topic. I think you have covered each and every part. So any questions from the audience?
सर को माइक दो। हाँ ठीक है, सुनाई पड़ रहा है। हाँ बोलिए सर। सुनाई पड़ रहा है। हाँ बोलिए सर।
With each cell, detection of each cell is a very easy. You can get within few hours, and culture will be available after 24 or 72 hours. So, should we also do each cell urine, and if there is each cell, we can start, and if confirmation is there, then you can prolong that treatment.
Definitely, sir. The first and foremost point is that you should start earlier the treatment. For that, you can start antibiotics, antifungal, even after the highest antifungal, even after the highest suspicion, or you can start after finding you have a budding yeast cell in urine routine examination. You can start.
That is a good indication for.
You can start empirical therapy.
Boss,
sir, oral. Yeah, we can use, sir, oral or IV, both. Yes, sir.
Boss, one question. Saroj boss, prophylaxis, about the antifungal prophylaxis, we should give in high risk NICU unit or a specific baby to whom we should start antiprophyl?
Actually, as far as this prophylaxis is concerned, and recommendation by IDSA, Infectious Disease Society of America 2021, the NICU having incidence of this fungal sepsis more than 10%. In that condition, you should use this fluconazole prophylaxis. This is according to the NICU, not to the particular baby. But most of the time, we do not have the data of our NICU, whether we have incidence of 5% or 10%. So you can start depending on the risk of suspicion.
Babies also.
Yes. Sir, ELBW.
In all ELBW?
The oral absorption is more than 90% in the cases of fluconazole. So it can be safely used once the patient is taking oral feed.
Yes, sir, exactly. Sir. Yeah. Thank you. Thank you, sir.
Thank you, Saroj boss, and thank you all the chairperson. I will request you all to come for the memento distribution. I will request Anil sir to please assist in the memento distribution. And moving on next, we have next I will call Dr. Rijwan Ahmad sir for the next topic, and for chairing that session we have Dr. B.B. Bose, Dr. Banke Bihari sir, Dr. Krishna Keshav Thakur, Dr. Binay Yadav, Dr. Manmohan Mishra sir. Dr. Rijwan Ahmad.
Good afternoon to everyone. I would like to give thanks to organizing committee for giving me the opportunity to present a very important topic, that is antibiotic stewardship through quality improvement approach.
So good afternoon all of you. I welcome Dr. Rijwan Ahmad sir, Professor of Pediatrics and ICU in charge Neonatology for this session, and we will really learn something from sir. Please proceed, sir.
Thank you for nice word. So antibiotic staff, I will try to complete it on time because it is after that it is the lunch time. So, okay.
there is a small announcement. We are going to announce the poster and paper presentation awards after this talk. Be here. We are going to announce after this talk. Thank you.
Now, I will discuss antibiotic consequences in NICU and challenges of antibiotic stewardship in NICU, which is we are usually facing, and strategies and intervention for antimicrobial stewardship program through QI intervention, and reviewing methods for monitoring the success of it. So why it is focus on NICU? Because in NICU there is up to 75% the antibiotic use is empirically, whether it is required or not, because it's also a challenge, because due to the immature baby and high risk newborn, we usually start it empirically, and excessive inappropriate or overuse of antibiotic leads to the development of antimicrobial resistance, multi-drug resistance, and late onset sepsis and invasive candidiasis. Besides this, we are disrupting the developing microbe of the newborn, which later develop to the allergy, asthma, and obesity. And besides that, it has a other burden on the economic sides, which increases the expenses also and death. And it has seen that culture negative sepsis had 8 times more antibiotic use than proven infections. And impacts on these in NICU is that every year 2 lakhs newborn died of sepsis, and burden most of the time it is very high in low to medium income groups countries. And it has seen that there is a rising resistant pathogens, and most of the time it has seen that more than 70% of cephalosporin resistance in the developing countries. And key pathogens in the where the outbreaks of the NICU sepsis is seen, or infections which is coming in positive in culture, the 3 to 4 organisms is the bulk of these infection, and it is E. coli, Klebsiella, and Acinetobacter. And in coming other antibiotics we routinely use. And 2 studies, Bangalore, and 5 studies, the importance of the high resistance of the initial antibiotics we use empirically, and found that there is a high resistance. So what is the these 3 studies, it also showed that we have told you that the 3 common organisms, Acinetobacter, Klebsiella, E. coli, most of the time it is found in the culture proven cases, and it becoming extended spectrum cephalosporin resistant and carbapenem resistance. And these studies has shown that in NICU, when we use empirically, whether culture proven or not culture positive, they have showed that more than 5 days use of empirical antibiotic leads to increased chances of NAC and death. And it has shown that any receipt of 3rd generation cephalosporin or carbapenem leads to invasive candidiasis. So, and these studies also show the burden of case fatality among the culture positive, methicillin resistant Staphylococcus aureus and Acinetobacter. These studies showed that there is increased mortality in these cases in comparison to the culture negative, methicillin sensitive cases. And these graphs also show the global death in these attributable to and associated with antimicrobial antibiotic resistance, which is published in Lancet. We showed that as I mentioned, that E. coli, Klebsiella, and Staphylococcus, these are the common bugs which is becoming positive in NICUs. And this is the global burden of the disease in the, mostly from graph it can be seen that it is more, burden is more in the African and developing countries in comparison to the developed countries. Now, what unique challenges we faces in NICU before starting the, that leads to the empirical use of the antibiotics. 2 fronts we faces challenges. One is the diagnostic and another one is the management point of view. Because newborn is, as it is premature, not develop the immune non-specific signs and symptoms which clearly simulates with other non-infectious causes of these manifestations. And other is high-risk patient, and difficulty to obtaining reliable cultures, and no combination of lab test which has sensitivity to reliably rule out the sepsis. And these reasons why empirical use of antibiotic is high. And from management point of view, because there is lack of evidence-based guidelines on the duration and choice of antimicrobial use in neonates. And most of the cases, it has been seen that empirical is used culture negative sepsis, there is 70 to 80% of all suspects, there is no consensus on the duration of the therapy. And besides these immature renal function where the dose and its manifestations are extrapolated from the adult studies. Then what comes to the solution of these? There is, these are the solutions which were prescribed, but the first one is 10 into 20 initiatives, which is planned for that in 2020, 10 new antibiotics will be discovered to combat these challenges, but it is failed, mostly due to financial reasons and other reasons. Then comes the reduces the cross-infection, that is infection control practices we usually do in our NICUs, preserve the efficacy of available microbials, that is antibiotic policy, and optimizing therapy, that is antibiotic stewardship. Infection control practices and antibiotic policy, that comes under the antibiotic stewardships. And what is antibiotic stewardship? It is a coordinated intervention designed to improve the outcome of the baby through the practicing 4D, that is dose, duration, drug, and the route of delivery of the drug, that is route of the administration, for the optimizing the treatment of the newborn and preventing the development of unnecessary collateral damage to the baby, besides the improving the outcomes, and curb the development of antimicrobial resistance. And NICU specific antibiotic stewardship, it focuses on the early onset of neonatal sepsis, late onset sepsis, and perioperative prophylaxis and culture negative cases. These 4 areas where we are looking to how to curb or decrease the antibiotic use. As Manoj sir had told that late onset sepsis developed, we should not only focus on the postnatal antibiotic establishment, we should also focus on antenatal antibiotic establishment, because in pregnancy, if we start antibiotic empirically, it also leads to development of late onset of neonatal sepsis after 1 week in neonates. So, implementing the antibiotic establishment, it also include antenatal antibiotic establishment also. How to implement antimicrobial stewardship program? So first we understand the pathogens profile, which is locally available, and antimicrobial use, and assess the available resources and decide priorities, areas, and act. This should be not, suppose we are in a very well developed NICU, and suppose another one is practicing in a low settings areas. So we have a different strategies to combat the antimicrobial preventing the antimicrobial resistance. So assess the available resources which is available there, how we can use these, and action and intervention for antimicrobial MS program, that is there is some basic intervention and some advanced interventions. Basic interventions that we usually follow in our NICU, that is hand washing, sending the blood culture before starting the antibiotics, and timeout plan before cultures comes negative, we stop the antibiotics. And besides these, the 4 things that is the main cornerstone of the success of the antimicrobial stewardship is that we should audit the data of the auditing and feedback, which is lacking in most of these NICUs. That is what we are practicing. If you not going to give the feedback and auditing the data, it is not going to be success. So it's a cyclical things which we should focus on that. And intervention to improve antibiotic prescription, that is persuasive actions and restrictive actions. For persuasive action, it is usually for the changing the mindset of the physicians by educating and training and prospective audit and feedbacks. It is not that you stop from prescribing antibiotic, but you are pursuing the physician or healthcare workers when and how to use the available antibiotics. And restrictive action, formulation of facility-specific antibiotic policy, pre-authorization and formality restriction, and antibiotics timeout. But restrictive actions usually it is used where there is a use of, suppose we require the 2 broad spectrum antibiotic. So here comes the restrictive action, follows persuasive action and restrictive action both. And it is a mixed strategies which is leading to the improvement of the antibiotic prescriptions. Now comes to the microbiology based in selective reporting of antimicrobial substitute test result and using a stratified image. Selective reporting means if the antibiotic is suppose a gram positive bacteria is grown in the blood culture, so we should only give the sensitivity only to the first line antibiotics, not the broad spectrum. Keep it in that it should be narrow spectrum should be used, not the broad spectrum. And pharmacological based intervention switch from intravenous to oral antibiotic, but it is mostly for the pediatric patient, not for the NICU. We usually complete because newborn is a high risk babies, we should usually keep that we decrease the duration of parenteral antibiotic, but usually not switch to the oral antibiotics. Time sensitive automatic stop orders, dose adjustment and dose optimization. And diagnostic intervention, that is biomarkers and rapid culture, blood culture methods. Biomarkers like procalcitonin or CRP, it is usually used, but it should not be routinely done. It should be only for the low risk baby to rule out the sepsis, because in high risk baby it is not used for ruling out this complete sepsis. And rapid blood culture, there is now bacterial culture is available, which usually it is very useful because gram negative bacteria grow within 26 hours and gram positive usually takes more or less 48 hours. After that it comes positive, we usually think it is a contaminant. So rapid blood culture is very important in the implementation of antimicrobial EM. Implementation steps it should be a smart aim, that is it is a specific, measurable and achievable and relevant and time bound. And basically the topic is quality improvement in healthcare. What is quality improvement? It is data driven. We collect the data, analyze and then implement it. So it is data driven approach to enhance process outcome and efficiencies. Key model is PDCA, Lean and Sigma. We usually in neonatology use the plan, do, study and act strategy. And key strategy for NICU antibiotic stewards via quality improvement. We usually follow evidence-based guidelines, antibiotic stop orders and sepsis calculator, daily stewardship round. Whether in daily stewardship round, in daily round, we usually look for whether it is still required the antibiotic, whether the baby is improving, we can downgrade the antibiotics. So these can enhance our practices to combat the antibiotic resistance. PDSA cycle, QI collaborations, root cause analysis and educations. So a few minutes about the PDSA cycle. What is PDSA cycle? Is the plan, do, study and act analysis strategy. This is a very simple strategy and it is very helpful in improving the outcome in NICU for various, not only for antibiotic resistance. In other thing, we use the PDSA cycle like improvement in kangaroo mother care or temperature hypothermia prevention. We use besides these. What is plan? Plan is identify problems, set aims and predict outcome and plan data collection. Do the test changes on a small scale, documents and issue. And study, analyze data, compare to prediction and summarize learning. Act, adopt, abandon or scale up if successful. In our NICU, we did a quality improvement on hand hygiene practices. We found that a simple improvement of hand hygiene leads to the improvement by the PDSA cycle. We can improve the practices of hand hygiene. Initially, there is a less hand hygiene practices, but upon the analysis or development of applying the PDSA cycle, there is increase in the hand hygiene practices. This is the PDSA cycle and fishbone analysis. There is a shortage of time, I will skip that one. And there is various guidelines which given by the CDC, American Academy of Pediatrics recommendations. All these recommendations about the neonatal stewardship, which focuses on the prevention of antibiotic resistance and development and its complications. And ICMR has a antibiogram driven policies focus on MDR, multi-drug resistant organism, and hand hygiene. So before advanced studies are biomarkers, as we have discussed, rapid diagnostic, we developed the networks. In India, we can collaborate with there is many ICMR collaborations for shared antibiograms, which give the idea about in India about what is the prevalent of these resistant organisms. Electronic and clinical decision support system, alert for inappropriate orders, guidelines-based order sets, and automatic timeouts. Telehealth and remote stewardships. In a corona period, we use this telehealth. We give the information or advice about the low resource areas about the antibiotic stewards strategies. And these are the indicators for monitoring the impact of ASP in neonates. These are the structural indicators and process indicators and outcome indicators. Outcome indicators depend upon how robust your structural and process indicators. And these are the indicators which we usually use for outcome to monitor the outcome indicators. And outcome indicators related to antimicrobial use, that is days of treatment per 1,000 patient days. And related to patient is in-hospital mortality rate, readmission rate within 13 days, surgical site infection rate, proportion of patient with clinical failure, treatment-related toxicity and cost, and microbial outcome, obviously multi-drug resistant organism growth rate. These are the case studies and example where using the quality improvement strategy to keep the antibiotic uses, decreasing the antibiotic uses, and improving the outcomes. And these are the few studies in India, rural, central India, northern India, secondary hospital, and all these studies which using the various QI strategies to help or improve the antibiotic use. And challenges and solution we will discuss about we must all be antimicrobial stewards. That is microbial guide therapy wherever possible. Indication should be evidence-based. Narrowest spectrum should be used. Dose appropriate to the site and type of infection. Minimize duration of therapy. Ensure monotherapy in most cases. So, because it is a very large topic, it cannot be taken in the 15 minutes. So I keep it short. That is key take-home message is that antibiotic stewardship is a critical quality issue in an ICU with significant impact on patient outcome and antimicrobial resistance. A structured QI initiative that is mostly PDSA cycle used in NICU is a safe and effective way to reduce inappropriate antibiotic use. Successful program require a multidisciplinary team, evidence-based protocol, continuous education, and robust tracking and feedback. This is very important. Robust tracking and feedback of the data and giving it to the treating physicians. By focusing on timely de-escalation and restricted use of broad-spectrum agent, NICUs can significantly decrease antibiotic exposure without compromising patient safety. And this is the theme of the antibiotic stewardship, that we should decrease the antibiotic use without compromising the outcome. That is the take-home messages. Thank you.
Thank you, Dr. Rizwan, for your nice deliberation. You have explained all the things very nicely. I think so. Most important factor in antibiotic resistance is inadvertent use of antibiotic, inappropriate dosing and duration, particularly centers located in periphery. Generally used to see the prescription, they are prescribing 3 or more IV antibiotic without doing blood culture. We focus on to stop that. Thank you.
Thank you. Thank you.
Any questions?
Thank you, Speaker Dr. Rizwan and all the chairperson. Please come for the memento distribution. I will ask Bhupendra sir to please give the memento to the chairperson and all speakers. chairpersons and all speakers. And moving on next, we have next panel discussion. I will ask the moderator, Dr. Bhavesh, to please come on the dais. Chalta rahega. And the panelist, Dr. Rakesh Kumar, PICU in charge PMCH. Dr. Amit Kumar, PICU in charge PMCH. Dr. Amit Kumar, IGMS. Dr. Kamod Jha, Dr. Ronak, and Dr. Richi Dalai. Dr. Ronak and Dr. Richi Dalai. And for chairing that session, I will request TP Golwara sir, and Dr. Kumar Sambhu sir, and Dr. Kumar Sambhu Katihar. Sarai. Hi,
Dr. Bhavesh Kant Chaudhary, Associate Professor and Head of Department of Neonatology, PMC, IMS, Patna. Dr. DNB Neonatology, MD Pediatrics, area of nutrition, non-invasive ventilation, State Academy according to 2124. And Division NNF policy, good conduct. Thanks.
Thank you, sir. So, Namaskar. Today we are going to discuss the topic extrauterine. So, today we are going to discuss the topic extrauterine growth chart. We all heard about the intrauterine growth and extrauterine growth retardation. So inside utero, if growth retardation happens, then it's called intrauterine growth retardation, and then outside after the birth, it's called extrauterine growth retardation. And as a neonatologist, we every day face this problem that EUGR, because in every NICU there is a major concern, and if we see the data that 40 to 70% baby has suffering from this one in NICU, and majority of the baby has this deficiency in the calories and protein after birth, and due to this one only this happen. So if they see the chart, when we compare to the EUGR group with the non-EUGR group, there is a major deficiency of the cumulative energy deficiency as well as the amino acid deficiency. So can we give this excess calorie and protein to overcome the crisis? So when deficiency of the nutrition is there in the perinatal period, and then the rapid weight gain and accelerated catch-up growth, overzealous actually, then it induces the important alternation in adipose tissue deposition, which increase the risk of adulthood disease, metabolic syndrome. So we should not do this one, that overzealous feeding to the EUGR baby. So on this today discussion, we are going to discuss the burden, definition, risk factor, prevention and treatment, as well as the outcome and long-term outcome. So with a start, a baby who is delivered at 29 week, and baby had 800 gram at the time of birth, which is came between the 3 to 10 percentile. We have started on the CPAP and surfactant for the RDS. Now baby become 36 week, that is 7 week old. Still requires some sort of respiration, and baby become weight is something around 1500. So if you see the 800 to 1500, it's looking good that baby gain so much. But if we put the baby chart, then seeing that the baby is consistent less than 10 centile. So something is wrong, right? Sir, Dr. Rakesh sir, what is the EUGR definition? What is the heterogeneity in this one? And consensus definition.
Thank you, Babes. Actually, EUGR is a type of postnatal growth failure in preterm infants. And as we all know that, there are various definitions and various factors have been taken into consideration to define EUGR in various studies. There are almost 355 preterm infant growth studies across the globe, and of those 355 studies, 67 described rates of EUGR. Of these, almost 60% use less than 10 percentile cutoff as a definition for EUGR. 10% used less than third percentile cutoff, this is a stricter one, and another 20% used Z-score criteria for defining EUGR. And some of them don't describe the methods they adopted to define this thing. So there is lot of heterogeneity as far as definition of EUGR is concerned. Although there are mainly two definitions we can have. One is cross-sectional definition, where weight less than 10 percentile is considered as a cutoff to define this thing. And another can be a longitudinal definition, where we can define EUGR as loss of weight for age more than one standard deviation or one Z-score from birth to 36 week or corrected term. So this can be one definition. Although there are number of definitions in use, so there is a lot of heterogeneity, and because of this we cannot use one study from another study. We can't compare it. We can't have more researches in future which can have a similar background. And again, to have more prediction for neurodevelopment outcome and in better way, in a precise way, we should have a consensus definition. And for consensus definition, we can have a longitudinal definition where we can define this thing, EUGR, as weight for age, Z-score, less than 1 score from birth to 36 week of gestation or corrected term for PMA, that is post-menstrual age, and while using standard prenatal growth charts like Intergrowth 21 or Fenton chart. So we should have a consensus definition to have a better correlation with the neurodevelopmental outcome, and also to have more comparable studies in future study and assist future studies as well.
So there is heterogeneity, but we have to come to a consensus where we all have to agree. Thank you, sir. So now, Dr. Amit sir, what is the burden of EUGR and what is the pathogenesis behind this one?
Thank you for Bhavesh and organizing team for this opportunity. So the question is EUGR rare, common? Actually, it is more than common. It's universal. So almost all places EUGR incidence or prevalence has been noted, and actually it can range between 40 to 70%. And the different criteria, as I told, it can be weight, it can be height, it can be head circumference, different timings like at discharge, at different gestation. So actually, many studies are shown here. It ranges from 40 to 70%. So it is actually very common. And in India, again, we do expect that EUGR would be there, and many studies have shown that it is again ranging between same 64 to 70%. But very important in this, in the AIMS New Delhi data, you can see that we can even substitute preterm formula for HMF. And actually, the incidence of EUGR in preterm formula group, in which human milk was fortified with preterm formula, the EUGR incidence was actually like slightly lesser, 73%. So yes, in India it's also very common. Next, please. Again, few studies, they are showing that at the time of discharge, actually the Z scores fall a lot. They definitely fall below the birth centiles. But by 1 year, it usually regains. The weight is usually regained. And actually it has implication in pathogenesis and treatment also, which we'll see further. And it's a common slide that as the gestation increases, the incidence of EUGR actually decreases. So now a very important slide, what about pathogenesis? We know the question is very simple, that the weight is not increasing as much as we want it to be. So few things which are very obvious, that infection, hemorrhage anywhere in the gut, in the brain, ischemia, gut ischemia, etc. are directly linked, previous slide please, previous slide. Yeah, they are directly linked to EUGR. In the toxic stress, I want to focus on pain. How many of us actually think about pain? The IV cannulation and sampling, and that pain actually causes EUGR, can cause. Coming to environment, NICU environment, so much of sound, so much of beeps and everything. We should even try to prevent that. And furthermore, nutrition is very important. Next. So this is just like compiling all the things which I have said. Only one thing which I want to focus is the last box, that when nutrition is not good, the IGF-1 is also decreased, because when nutrition is not good, body is not trying to grow. Body's focus is on something different, like brain and other things. So again, there's decreased weight gain leading to EUGR.
So the EUGR burden is really challenging, not only the India but also the abroad. As sir suggests, it is something around 40 to 60 and somewhere it's 70 also. And lesser the gestation age, more the incidence of EUGR will be happening. Thank you, sir. So, Dr. Kamud, what is the risk factor affecting this extrauterine growth, sir?
There are multiple factors that can affect the extrauterine growth. That may be antenatal risk factors and postnatal risk factors. Antenatally, that can be intrauterine growth retardation, and postnatally can be associated with some medical problem like respiratory issues and NEC, postnatal use of some medicines like steroids and diuretics. Associated with the feeding issues, both qualitative and quantitative feeding. Like if quantity of the feed is less or nutrition is less, and quality less protein and calorie, so that can lead to the extrauterine growth retardation. Prematurity is one of the significant risk for the extrauterine growth factor, because prematurity is associated with multiple medical problems and feeding issues, prolonged hospital stay. These all can accumulate and cause to the extrauterine growth restrictions. Some respiratory problems like RDS, PPD, prolonged ventilations, sepsis and other infections can cause extrauterine growth retardation.
Sepsis is bacteremia without focus, pneumonia, meningitis or omphalitis. GBS sepsis, early onset. The answer is bacteremia without focus. Most of the time it will present as bacteremia without focus. So Hare Krishna is leading. Coming to the fifth question, not a risk factor of late onset neonatal sepsis is birth weight less than 750, presence of central venous catheter, delayed enteral feeding, prolonged CPAP support. So the correct answer is prolonged CPAP support. Prolonged CPAP support is not a risk factor for LONS. And Arnab is now leading with 1634 marks. The sixth question of series, MChat is a screening tool for suspected ADHD, dyslexia, autism spectrum disorder or developmental delay. MChat score. And the correct answer is autism spectrum disorder. So Meha has the fastest answer. The seventh question is greatest sensitivity for diagnosing cerebral palsy before 5 months is for Heinz score, MRI, Prechtel's general movement and abnormal primitive reflexes. Highest sensitivity. And the answer is Prechtel's general motor movements. So again Arnab has come up. Eighth question, risk of hearing loss among asymptomatic neonates with congenital rubella infection is 10 to 15, 15 to 35, 40 to 50 or more than 90%. Asymptomatic neonates with congenital rubella syndrome. And the answer is 10 to 15%. Coming to the next question, the typical cutoff of maternal serum alpha fetoprotein screening done at 15 to 21 months is 1.29 to 1.5, 1.5 to 2, 2 to 2.5 or 2.5 to 3. Correct answer is 2 to 2.5 MOM and fastest answer was from Meha. Degree of hearing loss in a neonate with hearing threshold 40 decibel in right ear and 60 decibel in left ear is so mild. So we grade the hearing screening as per the better ear, not the worse ear. Okay? So Meha is again not essential to define cerebral palsy is abnormal muscle tone, seizures, muscle weakness or involuntary movements. So the correct answer is seizures. Seizures need not be there in every CP child. And Meha is leading. Coming to the 12th question, SMOF lipid contains how much soybean oil, MCT oil, olive oil and fish oil percentage wise? So the correct answer is first one, 30, 30, 25 and 15. This is the correct answer. And again Miha is leading. Primary esophageal peristalsis comes into existence by what gestational age? Primary peristalsis of esophagus. The correct answer is 33 weeks. Before 33 weeks, the primary esophageal peristalsis is not there. So no one has given correct answer. 14th question, goal milk supply in lactating mothers by day 14 or 7, 21, whatever is, which one is the correct answer? So the correct answer is more than 500 ml per day by day 14. And Arnab has now come up with the right answer. So the 15th question is, ratio of intracellular fluid and extracellular fluid reaches the adult value by what age? 1, 2, 3, 5. And the correct answer is 1 year. So Dr. Satvik. Which of the following presents with hypokalemia and hypertension? Out of all these disorders, hypokalemia and hypertension. So the correct answer is both 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency. They both present with hypertension and hypokalemia. Satvik, please introduce yourself. I would like to reiterate that Satvik being a
Good morning everyone. My name is Dr. Satvik Saurav. I am currently pursuing NBAMS diploma course from pediatrics in Sadar Hospital, Samastipur. First year.
Very good.
First year JRC.
Congrats.
I Arnav M. All the first, second, third on the dais, and all the participants. Hare Krishna.
Those who have participated, please come on the dais. Exactly.
Neha, Mukesh, Rashmi. आशुतोष आ जाओ भाई, तुम भी
आ जाओ आशुतोष।
आशुतोष भी कभी पीजी था, तुम भी पीजी हो ना, तो आ जाओ भाई, कैसा
सर ये है ना उन्होंने पीजी पा लिया और ये भी पीजी में है। और अब समय आ गया है अगले
I announce that this is not the only for this year. Every year, 1 lakh rupees amongst the PG student award in Bihar Neocon. This award will be given as a Dr. Shravan Kumar Excellence Award, and be prepared. And I am happy that you have participated, and let all the PG students to know that you do good works in neonatology, and because I have initiated neonatology in Bihar, I am very much eager that it should grow fast, and I should say that you people, that our young neonatologists will do wonder for Bihar. Thank you.
मैं एनएनएफ बिहार की ओर से आयोजन समिति को तहे दिल से शुक्रिया अदा करता हूं। हमारे जो जायसवाल जी हैं वो इन एब्सेंसिया मैं उनको कहता हूं, लेकिन सबसे पहले मैं नाम लेना चाहूँगा चंदन कुमार का। संभवतः चंदन के बिना कल्पना नहीं कर सकता था मैं कि इतना सक्सेसफुल होता, तो मैं आपको हृदय से धन्यवाद करता हूं। फिर हमारे आयोजन अध्यक्ष जो दोनों थे, जायसवाल जी तो है नहीं, लेकिन विनोद कुमार सिंह ने इतने मेहनत से और इस तरह की परिस्थितियों में भी इन्होंने इसको अच्छी तरह मुकाम तक पहुंचाया। मैं उनके लिए हृदय से आभारी हूं। मेरे सचिव जो हैं अभी तत्काल किसी इमरजेंसी कारण उपलब्ध नहीं है, तो उनकी ओर से मैं बाकी लोगों का भी धन्यवाद कर देता हूं। आयोजन सचिव डॉक्टर श्रवण कुमार जो मेरे सीनियर थे, और मैं इन्हें उस समय नहीं पहचान पाया कि ये फादर हो जाएंगे और हम लोग चाइल्ड ही रह जाएंगे। तो और भवेश खान चौधरी जिन्होंने बहुत ही मेहनत से सारे साइंटिफिक प्रोग्राम को अरेंज किया, इनकी पूरी टीम, इन्होंने एम्स के एक आदमी को खटाया। हमारे रिसेप्शन कमेटी के जो दोनों निगम प्रकाश जी थे जो कि अभी थक के चले गए हैं, 2 बुजुर्गों का नाम लेना बहुत ज़रूरी है, टीपी गोलवाला सर का और डॉक्टर एस ए कृष्णा का। इन लोगों ने जिस तरह से हौसला अफजाई की अपने सारे पीजी लोगों का, जिनके बिना कुछ भी संभव नहीं था, एनएनएफ के एक मेंबर का, और यहाँ पर आयोजन के लिए जिन्होंने, जैसे डॉक्टर रश्मि अग्रवाल ने संपादन किया और उन्होंने मंच संचालन कल किया। एनएनएफ की पूरी सेंट्रल टीम जो पूरे दिल और सशरीर यहाँ उपस्थिति दिखा के गई है, और कुछ वैसे लोग जो इनविजिबल थे जिन्होंने हमारे इस पूरे कार्यक्रम को आप तक पहुँचाने में मदद की। तो जो हमारा प्रोजेक्शन देख रहे थे, साउंड देख रहे थे, कैमरा देख रहे थे, सबसे बड़ा धन्यवाद मेडवे को। वैसे फार्मास्यूटिकल्स कंपनी के सहयोग के बिना नहीं होता। तो अविनाश और उनकी टीम अभी संभवतः हॉल में नहीं मौजूद है, अगर मेरी आवाज़ उन तक पहुंच गई है तो मैं मेडवे का सबसे ज़्यादा धन्यवाद करता हूं। प्रेस और मीडिया, दूरदर्शन, जिन्होंने हमारे कार्यक्रम को इस चुनाव के मौसम में भी बड़ी अच्छी कवरेज दी है, मैं उनका भी धन्यवाद करता हूं। होटल मौर्या के एक कर्मचारी का, जिन्होंने हमें इतना स्वादिष्ट खाना खिलाया, हमें इतनी ज़्यादा सुविधाएं दी, मैं उन सब का धन्यवाद ज्ञापन करता हूं। और मैं उम्मीद करता हूं कि एनएनएफ के मेंबरशिप को आप बढ़ाने में सब मदद करेंगे। जितने पीजी छात्र हैं, मैं उनसे, अविनाश आ गए हैं, मैंने इन एब्सेंसिया आप सबों को थैंक्स किया था। अभिषेक आपके जो बॉस हैं, जो लगातार बख्शी साहब जो हम लोग को बकस नहीं पाते हैं, तो और बाकी सारे फार्मास्यूटिकल्स का भी जिन्होंने जितना उनका श्रद्धा रही सहयोग किया, उसके लिए मैं सिर्फ एक ही आग्रह करूंगा सभी पीजी से, प्लीज़ आप एनएनएफ की मुख्य धारा में आएँ। मैं सभी जो हमारे फैकल्टीज़ हैं, जैसे भवेश, एम्स के भूपेंद्र जी, एनएमसीएच में मेरे बांके बिहारी, बीपी जायसवाल जी, सबसे आग्रह करूंगा कि कृपया, क्योंकि नवजात शिशुओं की देखभाल बहुत ज़रूरी है और बिना एनएनएफ के मेंबर बने आप मेन स्ट्रीम में नहीं आते हैं। जैसे पीडियाट्रिशियन बनने के लिए आईएपी के मेंबरशिप की ज़रूरत है, तो आप सबों से आग्रह है। और मैंने अभी जो कॉन्फ्रेंस हमारा हो रहा है, इसके हम लोग पहले एक मुहिम चलाए हुए हैं 7,500 रुपये में बल्क मेंबरशिप का, 11,500 नहीं 7,500। तो अगर आप सारे NMCH के सारे एम्स के अगर एक साथ बनते हैं एक इंस्टीट्यूशन से, तो आपकी फीस घटाकर 7,500 कर दी जाएगी। ये गोल्डन अपॉर्चुनिटी है। और ग्रेजुअली हम डिजिटली, आपने देखा हमारे जो CPG है NNF का, आप ही लोग के बलबूते पर आप अगर जो रिसर्च करेंगे लाएंगे तो हम भारतीय परिप्रेक्ष्य में अपने डाटा के अनुसार अपना ट्रीटमेंट कर सकेंगे। अमेरिकन के डाटा हमें काम नहीं आते हैं, बरगलाते हैं। हमारे अपने जो NICU है उसका जो माइक्रोबायोमा है वो हमारा काम आता है। तो मैं सभी से आग्रह करूँगा, इस कॉन्फ्रेंस के बाद बिहार में जो लोग भी छूटे हुए पेडिटिशियन हैं, कृपया NNF के मेंबर ज़रूर बन जाएं। और इसके लिए अभी यहाँ पर लीडर के रूप में मैं तो भवेश कांत चौधरी को ही देख रहा हूँ, क्योंकि अकेला एम्स है जहाँ पर पूरी तरह से रिकॉग्नाइज्ड वे में नवजात शिशु का एक विभाग है और उसके विभाग अध्यक्ष और DM नेटोलॉजी वाले लोग हैं। और यहाँ के सारे DM नेटोलॉजी वालों से आग्रह करूँगा, कृपया आप NNF को अहमियत दें। सबों का बहुत बहुत धन्यवाद। मुझे गर्व है कि मेरे रिजीम में एक इस जोन का कॉन्फ्रेंस हो सका। और मेरे सारे सीनियर, मेरे गुरु भवेश जी से लेके मेरे सीनियर श्रवण कुमार जी, मैं सबका धन्यवाद करता हूँ। सबका धन्यवाद धन्यवाद धन्यवाद। चंदन का सबसे ज़्यादा।
श्रवण सर 2 शब्द बोलना चाहेंगे।
ऑर्गेनाइजिंग सेक्रेटरी के रूप में मैं अब जैसे मैं बोलता हूँ कि यह एक आयोजन नहीं है, जैसे कि शादी का माहौल था और इसमें जैसे विदाई हो रही है, विदाई में जैसे कि पिता को दुख के साथ जैसे खाली हो गया, तो जैसे बेटी जाती है तो कैसे खाली लगता है, लेकिन खुशी भी होती है कि मैंने बहुत अच्छा काम किया। और यह मेरे लिए बहुत ही माने अच्छा लग रहा है कि मेरे जितने भी ऑर्गेनाइजिंग टीम थे, ये प्रेसिडेंट मेरे जूनियर है, लेकिन ये बहुत कर्मठ है। कर्मठ इतने हैं,
सही है, मैं स्वीकार करता हूं।
हाँ। और भावेश कांत को मैं अभी तुरंत जो इन्होंने बोला वही बात मैंने बोला कि देखो तुम्हें कोई चिंता की ज़रूरत नहीं है, लेकिन अब NNF को, नियोनेटोलॉजी को मैं तुम्हारे हाथ में, मैं शुरू किया जरूर बिहार में, जैसे पहला NICU मैंने शुरू किया, लेकिन अब नए बच्चों को हाथ में देना है। अगर वो नहीं करेंगे तो पिता कैसे खुश होगा। तो और आज मतलब कि सभी कोई साथ दिया है, लेकिन मैं एक टोकन ऑफ एप्रिसिएशन मीर बख्शी को और दोनों को, आप आई और अविनाश जी को मैं टोकन ऑफ,
मीर बख्शी और अविनाश जी दोनों जी स्टेज पे आए। सलोनी
छोड़ के
हाँ
हम लोगों के पास आए। नहीं तो पाकिस्तान को खत्म करने के लिए दिमाग में रख के चले थे।
और
पाकिस्तान का
दोनों
तो बचा हुआ
है, किसी एक आदमी के लिए नहीं है, पूरे मेडवेट टीम के लिए है। मतलब ए बिग राउंड ऑफ अप्लॉज फॉर मेडवेट टीम। सब लोगों ने बहुत मेहनत की है। तो फ्रॉम द ऑर्गेनाइजिंग टीम थैंक यू टू द मेडवेट टीम। हाँ सब लोग पीछे, बहुत लड़के में
एक कोई बढ़िया सा फोटो ले लीजिए नजदीक से।
ये हमारा सहयोग आगे भी जारी रहे।
हाँ।
और इसके लिए हम अपने फ्रेटर्निटी के लोगों से भी आग्रह करेंगे कि सपोर्ट मेडवेट।
So nice of you, sir.
Thank you. From beginning to end, आज मतलब सब कोई चला गया, लेकिन
रात को भी यही था सर। एंड हम लोग चाहेंगे कि ये मोमेंटो आपके ऑफिस, पटना ऑफिस में रहे एज ए, हाँ बॉम्बे ऑफिस जाए तो और भी बढ़िया टोकन ऑफ रिस्पेक्ट हमारी तरफ से। हाँ कि आप लोगों ने बढ़िया, हाँ बिल्कुल बिल्कुल। हाँ फार्मा कंपनी की चीज़ें हमारे घरों में होती है, हम चाहते हैं हमारी चीज़ें फार्मा कंपनी के घर में हो। कोई ठीक है। एंड कुछ और लोग हैं सर जो मौर्या वाले लोग। घोष साहब कहाँ हैं? हाँ हाँ
आशीष को बुला ले।
आशीष घोष। हाँ हाँ हमें हाँ लाओ एक ले आओ। हाँ दिस इज फॉर मौर्या। हाँ ये मौर्या में रहना चाहिए हमारी तरफ से। हाँ घोष साहब और लोग को बुलाना था, बुला लीजिए। आ जाओ प्रकाश, जितने भी लोग हैं जो मेरे कहने पे दौड़ते रहे। हाँ ठीक है। हाँ सर दोनों दो और लोगों के बहुत योगदान रहा है, हमारे ऑडियो विजुअल्स वाले हरी जी एंड टीम। हाँ हाँ प्रदीप सर, आप यकीन नहीं कीजिएगा कि कॉन्फ्रेंस के एक दिन पहले से प्रदीप और हरी जी की टीम हम लोग कॉन्टेक्ट, सारा पावर पॉइंट ट्रांसफर हो रहा था इनके मोबाइल में। और ये लड़का बहुत मतलब दोनों लोग बहुत ही एक था ना, एक मोमेंटो था ना छोटा वाला, दूसरा चले सर। एंड लास्ट बट नॉट द लिस्ट एसएसबी की टीम, जो मुझे दिखे थे पोदार साहब लेकिन लगता है नहीं। हाँ तो उनके छोटे जो इंचार्ज हैं लाओ एक मोमेंटो दो। हाँ कोई बात नहीं, मालूम है हमको, खत्म ही तो कर रहा है। ये लड़का भी रात को सर आप 2 बजे खोजिए, ये हाँ हाँ वही हाँ इन लोग को ही बुलाते हैं। हाँ
आप अपना फोटोग्राफी का सामान लेके सामने आ जाए, हमारी टीम खींच देगी फोटो। आ जाइए
आइए।
आइए
नहीं सर
आ जाइए। अरे वहाँ अभी आइए।
नहीं अभी
आ जाइए ना,
एक निकाल दो। हाँ कोई बात नहीं, लाओ। हाँ ठीक है एक बस एक चलो ठीक है लाओ ना, ऐसे लाओ, ऐसे तो पूरा मेहनत करेगी। तुम भी तो टीम वो दादी की टीम में थी, तुम लोग क्यों नहीं आई? नहीं ऐसे लो सर। हाँ तो थैंक्स टू द ऑल द फोटोग्राफर टीम, बढ़िया फोटो हम लोग को भेजिए, जो भी हमारे फोटोज हैं कि हम लोग ग्रुप में डाल पाए सर को।
प्रोजेक्शन के लिए ना आपने जो किया होगा ना रिकॉर्डिंग, वो
अरे हमको हरी जी हमको ही भेज दीजिए, जो भी है क्या है बोलिए। हाँ हमको पेन ड्राइव में दे दीजिए। अरे हम सब लोग एक ही है भाई। तो हम फिर पेन ड्राइव भिजवा देंगे। हाँ डिलीट मत करना। हाँ नहीं सर, थैंक यू टू बाकी बिहारी सर, सुबह से सर साथ निभाए हैं। हाँ एंड थैंक यू टू सलोनी एंड सुती सुबह, थैंक यू इन दोनों को। सामने आओ, ऊपर आ जाओ। हाँ अरे नहीं सर गलती से नहीं है, गलती से सर इतनी गलती मुझे अलाउड है। आ जाओ स्टेज पे, खाली आ जाओ, फोटो ले जाए। आइए सर दोनों आओ, फोटो हाँ आओ।
एक तो लाओ,
मोमेंटो लाओ दोनों। हाँ नहीं लाओ हम एक और देंगे तुम लोग को, टेंशन मत लो। है एक दोनों ले लाई, तुम लोग एक और देंगे हम लोग, टेंशन मत लो, तब तक घर पे रखना, ठीक है ना। बहुत बढ़िया, मतलब रियली हाँ बहुत बढ़िया। हाँ एकदम बिल्कुल सर आइए. So thank you everyone. सब लोगों को थैंक यू. जितने पार्टिसिपेंट, गलती सही माफ. मिलते हैं अगले साल. चलो.